I've logged on to vMix with a new number, but I can just see the intro. Is that correct?
That is correct.
Okay. And are you able to check that my green screen looks okay? Because it's not quite covering the corners. I wonder if I need to reposition myself.
No worries.
Okay. I need to sit lower.
They talk.
Yeah, can you hear me? Oh, that's better. I'm sitting on Zoom. I'm on the vMix. Yeah, great. I can only see. Okay, cool. Okay, cool.
De audio moet ik ook nog verbinden, toch?
De vMix.
Ja, alleen alles dat wel natuurlijk. Doe ik dat? Spiegelbeeld, want het is wel hier. Dat is weg. Ga je de camera toe, ja? De video. Dan zeg je video settings. Dan zet je nieuwe, nee, dat wil ik niet. Ja? Goed, dat doe ik. Video settings. Nieuwe mijn video. Nu is het goed. Nu is het fout. Nu is het goed. Nu zet ik hem erin. Ik kan niet veel uit voor ons. Ik moet even kijken hoe die hier komt. Hier goed. De audio. Hear me? Emma? Where's your volume? Let me check.
Okay.
Okay.
Yeah, I can hear. Emma, can you share the YouTube link? I do get my echo back from you, so I think you have your speaker on.
That's fine. Let me switch that off.
Yeah,
no, I am off. No, I'm off. It's not.
But
so I've got the Zoom off and I've got the vMix on.
yeah, I think I get the sound back from vMix. I think Zoom. But anyway, it's not in British at the moment. Can you please share the URL of the YouTube channel on Twitter or something?
Yeah, I'll do that now. Fantastic.
Okay, fantastic. Because we are broadcasting. Check if you can see the broadcast now. And then it should work.
Wilco, can you hear me? Wilco, can you hear me?
Okay, I'm muted. But I don't think I need it.
Wilco, can you hear me?
I don't.
Hi, I can't get through on vMix call. I'm using the number that we were given previously.
I will give you a call by phone. Please mute.
Okay.
Ik ben even bezig te lukken. Hoe laat? Als dat moet dan, maar je hebt nog even, nou doe maar dan. Ja.
Heb je die pinpas nu bij je?
Waarom?
Moet getekend worden.
Even, ja.
Oké.
Jij rijdt er toch? Hello Thibaut, I can see you. Hello, very good.
Good morning, Emma.
Good morning.
Well, we can see.
I'm not sure
John.
which screen to look at.
Well, look at where you're looking at now.
Yeah,
the best one.
that's right. That's the Vivek screen, isn't it? So that's all good.
Yeah, that's the best. Yeah, your hair is black on the white color. It's good, very good. No, that's very good. So, John, good morning.
Good morning.
Hi. You'd be surprised. It's always more technical issues than anything. But you were viewing before. Let me put the music a little bit down. Oh, just a little bit. And it says that we should start now, but I need another 5 minutes.
That's fine. Maybe if we do an introduction in 5 minutes, that'll be fine, I think.
But I get a feedback back, and let me check for the sound because that's annoying. John, can you talk for a moment?
Testing 1, 2,
Emma,
3.
I'm getting John back on your microphone.
Okay. So do I need to mute my microphone? Here we go.
No, not really, because it's nice if you can talk. But I think this, well, maybe yes, but I think the sound is coming back from the webinar.
I'm muted for the webinar.
Yes, and that's why you sounded good. And I think, of course, the webinar is our main source of contact. Everybody else, I can see. Look, just to tell you what I'm telling you, I'm getting a message from Bangladesh, I think. Let me check if it works. It should work, I hope. Look, hi everyone, morning.
Yes, good morning, Bangladesh. Great to hear that you're online.
Yeah, it's pretty cool, isn't it? Yeah, it's nice.
So that's from me.
Yeah, from Hassan, we all know. Good, Emma, I need to put you a little bit more down in a positive way. Oh, maybe not. Maybe.
I don't want to look bigger than John.
Well,
You do at the moment, so it's okay. You obviously are far more important than me nowadays, Emma.
Sadly not.
Okay.
Yes, I just had the early morning crisis of the fact that I'm sure that shirt wasn't that snug last year.
Yeah.
And I seem to have developed a Donald Trump on the top here.
Yes.
So
Well, tell me something new, John. So anyway, so that is good. Give me another 5 more minutes. Let me check.
Okay.
I can show you what's happening.
Well, I think if we type on the chat that it'll be another 5 to 7 minutes.
Yeah.
I'll do that. I'll do that.
Okay. Well, I mean, start with the review. I see Hanover's close to ready. I see Béziers. I see Kuopio. I see Napoli. So I think it's going to be Mayhem will start shortly, which means.
Well, we'll do 2 minutes. We'll do 2 minutes before the introduction.
Yeah. Okay. So I really, John, because once it starts rolling, I can't do anything anymore. I really need to. I'd like to invite everybody. Look. I think this needs to go out. I'm sorry it's in front of your face, Emma, but I'll take it away quickly.
That's fine. I can see it.
No, I'll put it on John's face, or I can change. I see Hanover is showing the patient case already. In 5 minutes, to everybody listening, in 7 minutes we will start. And this is like a good Mediterranean habit that we start a little bit later than promised.
All right. Well, I've just said 2, so we'll make that another 3.
Well, John, you Brits.
We like to work by the clock, Wilco.
Okay, I need to.
That's fine.
Yeah. Anyway, give me 1 second. I hope everybody recognizes it. That as soon as you have kids, they want the card to pay for fuel. It's incredible. Okay, hold on. I'm broadcasting. Hold on. So okay, John, and let me check if I can get the right image. I prefer you back on the. I can't find you anymore. It's so complicated. Life is too complicated. Let me check. Okay. I'll put you. I need to make titles, surgical titles as well. Okay, John, give me and Emma, give me a while. Please review how it was yesterday, and I'll make John a little bit bigger because I know he's very sensitive to that. Okay.
You can make me smaller. That's fine.
Yeah.
I welcome everybody listening around the world. It's a bright, breezy day here in the UK. I don't know about elsewhere. We had yesterday probably the best day Lions ever had. I hope that that's not tempting providence today, but we managed to connect 8 different surgeons and see about 15 surgeries, starting with primary stapes surgery, revision stapes surgery, cycloplasty, cholesteatoma, and powered implants. Traditionally, Lion has always done that on the first day of its summer transmission. So the plan today, which we'll go into in more detail in a few minutes when we do the official welcome, is that we're going to cover really in more detail cochlear implantation. And we're going to see 6 or 7 surgeons, all eminent in their field, performing various cochlear implants from different manufacturers to give you an overview of what's available on the market for your patients. And also some other interesting cases as well, which I'll describe in 5 minutes when we officially start. It's quite exciting that we've got so many people connected already. You'll notice that there's a new useful addition to the moderating team. We decided that some of us were becoming old farts and it was a good idea to bring some youth in, and that was a great success yesterday when we got Nina Mystery, who's a very talented UK surgeon just taking up a consultant post, and we were able to get a much better idea of how people wanted to be educated from the point of view of younger colleagues rather than those of us who were, somebody very unkindly, Robert Vonson, your name will not be mentioned, described as dinosaurs. So we'll come back to you in a few minutes. Perhaps if you set your clocks now for 5 minutes, hopefully we'll join you and we'll start today's proceedings. Thank you.
So, good morning. John, are you there? And Emma, I can see that you.
Yes, Wilco, we're here and all primed and raring to go.
Okay, so
Bleary-eyed.
I thought you'd be able to keep a short introduction to everybody. Good
Yes.
morning. As the president of Lion and the only one currently physically present in the studio, I want to welcome everybody who's joining us today again. Please feel free to use, if you're on Zoom on the webinar, please contact the hosts that are present there and they'll communicate with you. If you have login issues with Zoom, which I saw yesterday, there were some, we cannot troubleshoot that at this point. It's too busy. We don't have the manpower to do anything like that at the moment. John, you tell me, I can see Munich has started with their surgery. So I think maybe we should go to Munich, or who should start, John?
Well, should we just do a... We'll just do a very brief introduction, Wilco,
Okay.
and then if we go straight to Munich after that. So, welcome everybody. I'm John.
Ready too. Let's stick with the
Okay.
program. We should go to Hannover first, actually, now, and then
Okay.
Okay.
So I'll welcome everybody. We're the moderators, not physically present with poor old Wilco, who's struggling in the studio there in Utrecht. I'm John Oates, a recently retired ENT surgeon. Having been a sort of generalist for most of my career, with a specialist interest in otology and particularly middle ear surgery. And because of that, we've decided to bring in some useful new blood. And you'll see my very elegant colleague there, Emma Stapleton, on the other side of the screen, who's a young consultant who's been in post for 3 or 4 years and will introduce herself now. Emma.
Thanks, John, and thanks, Wilco. So I'm Emma Stapleton. I'm a consultant otologist and cochlear implant surgeon in Manchester, in the UK. And I'm really delighted to be here today. We've got some really fantastic surgeries coming up. Thank you.
Okay.
So hopefully we'll be able to give a broad panoply from the point of view of younger colleagues and more senior colleagues. And we'd like to try and get as many trainees and young colleagues today, particular, working on the chat room on the webinar. And you can post questions on YouTube as well. So without further ado, we'll go over to the first centre, to Hanover.
Rolf Salcher is ready. And of course, I think we should, if anybody's interested to join the Lion project, they should contact you, John, because we're always looking for good people. And we're very happy with Emma today and with Nina yesterday. Okay, Rolf, guten Morgen. Rolf.
Hello.
Hello.
Hello, yes. Very welcome to Hanover again. So today we will show a lot of cases of cochlear implants, and I will start with a 24-year-old lady. She's already implanted on the left side. You can see it over here. And what's so special about this lady? So she has a high frequency hearing loss. You can see it over here, left side, right side.
Just focus a little bit, Rolf. Could you focus the camera? Better. That's good.
Yeah. Okay. So quite good residual hearing in the deep frequencies between 125 and 500 kilohertz. She's next to normal hearing, and then no hearing in the high frequencies. And we want to go for partial insertion of a Flex 28 electrode. So what you can see down here, this is our so-called MyCI project. What we did, we looked after our patients implanted with the Med company electrodes. And what we found out was that the patients, there's a correlation between the depth of the insertion and the residual hearing. So the aim is today the same as we did on the other side. We want to insert the electrode up to 20 millimeters. So therefore we calculated that the contact number 10 should be just at the round window. Then we get a crossover frequency. We just show it over here, around 1,500 hertz. So, okay, over here you can see MRI scan. Of course, we do this before to know that there's no acousticus neuronoma. We do cone beam CT to see the mastoid is well humanized. facial nerve is fine. Around window niche is there. In the coronal sections, you can see the lateral semicircular canal to look after. I think this is very important to know where's my facial nerve in relationship to my lateral semicircular canal. The skull base is fine. You have a little bit of high bulb over here, but I don't really concern about that. Sinus sigmoideus over here. Yeah, so okay. We will do the insertion with cochlear microphonics monitoring. And yeah, I will use facial nerve monitoring. Always, if I use a drill, I would go for facial nerve monitoring just to be on the safe side. So then we can switch to the overhead. Yeah, thank you very much. So you see the patient is just lying on her back. The head is facing towards my nurse. Janina, she's supporting me. And we will just start with a radial incision. Later on, I will drill an implant bed for the body of the implant. Okay, then let's just start with the incision.
So Rolf, it's John Oates here, one of the moderators. You've already infiltrated with epinephrine.
Yeah. We infiltrate with 5 drops of norepinephrine together with silocaine, so that we have a reduction in bleeding and somehow local help for the anesthesia, also using local anesthesia.
And I'll probably ask you some fairly basic questions for the trainees that are watching.
Yes, of course, you're very welcome.
You prep the skin with betadine, I think. Is that right?
Yeah.
Good.
So,
hello, Rolf.
Yeah.
Hello, good morning. Magnus Teschner speaking. I would like to ask, do you do general anesthesia or local anesthesia?
No, we're using, in this case, general anesthesia. So, I will only support the general anesthesia with some local anesthesia here. Yeah, my first point of orientation is the mastoid tip over here. And then I have the osteogrammaticus coming over here. And just something like 1 centimeter behind the pinna.
While you're making your incision, can I ask about your choice of electrode?
We will use a Flex 28 electrode. In most of the cases, we're using this kind of incision. Only in Oticon implants, there we just modify the incision more like an S shape.
And why do you choose to partially insert a 28 implant?
The reason is she's 24 years. Yeah. She's 24 years old. So very young lady. And if you look at the results with cochlear implants, you can see that patients with a residual hearing really enjoy listening, because listening to music, listening to complex hearing situation is better if you have some residual hearing. And in that case here, she has really very good deep frequency hearing. So we will try to preserve her residual hearing in the deep frequencies. Or the low frequencies better.
So, Rolf, I may have missed it, but I remember in the past, the problem with, surgery like this is that on the long term, people did develop hearing loss in the local hearing loss. Has that not been cured, or is that still a risk of 20% or 30% to develop after successful surgery, still develop central nerve hearing loss in the local?
Yeah, that's the point you're now just facing forward, because of that, we are using longer implants. So we just measure the anatomy of her inner ear by measuring the cochlear duct length, that we know, okay, for an optimal placement of an electrode, she would need a Flex 28. And due to the fact, we will use a Flex 28 electrode. So if she loses her residual hearing, we can just advance the electrode. So go back in and just advance the rest of the electrode.
Fantastic.
And
Yeah,
that's
that's
very in
exactly
favor of patients. Pardon?
brilliant. Yeah, that's what I was going to ask actually. Are you using a longer electrode with a view to advance it further?
Yeah. That's just what we keep in mind, that we can just insert electrode longer if she loses her residual hearing. So, okay, now we have the temporal muscle over here. The musty tip is coming down here. Posterior part of the ear canal is over here. And then we are using the so-called fish flap, named after Hugo Fish. So I'm just looking for the line, temporalis line. It's just here. We will use that to cover the implant later on.
So, Rolf, we have a few standard questions that we've asked all the surgeons over the last 24 hours.
Yeah.
And one of them is really for the anaesthetist. What blood pressure does your anaesthetic colleague that you're working with give you?
Wie ist denn der Blut? 96/50.
That's good. That's very similar to the stapes and the ossicular surgeons that we were talking to yesterday.
Yeah. But it's a little bit a job for the colleague because it's a big lady.
Not you're talking about the patient, I hope.
Yeah.
Yeah. I think you're in theatre. Your anaesthetist is your best friend.
Yes, of course.
So, Rolf, it's very interesting that you say that, because when I was in Hanover, I think the only white or medical clothes I could wear were yours.
That's right. Yeah.
So we shouldn't judge too quickly.
Yeah, and to be honest, and to be sorry, it's still the case.
Well, like Rilko, I grabbed a shirt this morning that I bought before lockdown, and the collar is that it won't come together.
So, a message to the technicians in Hanover. We don't have echo from Rolf itself, which is fantastic, but as soon as we ask questions, we get echo back to the studio from us. And I can see that from the meter as well. So either there's a microphone on the microscope or somewhere else, or you have the speakers too loud.
So that's the fish flap. And I really want to see where's the top of the outer ear canal of the bony part. So here's spina Henlein over here. And you can see here's the top of the outer ear canal. And the master tip is coming down here.
So this is the soft tissue approach that I use for cochlear implants as well. And I've been taught four different but I like this one because it seems to close best over the implant at the end of the procedure because it's got three sides, I think.
It does give you quite a substantial meaty flap as well, doesn't it? It's a nice flap.
Yeah, and the aim is to cover later the implant with all that flap and soft tissue, because I think you really have to take care about your implant body and all that, for not to get it wound disturbance later on.
Okay, John, I think this is very good, but knowing Lion, we normally multiple sessions at the same time. So is there another clinic that we should go to, or do we stay with, I know at 9 o'clock we need to go to Kuopio. That I memorized, but is there anybody
We
else?
should have Joachim Muller coming online at
Yes.
8:45.
Yes, so-
Maybe if we go over to visit him while Rolf does the preliminary bone work.
Yeah, we go, but I do hear.
So we'll come back to you in a few minutes, Rolf, okay? Good morning,
Yeah.
Joachim. Can you hear us in
morning,
München?
Good morning, everybody.
Good morning.
Yeah, this is another case of CAR tympanoplasty in a 5-year-old child with tympanosclerosis and polycythoma.
Joachim,
Yes.
you have an audio intermittent or interference issue. Can you ask your technicians to look at it? We'll be back with you in 2 minutes, but we do get a lot of hum, which was not there yesterday. So maybe the battery needs to be changed or something else. Be
Okay,
back with
we
you.
check.
Back with you in a minute. Rolf, we are back with you for a moment. Hello, Rolf. John?
Yes, I can hear you. I can hear you.
Okay.
I can't hear Rolf. Maybe he switched his sound off.
It is on my side, but I was talking to the technicians. So Emma, you're still here too.
I'm still here. Yeah, we've got some poll questions. We can start up. Oh, got a picture.
Yeah, if you like.
All the poll questions for later.
Okay, well, whatever you like. Rolf, we don't get your sound back. I know your technician is working on the sound a bit. Your image is fantastic, and we recognize the Hanover image because that's always with the nice neurosurgical clips.
So I just start now with the drilling. I take a large Rosen drill. You can see it over here.
Yes.
And now I just start parallel to the outer ear canal wall.
Okay.
And parallel to the.
Okay.
And you can see now here the first cells are already opening up.
Okay, good. Very good. I think Munich has solved their audio issue, so we go back to Munich and we'll be back with you in a minute.
Thank you.
Okay, talk to you in a minute. Hello, Joachim. We're with you now. We don't get your audio. Hello, Joachim. Yes. Hello, Joachim.
Hello.
Can you hear us? Good morning.
Is it better now?
Yes, it's much better. Good
We
morning.
reduced a little bit the volume in the theater.
Okay.
Etwas lauter machen noch hier im Raum.
Well, we
I
can
will show
talk
you
louder.
just the situation which we have to deal. Mal raus.
Okay. And after Joachim, we will go to Kuopio because I can see
Schwarzer
Kuopio is ready too.
Etwas lauter bitte bei uns im Raum.
Okay, Joachim, it's John here. Would you just like to describe a little bit about the case? Tell us a little bit about the case.
Aber die sind jetzt nicht bei mir, ne?
Can you hear me, Joachim?
Sind die hier? Okay, this is the situation with a large perforation close to the annulus. I have freed the rim. Ein bisschen lauter, ich muss ihn hören, ich verstehe.
No, we can hear you very well, Joachim. Please
It's good.
continue.
Yeah.
It's good.
Okay.
Okay, thank you. Dr. Folger has solved the problem. Now you see the perforation is close to the annulus. So what we do is to reconstruct the tympanic membrane with a cartilage, which is thinned out, and an overlapping pericondium frame. And later on, I want to remove the annulus and put the graft as a composite graft underneath with the overlapping pericondium frame into the bony rim of the annulus. This is tympanosclerosis, which I'm going to leave there. In the posterior parts, we had also tympanosclerosis, which was removed with a tympanomeatal flap, and I prepared already the tunnel of the middle of the handle of the malleus, and later on the tympanic membrane will be completely removed, and the cartilage plate will have a groove to take the handle of the malleus, so that the acoustic properties will work out well. Usually it is said not to use to loosen the attachment to the umbo, and it's also like a dogma not to remove the annulus for acoustic properties. But with this technique, which goes back to Tolstoy in the late 80s, it is possible to have good audiological result and to reconstruct the tympanic membrane completely.
Okay.
The other option would be to slice the ear canal and put or pull the graft through that. I don't know the English term in German, and the Netherlands people will understand. It's step plastic.
Is it not pull?
You probably call that an anterior buttonhole.
Yeah, buttonhole. Yeah, that's
good. It's a good technique. It's a good technique if you have good skin.
Okay.
Yeah.
Okay.
But
good.
When you pull through the fascia or graft or whatever, it usually ends up with granulation for quite some time, and that's something a Haken which I feel can be avoided when using the pericondium cartilage island graft, which is in this case also favorable because of the tympanosclerosis and the recurrent infections. I try, like yesterday, to take the graft under the microscope, which is unusual,
Yes.
and which may will entertain you and look funny.
Okay.
When
That
doing
sounds
this.
very good. Joachim, I have to apologize. I know that Kuopio in Finland is doing a patient under local anesthesia, so we have to go to Kuopio right now.
Go to him, and I continue.
Yes.
I know
Sometimes we show
did
you anyway. Yeah. Okay.
Local is always time saving in stapes surgery as well as in cochlear implants,
Okay.
which was done.
Thank you.
I remember the first sonata.
Hello, Arno.
Hello.
Hello. You're live. Good.
We are live. Thank you very much. Nice to hear you, Wilco.
Yes.
And the sound is hopefully as good as before.
If the sound is
Yeah,
not
we've got good sound
we'll
on
tell
it.
you.
Good sound.
Great. So I got a good signal from you too. And just for John, I was delighted to see that there was snow in Manchester too. So
yes, an Arctic blast from Finland.
For today.
That's from Emma. Emma lives in Manchester.
Yeah.
All right. So it's not too bad here. So we have a patient under local anesthesia, and she's a 47 years old woman with a bilateral cochlear implantation, and we will be doing it on the local, just transmastoid posterior tympanotomy approach. But what's special is that we can monitor her hearing during the insertion, and this we will also double check with ECOG measurements, just to have some kind of validation of how the ECOG events will correlate with the sound signal she is perceiving. So that's quite interesting and quite exciting. And we will be doing. She had the first left ear was successfully implanted in March last year. Do you see our slides there? Perhaps.
Yes, we see those quite clearly.
Okay. All right. Good. And here you see the left ear, and this is pretty much what I would suspect for a successful hearing preservation, that we see some kind of deterioration. It was in about 10 dB in 250 and 500 hertz, and she still can use her residual hearing, and actually she's fitted the way that we just start the electrical stimulation at somewhere 70-50 hertz.
I know.
And she's.
Can I ask you something? Because as you know, Professor Cor Kramers is here, and he's very much involved in genetics. And I think he may have a question about genetics. Because
would this be an autosomal dominant type of hearing impairment?
Well, we haven't done a extensive genetic testing. What we do, we have the normal Connexin 22, which we will screen, but normally this is done for the pediatric cases in routine. For our adult cases, we don't screen on routine. But may well be so that she has a dominant trait here. Yes. Okay, I will just show you around our setup, and this is, I think, very much important for a successful procedure in local anesthesia. One is, of course, the patient has to have much space below the draping, so that we can communicate with them. In her case, she has the left ear implant, so we have no problems in communicating with her. But in cases where you have a bilateral deafness, then you can show something on a tablet or from some written information from a tablet computer, or then if the patient has vision problems, then you can teach him some tactile signs, which would be quite appropriate for that kind of procedure. But we seldom use nowadays sedation, because we want to have the patient as cooperative as possible, and sedation is all nowadays only reserved for patients who are uncomfortable during the operation. And one of the main aspects is that you have to have the irrigation fluid warmed up, and we use here an infusion warmer, and you see that the hose is wrapped around the infusion warmer, so that we can so that the patient is not developing a caloric reaction during drilling. And basically the local anesthesia, the infiltration is as seen in the figure, which is quite the same like for every middle ear surgery. So I can demonstrate it to you right away. So are there any questions so far?
No, that was a very clear description. I love the space you have in your OR. I'm very jealous.
All right. So do we have the camera here, Timo? Can you show? Or should perhaps I take the microscope? Then I think this is then. Yeah,
so this is interesting, Arno. Is the extra plastic there? Oh, we've lost the feed.
Yeah,
picture.
This
is the extra plastic there because of COVID, or is that just?
That was the idea from Thomas Rowland. I have to give him the credit for that, because, and I feel it's really nice to have it, because it keeps your field much more tidy. So I think I will use it also when the pandemic is over. I really like it.
Yeah, we had long discussions with Thomas Rowland during the peak of the epidemic in New York, and certainly NYU, where he works, seems to have made some very, very sensible modifications so that they could continue operating.
Just to all the searches, we're showing Arno Dietz from Finland in the center, Rolf Salcher from Hanover on the left side, and Munich on the right side. But we have the sound only from Arno Dietz at the moment.
All right, and now this is, I think, the most important part of the infiltration, to get it under the periosteum, and basically voitko vähän minun päin kääntää? Hyvä, kiitos. And this will help also if you open the posterior tympanotomy. And you see that the skin is getting pale, and here you see that the lidocaine is going under the periosteum, and it may be also go into the middle ear, and this is something we actually would like to see.
Arno, can you just raise the image a little bit? You're at the bottom of the frame. That's better. Perfect. Perfect.
All right. So you see that the skin is getting pale here, and now that's a sign that the infiltration is going in the right place. Sometimes when you are a little bit lateral, then you can get some kind of hematoma in the skin, and this is obviously something you don't want to see, which for middle ear surgery will blur your vision and obstruct your vision. And for this I take my time, because I think that's quite crucial. Also,
these are quite important points, Arno. It was interesting that Chris Aldrin focused on these yesterday as well. When you're doing a siccular surgery, if you inject deeper in the canal, the big problem is if you inject too quickly, you get blistering. And then the skin tears when you do the dissection. But it's a good tip for the trainees watching, that the infiltration should take a couple of minutes, not just squeezing the infiltration straight in.
Yeah, and actually you see that there is not going very much of stuff there. So, but
well, the first whitening, of course, isn't the effect of epinephrine. It's pushing the blood out of the vessels.
Right. So that's about it, and now we can plan the skin incision. Now, if we go for a cochlear implant, traditionally we had quite large skin incisions made, which was also a problem for or the susceptibility to post-operative infections were much higher than with the smaller incisions. And the patients,
you're in the startup phase. I can see Hanover is moving on swiftly. If you don't mind, we do a quick switch, and because we have 3 surgeries going on, just to indicate, because we know you're working on the local, indicate if needed, and we'll come back to you, and we'll keep an eye on the video anyway. Okay.
All right.
Okay. Thank you. Thank you, Arno. Okay. Rolf, we're back with you.
Yes. Hello. Yeah, I can hear you. I can show you what we did so far right now. So we proceeded with an S-videectomy. orientated me at the skull base, coming down into the antrum area over here. So you can see here is my antrum, there's the antrum. Here's the short process of the ambos. This is a semicircular canal, the lateral one. You can see down here already the facial nerve. And now, for my posterior tympanatomy, I know now the height of the facial nerve is just in the level of the semicircular canal in this case. So it's just coming here. The choriotympany is coming close to the outer ear canal. And the most important thing is always to work parallel to your structures. And now we will start just very, it's very important to have a good irrigation, that there's no heat to the bone, because that could harm the facial nerve.
So Rolf, we've got a good view there. Perhaps you could tell us some of the technical aspects of the equipment you're using. For instance, the type of drill and the monitor.
Yes, of course. We have. I'm using an. Okay, the microscope is an iriscope we're using, and the drill is a 2.0 diamond drill. And my irrigation, my system is a Medtronic Indigo.
You're very quick about the iriscope. Can you please explain what it is? Because I'm sure not everybody knows.
Okay, yeah, the iriscope. The iriscope is a real 3D microscope. So I'm not looking on I'm not part of the optical axis. I'm just looking on two small monitors, which are looking like an ocular, but in real they're like two small monitors. And the big advantage of this system is that you can do a very good teaching, because as you can see, hopefully, you can see a very nice picture out of this microscope. And you could also be able to look on 3D pictures with this microscope. So we have two cameras in the front of this microscope, and so I'm looking TV all the day, not working. Yeah, but by the way, so now I'm approaching here to the middle ear. Here's some kind of an Holstein cell. Yes.
Could you show us the microscope with a macro camera?
Yeah, kann man bitte einmal kurz die Makrokamera auf das Mikroskop richten?
Yeah. The nice thing about the iriscope is I think it's a full digital. There's no optical connection to the surgeon direct. It's I think it's a 5K or a high resolution camera that splits the screen into small video, small screens, which are your input. And the nice thing is the image that we get is very natural. It's a very nice image. And I know the company is big in Hollywood and video production, video camera hardware anyway.
Yeah.
So it's quite nice.
You're totally right. The company is very famous in Hollywood films, Hollywood movies.
And I think Joachim Müller has one. I'm not sure if he's using it, but we shoot, and I talked to Thomas Lenz about it. We will do shortly a 3D broadcast from the studio that people can watch in 3D around the globe. And of course, we need Joachim Müller to be with that as well. But that's going to be nice. The image is very good. Sorry about.
I can see an Oscar looming for Rolf Sacher. Rolf, there's a question here from Syed Hassan. He said, "Do you feel the facial nerve is in a normal position here, from what you can see at the moment?"
Yes, it is. So the facial nerve is just here, where my section is now. So just in the level of my semicircular canal over here. And yeah, it's a nice approach now, because I can already see down here the round window niche. Bitte mal die Bohrer auf 5000 Umdrehungen und die Spülung auf 5 gepulst. So I will now start with the drilling of the overhang of the round window niche. Therefore, I reduce my drill speed to 5 gepulst und 5000. 5000.
To 5,000.
5000. 5,000.
And pulsed water.
Yes. Yeah, 5 plus my water and only 5,000 units a minute. So that I'm not too fast drilling now. Was ist das für eine Größe jetzt hier? Nee, bitte einen 1,5er. And now I switch to 1.5 diamond drill.
Okay, good.
And what's the situation with drills in Germany? Are they all disposable or reusable?
We can reuse them for several times.
Can I just ask, in this case where the patient has good local hearing, what are you doing to try and preserve those thresholds?
We give a shot of steroids at the beginning of the operation, 500 milligrams of solo-decotin. And now I try to drill very slow under the cochlear. And really taking time for this step.
Any topical steroids?
Yeah, later on, when I did this drilling, I will just place some Helon mixed with Forticotin, 4 milligram, just to the round window. And in between, I will do the drilling for the implant pad.
Okay. It looks very good. I think because Kupio is working on the local, we need to check Kupio for a moment. But
of
we'll
course.
be back with you in a minute, okay? And Emma has some questions for Arno. Arno, be prepared. You're going to get some difficult questions. Hello, Arno.
So there were some questions.
Come on, Emma, go.
Yeah, so a couple of questions about your case, which is under local. Firstly, are you using a facial nerve monitor?
No, you cannot use it in local. So we do it the old-fashioned way, with just to see where the facial nerve is. So that's a downside of this method under local, that you cannot use it. Maybe there.
Yeah, I do the same.
Yeah.
I do local cases without the facial nerve monitor. I did try it once, but the patient really did not enjoy having a facial nerve stimulation working with the weight. It was a very painful experience for him. So my second question is...
Emma, I cannot hear you very well. I don't know what's the problem.
No. Okay.
So can you repeat your question?
Emma, can you repeat the question? Because, of course, there's a lot of noise in the OR, and it's not your English. I don't think your English would be the case. But
actually, he's answered the question very nicely. Can you hear me now?
Yeah, better. Yeah, but it's quite noisy here. So
yeah.
Yeah.
So my second question to you is: so your patient is already implanted on the first side. Is that correct?
That's correct. Yes.
So is she wearing her implant now? How are you communicating with her intraoperatively?
Yeah, she's wearing her cochlear implant up to the point where we do the electrocochleography measurements. So we can communicate with her very well. So that's not a problem.
Brilliant.
And this often helps quite much if you have a good good connection to the patient, and you can tell the patient about the different steps, how long it will take, presumably, and things like that. So we will start now the mastoidectomy. I will just show that again that I also use the inferior pedicle flap, which gives a quite good coverage to the cochlear implant, and the skin incision is not. You can do it through a smaller incision, of course, but then if you want to do a good implant bed, then you have to retract the skin quite much, and this can sometimes be counterproductive. So it's better to start with a bit larger incision. And I will start now the mastoidectomy. I can show you the landmarks we have here. So here we have the spine of Henle, and linea temporalis is at that point. So here we start our mastoidectomy, and she has quite a large mastoid air cell system, so that we can do the implant bed also partly into the mastoid, which helps to sit the implant without getting any bump here at the skull.
Okay, thank you, Arno. We need to go to Hanover, and after Hanover we go to München.
Hey, what is that?
Okay, hello, Rolf, sorry.
So now, I'm still doing my prep on the round window niche. So you can see now the round window is next to complete visible. It was quite a drilling. She had quite a large overhang, bony overhang. Just a little bit more. Now I changed to 1 millimeter drill.
We can't fully see the image. If you could angle it a little bit better. The image from the microscope is fantastic. Very nice.
Kann ich einmal bitte ein Stückchen groß haben?
For those of you watching on the Zoom webinar feed, there's a questionnaire just been posted. Perhaps you'd like to answer.
Okay. Rolf, I hope you can wait for us. We need to go to Munich for a moment.
Yes, no problem.
We'll be back with you as soon as possible. And for the technician in Hanover, we still get a feedback from the questions, not from Rolf. The sound from Rolf is fantastic, but we do get a sound back.
So, kann ich einmal
Munich.
den Hochmann, dann bitte die Spülung wieder auf.
Hello, Joachim. I see the clear blue silicon again. We're with you.
Hello.
Hello.
Yeah, I'm on the way back. And what you see is that we have replaced the tympanic membrane, and I have lifted the fibrous annulus. And with these silicone sheets, I reconstruct the tympanomeatal angle, and also put some gel foam soaked with tetracycline to get the a good shape. Nochmal eins. Schön trocken.
The same way
Are you-
as yesterday, you use a nice closure technique with this special silicone sheets.
Yes. And
Yeah, I
but
quite like this idea. Perhaps you could get your nurse to show the packet under the camera at some stage of the silicone came in.
yeah, in a minute you will see how it comes in.
Yeah.
And what we forgot yesterday to show you the special hooks. This is just temporarily placed to keep the tympanomyetal ankle nicely reconstructed and not bleeding. Nächste Folie bitte. Schön von oben mit der Rundung nach unten. Das möchten die Herrschaften im Fernsehen sehen. With me is Julia. I'm not sure if I can show her. It comes downwards with a rounded tip, and then you can suck it and manipulate it into the ear just in a way as you want it. Nächste, Julia. And we try to surround the whole ear canal with silicone to avoid granulation tissue and to facilitate epithelialization. Okay. Und ein neues Schwämmchen. Geben Sie mir mal 3 verschiedene Häkchen, 90 Grad und 45 Grad, dass ich das gleich mal zeigen kann. Before closing, I just want to show you the instruments that we discussed yesterday in stapes surgery. Haben wir die mit Ringen? Look, these are green and red rings at the instruments. One are 45 and one are 90. Green is 45 and red is 90. And depending on the length of the hook, we have 1, 2, 3, 4 or 5 rings. Some advertisement. It comes from Spiegel und Theis. This
That's
is
a
the
German
number.
company, isn't it?
I will send them a message to give you some discount and support the Lion broadcast next time. But
Very
this
good.
is very helpful because under stapes surgery, the room is a little bit darker. And if I want to have a short hook or a long hook, it is much easier for the scrub nurse to come in with the right instrument. Weiter, Schwämmchen. And now we pick and later on we pack it, and then after closure from the back side, we will unwrap it and make a package in the canal. Noch 3. 1. 2.
I think that's very good. We need to
Yeah.
go to Kuopio one moment, I think.
Yeah.
If,
We'll go. One,
yes.
just a quick note.
Okay.
As we discussed on Monday evening, due to anesthesiology wishes, we will start with the cochlear implant, which was scheduled a little bit later, directly after this case.
Okay.
So we will come in, if you like, with the cochlear implant
Yes.
in about an hour or so. So electrode insertion would be ready in 2 hours from now. And the surprise will be that I will force Dr. Folger, she does not know it already, or up to now.
Probably watching the stream.
I missed that because John was intervening.
Sorry.
Can you repeat the last word, please?
Okay. Danke.
Well, be gentle with Dr. Folger, but of course I leave it all completely up to you. We need to go to Kuopio because Kuopio is Under local,
Under
and
local.
then we go to Hanover. Okay, thanks, Joachim. We'll see you in an hour.
Okay.
Bye, bye-bye.
Emma, can you close the poll on Zoom, please?
Hello, Arno.
Okay, hi guys. So here we have the subtotal mass spectrometry done. So we see the lateral semicircular canal here.
Yes.
Then we see the incus there. I will not touch the incus because this is a hearing preservation case. And this is something what many surgeons do automatically, to touch the incus just to see whether it moves or not. So I prefer not to move it. So, and now I will start the posterior tympanotomy. And my landmarks for the posterior tympanotomy are the incus. And here actually we see the insertion of the incus is somewhere here of the short process of the incus. And here we see that there's still quite much bone left in the posterior canal. And this is something I have seen in many trainees, that they leave the canal wall just too thick. And this has to be thinned out very, very carefully to have it really, like Shaq says, eggshell thin. And I will start here just to make it a bit thinner, and then I will proceed medially. And when that's done, then I will switch to a smaller drill. Here I have a 4 millimeter coarse a diamond. And to answer John your question before, that yes, we have the drills are disposable, so we are not allowed to use them or to sterilize them anymore. So, but we have a nice center where we have temporal bone left, and this is where those burrs go. And for the temporal lab, then we have good quality burrs. So I will start here to thin the posterior wall. Something what you can do if you are not quite sure, you can remove, or you can elevate the posterior skin more. Then you can look from here just to have a view that how thick the posterior wall still is. This is a quite good trick. I don't know who showed it to me once. Most probably it was the Lion Web where I picked it up.
John or Emma, please pick up the question from presented.
Yes. So there's a very nice question that's come through from the YouTube platform, which is about indications for going for a local anaesthetic cochlear implant rather than a GA. Do you offer it to everybody, or is it generally for a patient who have a contraindication for general?
Who's asking this?
So this is someone on the YouTube platform.
Yeah, Anwar
Ashkar.
Okay, so still I can hear Emma quite Emma's signal is not so good, but I repeat the question. So what are our indications for a local anesthesia procedure? Was that basically the question?
Yeah, that's correct.
Okay, so we started out doing this with the elderly in mind, elderly patients in mind. I once had patients, usually 80 plus, who didn't want to have a cochlear implant because they fear that they wouldn't wake up from the procedure. And then I promised them to do it on the local, and on second thought, I had to figure out how to do it, and actually nowadays, as our experience have grown with this procedure, it's basically we have reached the point of no return, so to speak. So we have to we offer it to every adult patient because we don't see any absolute necessity to do it under general anesthesia. Obviously, the patient has to be suitable for that procedure. That's for sure, and it has to be well, in cases where there's a doubt that in the patient, then we do it obviously on the general. But as a second indication, which is quite new for us, and this is something what we discussed with Professor Lennartz is obviously hearing preservation cases where we can do quite reliable hearing monitoring during the insertion, and this way it might be possible to prevent trauma, insertion trauma, in the way that when the patient says, okay, now the stimulating sounds gets quieter, then we know that the electrode is doing something to the cochlea, to the basilar membrane, for example, and this has been quite a good method to prevent insertion trauma. And I think this is more reliable than electrocochleography. So we have seen in patients hearing perception despite no ECOG responses. So this has been a quite successful approach, and we are planning to do also at one stage randomized trial just to see that can we preserve hearing better if we do it on the local anesthesia.
That's fantastic. So you mentioned earlier that you prefer to use just local and not conscious sedation. Have you tried doing it with conscious sedation? And what do you think of the drawbacks?
Yeah, the conscious sedation, it might work, but in the cases we were really where we had problems, that was the cases where we had the conscious sedation, because sometimes it's quite difficult to get the doses right, and patients might get asleep, and when they are waking up, then they basically want to leave, almost basically leave right away, and then we have problems. This was actually a case during a Lion Web broadcast once, so where we had really trouble to keep the patient on the OR table.
Okay.
Yeah. So now I have the posterior wall, and sometimes I can demonstrate to you. Here you see the sign. If you go with a suction here, and then you see a shadow here in the bone, and then you are quite sure that this here you see it very well. You see, if you look at this place, and now you see see my suction, then you see that there's a shadow, and now I see that this is sufficiently thinned. So now I can proceed to the posterior tympanotomy, and basically at that point I will start my drilling. We'll look for the chorda, and then
I know. We'll keep an eye out for you. We need to go to
Okay.
Hanover for a moment. Ralph,
Right.
we're with you. Hello.
Yes, hi. So we just set up everything and I can show you perhaps with a microscope. Yeah, just yes, now you can see my microscope again. Yes, very nice. Okay, jetzt kann er mal raus. I will just give you a guide what we did so far right now. So I drilled the implant bed. We are very in favor of that in Hanover because we see it's very important to take care about a good fixation of the implant body, that it cannot move around afterwards. So you can see down here, kann ich ja mal
Ralph,
den nehme ich mal.
I think you should emphasize, because you do it implant beds, but it's more than that. Because the Hanover technique really shows a canal in Citelli for the implant.
Yeah.
It's fantastic fixation.
So it's really in this mold. And then we have this tunnel technique where the lead is just under this bridge. So it's very stable fixed. You can see over here, I have a loudspeaker now in the outer ear canal, which is connected over here to our loudspeaker. So, now I will place the button on the implant because we want to measure cochlear microphonics while we insert the implant. That's really the case Arno just mentioned. So the best thing is if you really want to go for good monitoring of residual hearing, that your patient is awake. But in the other cases, of course, yes, you can try just einmal warten, wir müssen wissen, dass wir guten Kontakt haben. Then the use of cochlear microphonics is a very nice tool. Okay, so we just check that we have Achtung, Elektrode nicht festlegen. It sticks everywhere, not there where it should. And the downside now of our technique of the partial insertion is, I will show you it now. It's not always that easy to count the contacts. Yeah, you can see now, we have now the Flex 28 electrode in the vector version, so we have a stronger magnet. Darf ich mal einen blauen Stift haben? And now, with L series, they have 12 contacts, starting at the tip with 1, down here at 12. Now we want to have the contact number 10 at the round window. So this is number 12, 11, 10. So just over here. I just try to mark a little bit, but it's not really working that well. Okay, so now we go back into the masthead. I lift up the table a little bit. Kann man ein Mikrofon mit besorgen hier bitte für die Ingenieure? Kann man ein Mikrofon einmal besorgen für die Ingenieure? Machen wir den sauber. So, okay, now you can see our mastodectomy. In between, I closed it just with a little bit of gel foam, but there is no dust going into the middle ear. Noch nicht, bitte. In between, I had a little bit of dexamethasone just to the inner ear. And you can see now here the slit, because another thing is what is very important is to take care about the fixation of your electrode. And that's a thing about the use of partial insertion with a company. Due to the electrode, you can see over here, the electrode is getting thicker. And to clamp this part part of the electrode to fix it, you need a 1.0 drill. Over here, you should drill with a 0.5 drill. So in that case, because we want to only insert part of the electrode, I made a smaller slit. You can see it over here, facing downwards to my round window niche. So, dann bitte mal einen 1-0. Können wir ein bisschen Pergament entnehmen? Oder wir nehmen lieber Nadel einfach.
So welcome to all the viewers. You're watching the Lion live broadcast of the second day.
Jetzt ein 7er Sauger.
We're now watching Hanover broadcast.
Yeah, okay. Nee, machen wir nicht. Okay, so now I will open up the round window. Bitte ein 04er Arbeitshäkchen.
So Emma, what's the situation in England? Is partial or hybrid hearing very common in England, or is that still an insurance discussion?
Yeah, so this is something we touched on earlier. I wonder why a partial insertion of a longer electrode. And in fact, he's given a great explanation that the patient currently has nice low frequency hearing to preserve, but that when she inevitably loses that, he can advance the deeper. We're not doing that at the moment, but it'll be really interesting to see whether data comes out.
Dann bitte mal Einführungszähnchen. And now the special thing about the metal electrodes is they are very, very soft. And really like to move to every drop you have. So now I'm just starting to insert the electrode, but it's not going their way. Noch nicht jetzt. Kann ich bitte mal einen Sauger haben? I have to open up a little bit wider. Darf ich bitte einmal das Schippchen groß?
So when you open your round window in a hearing preservation case,
Yeah.
do you lift the annulus of the round window, or have you made a cut in the round window?
Usually I make quite a large cut into the round window, like a Swiss cross.
Yeah. Yeah.
Das mit Elsie bitte, ne, an den Tisch.
John, Emma, there's a question maybe.
Sauber, ne?
So someone's posted a question about whether you do your insertions through some liquid, through the dexamethasone.
Rolf, could you comment on the Cochlear microphonics?
Not yet, because we are not starting.
Okay.
I think we need to emphasize that we need a question.
Darf ich nochmal bitte die leicht geschwungene Nadel haben?
Over which the clinic is named after as well, and it's a very good question. Am I happy to pose it? I'm not sure if it's now the moment.
Sorry, Rolf. Wilco, when you're talking, we can't hear you.
I'm not talking at the moment because I'm just struggling with the electrode going in that
Rolf.
direction.
No, it's not you. I'm talking to Wilco and just telling him he's unusually for a Dutchman very quiet.
So, nun können wir einblenden. So now that was the very first challenging part with the flex series, just to insert the tip of the electrode. And now you can see this insert in my microscope. Now we want to show you the recording of cochlear microphonics while we insert the electrode. Habe ich das mit L7 am Tisch? Bitte mal die Forke. So please, can you start doing cochlear microphonics recording? Hast du ein Mikrofon? Kannst du ein bisschen was dazu erzählen? So can you hear my engineer, Manfred Schwebs? He is just doing now the cochlear microphonics measurements.
Yeah, we can see the image beautifully in the top of our screen.
And now you should hear his voice too.
I hope so.
Yes, we can hear him.
This is the first time of the measurement. We stimulate with 50 dB, and there were nothing to see at this time.
So we advance the electrode.
Should I start again, or
now you can start again? Yeah.
Start the next step. The black line is the line that we measured before. There we see no answer. Here I see not so much more. For me, it is no answer.
Wie viel Dezibelstimme bist du?
It is 50 dB.
Okay. So I insert more?
Yes. Should I start again? I start again. Put the window a little bit away. Maybe we get a little bit of an answer, I'm not sure.
Can you show with the mouse where you think the answer is?
Maybe there we got yeah, here you can see it maybe a little bit better.
Okay, dann kannst du wieder.
Okay, I start the next. It's not much, maybe a little bit.
Just wave again.
I think it's not so much to see. Maybe it's less than the measurement before. Okay. I would say the measurement before was a little bit better. Yes.
The pity about the mid-L system is that it's not working like a live system. For example, Cochlear or AB is it doing now. So I have always to stop my insertion process and wait for the measurement. And so I cannot react immediately like I can do that with this other measuring the systems.
This one is nearly straight, I would say. Maybe a little bit, but yeah. Yeah.
What do you do if the cochlear microphonics disappear?
At first, I stopped to insert the electrode, and then, if I can trust into my signal, I would pull back the electrode to see if the signal is coming back again. Kannst du noch mal messen?
Measurement is running. Maybe see a little bit. No, it's not so much, but I would say there is something.
Okay. Kannst du noch mal messen?
Let's start again.
And my hand is now resting on the head of the patient. As you can see, it's not that easy to count contacts while you insert electrodes sometimes. So here is number 12, 11, 10 is down here.
It's not much but to see, but yeah, maybe a little bit.
Willst du noch mal messen?
I start again.
Nee, erstmal gar nichts.
Vielleicht könnten wir etwas höher stimmen.
Ja,
am Ende noch mal.
Darf ich mal hier den Sauger haben?
Mit 55 dB?
Ja, mach doch ruhig. We will increase a little bit the loudness.
Okay, but maybe the answer was a little bit higher, the last one. I go from 50 to 55 dB.
So now you can see here, just in the slit is contact number 12. Down here is number 11, and this one is number 10. So I will insert one contact deeper. That's something around 2.5, 2.8 millimeters.
That's the measurement is 55 dB. Think the answers maybe the same, maybe a little bit higher. Just not so much different to the measurement by 50 dB.
Medikran. Wenn wir leicht geschwungene Nadel haben. So now again, trying to count contacts. Here number 12. This should be number 11. This number 10. So we'll just proceed a little bit. So here number 12, 11, 10. Just a little bit deeper. Okay. Now we have here number 12, 11, and 10 just down to the round window. And yes, you can see over here, that what I just mentioned before, here is the electrode is getting thicker in the diameter over here. So therefore I drill just a slit 0.5 millimeters to fix the electrode here, and it cannot move out of the inner ear. So if we want to later on insert all the electrode down into the inner ear, we have to widen a little bit our slit. Wenn wir ein bisschen Blut bekommen dann von der Anästhesie, kannst du nochmal messen? Ja.
I measure again by 55 dB stimulation.
In your experience, when you come back to re-advance further, is it always going easy, or is there ever any fibrosis?
So far right now, we had not a problem inserting over electrode. Yes, there is a risk of fibrous tissue formating in the inner ear, but so far right now, we had no case where it was a real problem. And we know also by cases where we have to go in and change the implant due to technical failure, but in most of the cases, we are lucky and we have no fibrous tissues inside the cochlea, which makes such a big problem that we cannot insert the electrode. And so far right now, we had no case where we could not insert all the electron down there. Kann ich immer zwei anatomische Pinzetten haben? We're just now waiting for a little bit of fresh venous blood, just to closer the round window.
Okay. I really would like to see if we need to go to Kuopio for a moment.
Of course.
As you know. Arno, we'll back with you for a moment. Hello, Arno.
Oh, now it's away. Hi. So we are now drilling the implant bed, and I prepared the round window. I removed the bony overhang, and also because we will monitor her hearing, I was trying to remove all the hematoma and the bone dust in between the stapes, foot plate and the stapes substructure. So I think you can go to, because you don't see here anything right now. I just make adequate implant bed, and then you can come back for the insertion. Would that okay with you?
Yeah, absolutely. We'll be back.
All right.
There's a question here, maybe for Rolf and Emma. It says in cases where there's damage to the chorda or cutting the chorda for access, what's your experience of subsequent taste problems?
That's quite interesting, the chorda, because sometimes it's really crazy. Sometimes it's really better to cut it, and the patient has less discomfort afterwards than manipulating too much. Yeah, that's my opinion. But in most of cases, you can preserve the chorda. You have really to thin out the posterior canal wall, and then you can come down here to the chorda.
Yeah, I think we often say, Rolf, that I know Chris Aldrin has mentioned this before, in Stapes surgery, if you chorda and you get a bad hearing result, the patient is much more likely to be very unhappy than if you cut the chorda and you get taste disturbance with a good hearing result. And I think that's true. I mean, it's a very small number of patients that get dysgeusia, but some of them complain bitterly, especially if they're chefs or what we would call foodies. I don't know whether it's the same.
Do you have?
Of course,
word in German? Yeah.
John, do you have?
I think it's more a problem if I don't think that's a problem in England or in Germany, because they are not so good in tasting like France.
Well, no. I think there are a lot of Michelin-starred chefs now, apparently, in the UK. But we're not telling the French. But you can only get fish in the UK at the moment, not in France. But Wilco, you were going to say something. Yeah.
Okay.
So we just start with the Stapes measurements.
Okay, hold on. There's a question
Be
from
great.
Mariana Lille. And John, can you look at the program? Because I can see that Naples, Napoli in Italia is also almost ready to promote surgery.
Yes, you're right. Yes.
Is that correct with the program as well, John?
Hang on a second. Give me 2 seconds.
Yeah.
Yes, you're correct. You're correct, Wilco.
Okay. So as soon as we get a live feed from Naples, we will
go to
Naples
listen
as well. And we're now in with Hanover with Rolf Salzig connected, and I can see Antonio.
Okay, ja, ist okay. Kannst du listen gehen? Zum Listen.
Antonio, 2 minutes and we are with you, okay?
Yeah.
John, can you address the question, please?
Nee.
Yes, there's a question. Do you use electrocochleography for any type
of
electrode?
Sag mal die AT-Messung. So we now start the ART measurements. Ein bisschen verbessern. That improved a lot with the mobile companies. So now they're really good in doing these measurements. It's very fast and also reliable. So we have the first answers on contact number 2 and 6. Now it's interesting if you get an answer on contact number 9 or not.
Ralph, we need to go to Naples as well. Just indicate if you have something to share. Antonio Della Volpe a Napoli, buongiorno. Antonio, mi senti? Buongiorno. Antonio. Antonio.
No, pure al
Antonio.
L'hai visto?
Okay.
It's interesting that
it is, yes.
It's interesting that the Italians produce more sound than all the other centers combined.
Well, that's because I muted the other.
It's the Mediterranean bonhomie.
John, to tell you honestly, I muted the other Mediterranean sites. Yeah.
Did you?
Okay.
Right.
Rolf, we're back with you for a moment. Italy is not ready yet.
And we will see now if we repeat the measurements with a slower but more precise measurement. If we get an answer of contact number 9 and 10, but 10 should not be an answer possible because it's just outside round window. So you see now it's advancing slower than before. And we just see what's happening. Later on, we will go for cone beam CT, just to document the placement of the electrode. And also use that for fitting. No. Wollen wir noch irgendwas anderes machen, dass wir es noch kriegen? Ja, dann mach nochmal. Yeah, stop it. Number 10 is not interesting because it's surely outside. Mhm. Mettimi là il PowerPoint.
Das ist auch nur die Nummer 9 testen, oder?
PowerPoint.
Oder euch hi.
Okay, we're
Also,
now
so langsam.
tables to Antonio
Yeah.
Della Volpe. Buongiorno, Antonio. Come
Buongiorno. Ciao Wilco. Bene, how are you?
Non posso dire male, no, molto stressato. E qui sono con miei amici, guarda un attimino. Qui sono qui avec no, scusa, con la vita è troppo difficile per me.
Fai un mix italiano-francese.
Sì, certo, è difficile adesso. I'm here with Emma Stapleton, John Oates, and of course Professor Cor Kremes, a good friend of mine as well. And we welcome you, and we're very happy that Naples is with us today. And we now are broadcasting you live. And please present your patient case.
Thank you. I present my case. We will start. She's a young girl, 4 years old. She has a profound bilateral hearing loss. She referred to our center at the age of 2 years. She has no other pathology. She's only hearing loss. This is the audiometry. You can see that she has a profound hearing loss on the right side, and we will perform. We perform cochlear implants on the right side, and she wears hearing aids on the left side. We will use better cochlear implants, and okay, this is the image. The anatomy of the cochlea is absolutely normal. We perform only MRI because a very young child, we prefer don't perform CT scan to avoid radiation in this very young child, but we will perform, of course, if it is necessary, but in this case, it was not necessary. Please, this is the same image. You can see the cochlea, normal aspect of the bilateral of the cochlea. And we will perform this surgery using, please go on, with the use of robot scope. We will perform the first part of the surgery without any microscope as usually, but after we will use this kind of microscope. Roboscope is a visualizing system for microsurgery. It's based on a digital software controlled technology. It consists of 3 coordinate main components: head mounting display, robotic arm, and a microscopic camera. You can see the robot.
Yeah, we see you. Okay, there we
go. Yeah, you see you, but now you can see. I think it's more interesting for you to see the robot scope than me. Do you agree?
No, non lo so, non posso dire così.
Okay. This means, Walter, this means the all important functions and movements of roboscope can be activated hands-free. Unlike conventional surgical microscope, roboscopes allow surgeons to keep their most important tools, their hands and their eyes, through the operation on the surgical field. It enables surgeons to enhance the ergonomics, high-quality view, as well as free adjustment of visualization system. I think that it could be useful in some type of surgery. Of course, we have a training to have the possibility to use this one. It's different with the normal microscope. And now we will try to use it in the final part of the surgery because they use the very important use of this roboscope is in the part of the cochleostomy and the insertion of the lecture, because we have a very big magnification, and you can do insertion of the array with high precision.
That sounds very good. It's very interesting, Antonio. I think I've seen the device in France for a short while. I'm very curious how good the quality will be of the image. As you know, we also use the digital microscope in Hanover, and maybe also even in Munich. I don't know. But it's very nice. Okay, good. So, do you want us to come back when, or do you want us to stay with you? We need to go to.
We start without the microscope, and then we call you. Okay.
Okay, fantastic. Okay, just show me the picture. Okay. So now we go back to Upio.
Okay.
Okay, we're back in Finland now. Hello, we're back with you.
Okay, I can hear you.
Yes, and we can see you.
I have to turn down the volume of my headphone. There were really big noises from Naples.
Oh, that's good.
Yeah, that's the way it should be. Okay, I just put the ear tip into her ear, and now we are ready to proceed with the implantation. So the next step, I put the implant in, and then we will start the insertion, and we will monitor her hearing. And to keep it a bit more tidy, we will put another drape on, so then we have no bone dust making our now the implant making our job more difficult. Yep. So our experience with the measurements of the cochlear microphonics and the subjective hearing is that in many cases where you don't have any ECOG responses, the patient is still hearing the sounds, the stimulating sounds. So that's therefore I think this is a quite good way to ensure that you are not harming the cochlea during the insertion.
So this is a cochlear device, isn't it?
This is a metal device.
A metal. Okay, sorry.
Yes. No problem.
Some people have connected just now. I think you could explain that you're doing an implant on the local.
Right. So that's a bilateral cochlear implant on the local, and we are now ready to do the insertion. We have to make some preparations because we are doing intra-op measurements. We have to check that everything is set up. Probably this is sometimes a challenge to have all the devices and the nurse battery has to keep it. So then you can go to the microscope view and let's see what we have. So, okay. Like Rolf Salcher in Hanover, I use steroids for the round window, after the round window preparation. and it's sometimes quite tricky to remove the round window overhang without perforating the round window. And this is something for which is what you should avoid in hearing preservation cases, obviously. And now, since we are measuring hearing, we are also want that the staples can move freely. Here we see that there's some bone dust between the staples. I don't know if I can manage to get it out. So now it's centralized a bit better. Here you see. And now we go to the round window. And about the quarter problem we spoke about, here you see that here's the quarter a bit exposed at that point. And actually she sensed it, that there's something in the taste at the moment. So here you should see the round window membrane. It's well prepared. So we see just the window, and now we can proceed with the insertion.
Just a general question, Arno. 4 years ago, I had my thumb reconstructed following a skiing accident. Had to lie on the table for 2.5 hours, 3 hours under local. Do your patients find it uncomfortable lying on the table for that long, or do they say it's not a problem?
Yeah, I think that's one of the main problems, because the OR table is not made for comfort. So no. We really take care and spend some time that the patient is comfortable on the table. So that's right. So that may be a problem for patients who have back problems or neck problems, and sometimes it's implantation of local is contraindicated because of that. So
yeah, I have to say the first 2 hours was okay. It was beyond that, and this case isn't that long, so yeah, that's probably
okay. Do you have the picture from us?
Yeah, we've got a really good picture. Yeah.
All right. You see the round window. You see my needle, and now it goes inside, and now it's perforated. And now I will take a hook, and with the hook I will flip the membrane upwards or towards me. And here you must be very careful not to suck the fluid out of the cochlea. And now I have the small hook. Now I flip. Now it's open. Now, and this is something I think has made my hearing preservation results better. So I used to use the slit, but in that here with this method I've been having better results. Now I put some dexamethasone again on a little bit bleeding here. This is always bleeding is your worst enemy. But I think we can manage. Then I will, and this is also important, I will curl the electrode wire already in the mastoid, because we have experienced some we have experienced we have experienced problems with extrusion, and this might be due to the fact that the electrode wire maybe cause tension, which can facilitate that the electrode, especially those lateral wall electrodes, can migrate out of the cochlea. And this is something you have to be very, very careful about. And I'm not quite sure whether we have solved this problem already. You see that there's quite a bit tension here, also in this wire. So, but this is basically how it will fit in the cochlea. Now you see this point here, and this is something I really appreciate that the new flex electrode has, that we have this marker. And this marker gives you the right orientation. But anyway, it's not very, there's not very convincing data that there is much how significant is this is how the electrodes are orientated. Now somebody has. Okay, we have to take the implant out from the patient. The other one. Anna Imo. Musta. No. Okay. My engineer says that we have to make an impedance check first. So.
Just a message to Hanover. We will go to Hanover as soon as the insertion is done. I can hear Professor Lennartz. We will go to Hanover after the insertion.
Okay, we do the anna se tuo niin toi se paketti siinä. Laitetaan sitten pesit sinne. Okay, we do the impedance check first. Sorry for that delay. I wasn't aware of that. And for this, we have to put the electrode somehow in water. So, en mä voi kudokseen laittaa. En pysty laittamaan. Että ei tarvi. Hyvä. Joo, ei onnistu. Okay. And now you see this is like surgery, that we have here some bleeding, which, as I said, makes our work every time a bit harder. And the more you are doing different stuff, so then you have the problem that with the bleeding. But I think we could manage. We have.
Just as a matter of interest, Arno, what's the blood pressure?
I don't dare to say. So this is a.
Oh, don't you? All right.
Yeah. So it's the blood pressure is 140/82. So
that's okay.
That's okay. Yeah, but I enjoyed the discussion about the blood pressure yesterday because are you aware of any trials which have somehow assessed how the blood pressure affects bleeding? So I basically have of the opinion that
sorry.
I think, Arno, it's not so much the hypotension that matters as the lack of change of blood pressure. I think if you have a constant, even blood pressure, that's important. But I'm not aware of any research on the subject. All I'm aware of is my anaesthetist always told me that if your patients were fit, that's ASA, American Society of Anaesthetists 1 and 2, hypotension was not a great concern. But certainly in patients who are not so fit, it's a problem. I mean, I don't know what it's like in Finland. I mean, you guys spend your time thrashing yourself with birch twigs and jumping in cold water. Yeah.
John, let's focus on the insertion and then we go to Hanover.
Yeah, sure.
So now we make the measurements, and here you see we have electrodes, 3 electrodes in, and now the patient basically tells us whether she can hear the sound or not. Anna Imo. And as you see that I'm a bit busy with, so she hears it, and we make the electrocochleograph measurements at the same time. Anna Isampi Imo. So I'm a bit, not just a bit, but I'm really annoyed with the bleeding here. So I have to try to control it here outside the posterior tympanotomy. So, and I will proceed with the insertion. The patient says that she hears the sound. And now I go a bit further. So, and now, and she hears the sound still. And from measurements, I have came to the conclusion that we will end up with a partial insertion with about 2 or 3 contacts outside the cochlea. And the concept of partial insertion is I think very, very good, because you can really push it further in case the hearing will deteriorate, because there are studies about the long-term results of hearing preservation, and all tells the same story, that in a time span of 10 years the hearing is gone anyway, and but in this case the patients really can benefit can benefit from the electric acoustic stimulation, but this is just, you know, for a transition time, so to speak, and therefore I'm not so comfortable in inserting short electrodes. Does that make any sense to you?
Yes, it does make sense. But then, even if you don't do a full insertion, because you leave some electrodes out, isn't that a negative point either?
There are studies which show quite nicely that if you have 8 active electrodes in the cochlea, this is usually sufficient. Then you get a saturation effect. So this is what I have measured for this patient is the cochlear size, and then also the length of the electrode, and usually for hearing preservation you end up with an angular insertion depth of 300 degrees about, and for 300 degrees I would like to see 9 intracochlear electrodes. And
okay, that's clear.
And now we are going further on. So now we have about 1, 2, 3, 5 electrodes outside, and the patient hears the sound very well and clearly. Yeah,
that's amazing that your patient is awake. I know.
You see when we are stimulating, you see actually the stapedial reflex here. If you can, Pia, can you do the measurement again?
It's measuring at the moment, but I can do it again.
No. Let's go.
But we don't see the camera. We don't see the stapes. We don't see the stapes.
Oh, sorry.
We don't see the stapes.
Sorry. Now you should see the stapes tendon.
No, they give us they give us the screen, so we like to see the surgical image.
Okay, so can you switch to the surgical image? It's hard to see, but I can see it. Okay, and then can we go?
No, we
further?
can see it. We can
Yes.
see that. We can see it on the reflection of the head of the stapes. We see the
Okay.
change. Yeah.
Great. All right. Gotcha.
Joo,
Oh, oops.
ja sanokko pysähyt?
So this is what you shouldn't say under local anesthesia. Never say oops. All right, now we have it's about it. So we have 3 electrodes outside the cochlea, and still the patient says she hears the sound very well. So I will try to go as deep as possible, as deep as possible, to have obviously as much electrodes inside. But when the patient says now the sound it's getting quieter, then I usually will retract it a bit. And now when the patient speaks, you can also see the stapedial reflex actually. Now she's speaking. And all right, Hyvä.
Response is a bit higher than before.
All right.
So how many extra cochlear do you have at the moment?
4. I will go a bit deeper.
Okay.
You see quite nicely how the steepest reflex. And still I'm struggling here with the bleeding, and this is kind of multitasking right now, that you have to have the whole whole operation view under control, that it doesn't get spoiled with the bleeding. So
no, that's clear. Arno, I think this is what you wanted to demonstrate, isn't it? Or do you have some other?
That was the point. Yes.
Okay.
But now I just a small hint for the trainees. Now I'm proceeding the posterior tympanotomy, and now I have to let loose with this forceps. Nice. Otherwise, I will have it stuck inside the posterior tympanotomy. And just as a tip for those who are trainees.
Okay. Arno, I need to go to Hanover because I think they're quite far. If there's anything, just let us know, either via phone or whatever. And otherwise, we'll see you later on today. Thank you very much. Very impressive, and please thank your patient because it's very nice introduction. Okay.
Okay. Thank you. See you later.
Hello, Wilco.
Hi, Tom.
Hello.
Professor Leonard.
So, good morning. Hello. So we have here a lady. She has da drüben, wenn Sie es drüben lassen bitte und das zeigen. Ne? We have a lady. She is already implanted on the left side. Now she has progressive hearing loss on her right ear. Können Sie sehen, oder? Yeah. And so she has. Okay, now you can see it. So she has basically left side, that is the aided threshold on the left ear. On the right ear, she has acoustic hearing, so it's very low. But you look on the speech audiometry, it's interesting that she, with hearing aids, still does something like 40% or 35%, even though the threshold is very poor. But that's how it is. And now she is under 50% monosyllable, so that's an indication criterion to give her an implant. And here we want to use an AB implant, Advanced Bionics Slim J electrode. Her CT scan and MRI look normal. There is no pathology we can see in it, and so now I realized here in this case a very narrow posterior tympanotomy. You will see in a second, and just to show you, I had to uncover the facial nerve, unfortunately, and also to cut the Corda because I had no chance. Bitte mal den Aufstecksauger. Ich gebe Ihnen das mal 1-0 to really get access to the round window. And even with this, I think the nerve now is protruding, which I don't like, but that's how it is. So I want to go higher magnification and see that whether we can see the round window, which you see the nerve is here. I uncovered it and it's just visible, the round window.
You can see that quite nicely, Thomas. That's a good view.
And the corda somewhere was here, but I had no chance to preserve it. No? So now we have here, see the round windows is in this perspective is a bit better, but you see only by uncovering the facial nerve, I was able to somehow to see it. No? Yeah. Here's a bone slit. And okay, now we try to also use here the robot hole system for the insertion of the electrode. And Mr. Barra from Colin manufacturer is here. So well, you see here, we have now a tip. Let me check that I can visualize it. You see here the instrument. It's like the tip of this holder for the electrode, and it's like a fork at the tip.
It's a little bit long.
And this tip will then take the electrode wing, and then we can fix it with that once we insert. So now the next step is that we probably have to position pre-position the system, and so I have to do some movements here now, and which is, I think it's like a mouse pad I have here, or like a space mouse, and I have a control pad. So now I can use, for instance, and I can rotate the tip. Perhaps you can see it, that I now can rotate it, and also I can, so to say, pre-position how it should be. I hope that we still have enough, so to say, freedom for movement. And now I can look for the possible best trajectory. So I now have to somehow advance it, and move it forward, so you can pre-position the fork, so to say, right over the. I will go up in magnification.
Thomas, you change this with the mouse. It's like you with a mouse you control the tip that we're seeing right now.
Kann ich nicht. Sorry. Yeah, we will try. We will try our best here to visualize. And so I think it's a French system, and so we now also work with it here, and I think it's well done. I heard that probably it was developed over, I think, something like 15 years to make it. So I try to pre-position it now over the as close as possible to the round window, and then we can, so to say, then memory this position, and then we move it back. I so to say, clamp the electrode in, open the round window, and then we can try to insert it in this trajectory, you know. So it's just so perhaps this could be a good position. I don't know, Mr. Barra, whether this is okay. It's still good. Okay, good. Here, and then we block everything and can be and move it out. No, so now we move it out. So I hope it will do that. And so then I hopefully can. Well, I think I have to do one thing more, which is probably to. Also, I have to. You see, it's a kind of it's a bit to play around with that system, but I think that's what robots are. They basically do what you tell them, but you have to tell them. So I think I will block everything now and try again so that I can see whether it moves now back in the right position. But we have to move it up a bit more. Okay.
And Thomas, the robot is just on the wheels in the OR. Are you not afraid that anybody will bump into it, like what happens all the time?
So it's okay. I think now we probably have quite good position. It could be. It could work like this. Okay. So now I try again. It takes some time until you really can adjust it. Then what you also can do, we can change the speed of insertion. It's now sort of normal, as it's called. Now I can also go for very slow movement. So for instance, for insertion, you see now this is the speed for insertion, very slow, very even. Yeah, you see, so that's what we want, kind of controlled movement. And for pre-position, you can speed it up. No? Okay, so that's, I try to, still we have to correct it in one more. Well, that's, I think, our learning curve also we have here, so it should be okay now. Good, so then I probably will fix the electrode and then we can try to insert it. Können Sie mal, ja mal hoch, mal ja, kurz einfach so, also hier einfach vorne nehmen, an den nur ein Leser, ja genau dann. So, this is, so now you see here the fork, and I try to fix now the electrode into it. So hopefully we will succeed with this. Aber wieder meine Pinzette. That's basically that we could fix it here in the wing and try to, zweite Pinzette bitte. Mhm.
So we know from one of the polls we've done that most of the people watching are not cochlear implant surgeons. So would it be possible just to talk about why it's important to get a smooth insertion with the electrode?
Yeah, it's we try. First, let me check that I get it in. I hope that I can really fix it here with the wing. It should be like this, and I'm not sure whether I already have done it. So. So I still can correct it. Yeah, it's what we want to do is, I think it's everything is here under development. It's not, I think, yet completely developed to how we should want to have it. I think we need some improvements of the whole system, that is for sure. One thing is the even movement should allow us to reduce the trauma of insertion. Whether this is possible, we still have to prove. It's not 100% clear, no? But the speed of insertion, and also to avoid some strokes while you inserted are very important. So Dr. Rau from our research group, he has worked intensively on the speed of insertion and the importance on the forces that are created. So I hope that I've been able to bring it on. So otherwise we have to play around a bit more. It's quite tight. I would love to have more a clamp instead of that, but it is as it is. So now we can basically try to correct the position a bit more, bring it into the, I still can move it back. That's what I understand. A bit more out so that the tip is free, and then I can open the Cochlea. Müssen erstmal die Instrumente wieder zurückgeben. Okay, so it's not very comfortable for the surgeon, but anyway, we want to see that it is possible. We also will try to measure somehow the microphonics in this patient, but first thing is that we open the inner ear. Ich bräuchte dann mal dieses, geben Sie bitte mal ein Häkchen. Okay, so now, gehen wir mal mit den kleineren Zauber. Danke. So we can see the round window now again, and I will try to make an incision. Bitte mal die Kanüle. Die ist zum Einschneiden, ne? Danke. Okay, so let's see whether it works. I'm not, don't know, but we try it at least. Okay, dann bitte mal eine Kanüle, eine Pinzette. So now I try to position the tip of the electrode in front of the round window. And I think I have to go to low speed. And then also to, klar, jetzt geben Sie bitte nochmal eine Gabel, wenn Sie haben oder sowas. Also auf dem Tisch, ne? Was denn die Gabel? Diese Dinger. Ja, alles klar, danke. Okay, gut. Let me check. So now. So now I move the electrode forward. Just to give you a better view, I have to change somehow the view. So now I just hold it here with the fork. And now you see how it's moving in. So very even movement, no? Okay, good. So now I have to detach. I also could pull back, you see, if I want. If it's too deep, we have a blue marker right down there. Und jetzt brauche ich bitte mal eine Pinzette.
Pulling it back seems a bit counterintuitive if you're trying to get a smooth insertion to reduce disrupting the fluid dynamics.
Sorry, I was too soft, your question. Können wir ein bisschen lauter stellen, den Lautsprecher, bitte?
Just ask a little bit louder, Emma. He didn't quite hear you.
Okay, so now we have detached it. And now I will hold the electrode and pull the system back so that I don't pull out the electrode now while I move it backward. But I haven't heard Emma. Sorry for not being able to take the question.
Can you hear me now?
I can hear you better, yeah?
So I was just asking, you mentioned you might pull it back a little. Does that interfere with the fluid dynamics? Because surely the purpose of the robot is to get a very smooth linear insertion.
Yeah, I think the point is that, of course, you have to make the opening large enough, no? So that you always have an extrusion of fluid while you basically insert the electrode, so that you have the possibility of the fluid coming out, no? And that is a major point, no? With it. So we then, of course, with a slow, even movement, we should avoid any, let's say, rapid increases in intracochlear pressure. So that's probably the most important thing. Yeah? What we can if you look on your hand while you insert it, and even if you are very good, but specifically made for that purpose, and I think it's very good. Yeah, da steht es immer, thanks Professor for the opportunity to very good surgeries, and okay, thank you. Okay, well, that's what we have to show here. I think otherwise was everything uneventful, and we will do our regular measurements now and close. No? We'll go.
Yes, that's very good, Thomas. But we would like to stay with you a little bit more, unless Naples is ready to show their feature.
Okay, so then I think we do some measurements. We can try for the, können wir die Microphonics da einblenden with us? I don't know whether we haven't now looked for Microphonics, but I think we can try, even though it's very little residual hearing. And so we get some response, I think, already shown in here. Perhaps we can again, no response, huh? Okay. So can we see the raw signal? Is that possible? And okay, now you see these are there is the raw signal while we stimulate in the outer ear canal. And so you see here there is a kind of loudspeaker in the outer ear canal. Just here an insert phone. Yeah, just nearly visible. Okay, and so we stimulate acoustically. Sorry, while we and then we just try to get some responses from the cochlea. And what we see now here in the screen is the kind of the response. You have this one bump. I don't know what that means. Können Sie noch mal messen, damit einfach fortlaufend? So normally we can do it through insertion, but here we did it now just to show the Robotoll.
Yes.
And
it's very, very.
In fact, yeah, and probably there is not much to see, but you see the residual hearing was very little.
Yeah.
So I can't change that now. No.
No.
Now this is acoustic measurement. Now we do the electric measurement. Müssen wir da irgendwas wechseln oder können wir das? Die Spuren tauschen. Okay. And now we go for check the implant function. Which means just to measure the NRTs, the nerve neural response telemetry. Haben Sie Verbindung? Yeah, okay. And then I don't know whether we can connect this. Geht das vor Banamo? Ja. Okay. Vorsicht ist. Es ist einfach gehen, aber Banamo gehen so lange. And so we try to get some neural responses. So now in terms of the facial nerve, I have created this this bone notch, which is out of this area where the nerve was uncovered. You see, it's just
in the center, yeah.
Below it.
Yeah.
Is below it, so that we hopefully have no direct contact with electrode on the nerve. No.
And Thomas,
okay.
I know, okay, like in Finland, they did a nice procedure under local, also for.
Yeah.
I know you've done some local cochlear implants as well.
I think the next patient should be like that.
Okay. Okay. Because it's a very interesting discussion, of course, that you can ask the patient to respond to the hearing, etc. live.
Ja. Ich glaube, den Robotoll können wir zurückfahren dann. Okay, now what do we see here? Oh, sorry, now can you, it's the Pedis reflex. So, können wir ein bisschen zurückfahren, erst, dass wir sagen, dann haben wir das schon mal außen. Okay, now we can try to look on the stapedius muscle, the tendon, whether we see some reflexes. So ein bisschen höher, glaube ich, oder sowas. So they always stimulate in group. So you see the first 4 electrodes, and we have to look here on this, whether we see some movement here. Mach mal bitte. Da kann ich nicht sehen, nein. Nein. Nein, nicht. Ich würde sagen, gehen Sie mal auf, noch konnte ich höher gehen, ob wir was sehen, weiß ich nicht. Nein. So we can't get responses here. Well, ist auch nichts. Okay, so bitte mal die Nadel leicht geschwungen. Ich will dann einfach, wenn Sie nichts bekommen, auf NRT gehen. Probably the status is a bit fixed. So no, it's okay, it's moving. Okay, I think we go to NRT and NRI and see whether we get neural responses. I think we have something, or do we see some responses? Where do we see them? Wo sehen wir diese responses? On right? Okay, here. No? Okay. A bit higher in stimulus level or so. Verbindung haben Sie noch, ja? Ja, es könnte sein, dass das Gehäuse noch ein bisschen freilegt. Ja, ein bisschen flüssig, ein bisschen Wasser mal bitte. Aber könnte sein. We hope we can see something, huh? Suspicious that the electrode is not in place, huh?
No, I hope not. But well, we see the status, but we have not seen the movement yet. No.
No, we haven't seen it. But this is now on the. So, jetzt gehen Sie mal hoch in der Intensität.
But I know you at one point also did intraoperative imaging. Do you still do that?
We will do that, definitely. So, jetzt wollen wir mal gucken, ob wir da irgendwas kriegen. Das kann nicht sein. Können Sie das noch ändern, was Sie da im kleinen Moment mal? Ich muss mal die Schere mal bitte, dass wir das mal wegtun. Dass die Spulen, ja, dass die Spulen sich nicht da berühren. So, ich halte es nochmal drauf. Jetzt machen wir nochmal bitte. Und kann man das denn nicht anders darstellen, diese ganzen oberen Dinge da, oder ich weiß es nicht. Yeah, no responses, so we have to check what it is. So we have to. Und diese Pulsbreite, kann man das irgendwie verbessern? Oder? Ah, okay, gut, dann gucken wir mal weiter, ja. So we get no responses so far, so we have to check. But I'm sure that the electrode is right in position.
And of course, your anesthesiologist doesn't use any muscle relaxants or anything.
No, it's not. We don't measure the muscle. We just measure the NRT responses.
I thought you were still looking at the stapedius reflex. No, sorry.
No, that's what we gave up, so to say. But well, we will check. Muscle is on the reference electrode. Is also here. There's one here. Now we get one, huh? Ah, okay, so this was 11 or so, okay. So we have a response from one electrode. Is that true so far? There is something? No, not very much. No, okay, not at all. So we are not satisfied with that. No, that's not satisfying. So, okay. Good, yeah, but we only can take it as it is, no? Okay, and then we close and see what we will get, no? Bitte?
So, Thomas, do you agree if we do some messages from our sponsors, or do you want to stay connected at the moment?
No, what we do is just that we close and make an X-ray and see what's on. No? Sometimes you have it that you don't have responses. Okay.
Okay, then I suggest that we start a little bit with the sponsors that make this all possible. And please tell us later on what the imaging resulted in.
Okay.
Yes,
Good,
maybe
you.
Wilco, if I can say something there to the audience. As you probably may have gathered if you watched yesterday, Lion is a completely non-profit making organization, and we are totally dependent on our relationship with the industry to produce this type of educational material. None of the moderators or surgeons associated with Lion have any financial interest in any of the companies. So we would appreciate if you'd stay online and watch these educational videos that the companies have produced. They are extremely good. Thank you.
Yes, that's one thing. And the other thing, I would say, we also see Thibaut Dubon. We will go to Thibaut after the message from the sponsors. But also, please don't feel shy. If you want to ask a question on Facebook or on YouTube, be our guest. And it's very likely that we will send the question to the surgeon if possible. Okay, thank you.
Since Graham's encounter with a seashell on a blade of grass in the 1970s, and the inspiring discovery that brought the first multi-channel cochlear implant, the cochlear story has evolved. From an ambitious endeavour to a life-changing partner on the journey back to hearing. Our people are driven by this same dedication today and have helped transform hundreds of thousands of lives. This shared drive to do life-changing work is inspired and influenced strongly by our beginnings, while being motivated by the energy of our people today and everyone we partner with, and always guided by a clear, simple truth, that our position to connect people to a life lived with hearing is nothing short of a privilege. So we'll keep listening and responding to bring implantable hearing within the reach of those who need it.
Otoplan is a revolutionary tablet-based otological planning software. Quickly and easily import DICOM files from PACS or USB drives. Intuitive controls makes it easy to master Otoplan's advanced features. Otoplan's guided workflow simplifies 3D modeling and surgical planning. Easily create 3D reconstructions of otological structures, including facial nerve, chorda tympani, and more. Otoplan lets you see exactly where you are going before you make the first cut. Otoplan makes it easy to achieve an ideal view of the cochlea and make consistent measurements. Choose the ideal electrode array for each patient for best hearing outcomes. The electrode visualization tool uses patient-specific data to show insertion depth and covered frequency of each electrode contact. Otoplan makes it easy to discuss the ideal electrode choice and surgical considerations with your patients. One-step export feature automatically generates a full case report in PDF or PowerPoint format. Otoplan's post-op analysis feature makes it simple to perform a quality check and verify insertion status from post-operative images.
reference electrode on the implant casing, as you can see here. And in this model, you can see in red all the current flows. And it has been measured that only 14% of the current returns via the modulus. It means that all the rest of the stimulation current lines are passing through other directions, and it's bigger risk of facial nerve stimulations. So stimulation modes can be, I would say, separated into different categories. We just mentioned the monopolar stimulation, the monopolar mode, with only one return electrode that is extracochlear. And that leads to a broad stimulation, but with somehow a high efficiency because all the charges are crossing the cochlear tissues. On the other side, we can propose intracochlear stimulation modes, type of stimulation mode, where in that case, all the return electrodes are intracochlear. So that's the case for tripolar stimulation, bipolar stimulation, but also common ground. It's a quite old stimulation mode from the 90s. What we would like to suggest here is that there is a third way, is to combine both with intracochlear and extracochlear return electrode. In that case, these modes were referred in the literature as being partial. And especially, I would like to emphasize this one is the partial tripolar with two return electrodes intracochlear, one on each flanking electrode of the stimulating one, and one extracochlear return electrode as well. By combining intra and extracochlear electrode, then we can reach to a very nice compromise in terms of stimulation and in terms of focusing the stimulation. The Oticon medical stimulation mode, referred as distributed all polar, combines a different way of recapturing the current by using all the intracochlear electrode and one return electrode that is extracochlear. So most of the charge stay inside the cochlea, thereby reducing the risk of extracochlear stimulation. But some are flowing back to the reference electrode that is outside of the cochlea. So it's designed to optimize the accuracy, precision, and the safety of the stimulation. So if we are back to these different families of stimulation modes, our stimulation paradigm would be in the combine with all the electrode intracochlear used as a return electrode plus an extracochlear reference. If we say a few words about the pulse shape, so this pulse has a great interest because you have a first phase that is activating, that is stimulating, an active phase with a positive stimulus that delivers the charge efficiently to the auditory system, and a second phase that helps to recover from the positive charge that is non-stimulating. And thanks to this non-stimulating phase that has a small amplitude, all the charge are recovered, so for the safety is ensured, but it's small enough not to stimulate the auditory nerve, designed for safe stimulation. So the pulse shape allows for more efficient stimulation. This allows to have lower C levels if you compare this pulse to biphasic square pulses, and lower charge injected means reduced risk of facial nerve stimulation again. The triphasic pulses that some of you may have heard and may be used in their clinical practice are inspired from that idea. However, that introduces limitation on the stimulation rate and is also can lead to higher power consumption than our stim shape. So just to conclude briefly, the neurocochlear implant system stimulation parameters has critical features to reduce non-auditory stimulation, such as facial nerve stimulation. Firstly, thanks to the stimulation mode, the distributed all-polar stimulation mode reduces a lot the extracochlear stimulation. We mentioned 80% at intracochlear, 20% extracochlear. So it reduces in comparison to monopolar with lower risk of non-auditory stimulation and designed for focus time and charge efficiency. And at the same time, the pulse shape with non-stimulating charge recovery phase increases the stimulation efficiency so that lower charge are needed compared to biphasic square for similar T levels that further reduce the risk of non-auditory stimulations. Thank you very much.
So, John, I see you're looking on the screen actively. Very good. I just got a message from Naples where Dr. Antonio Della Volpe is doing surgery on a child, a cochlear implant. And so we now go to Napoli. And John, you please take it away so I can focus on some other stuff. Antonio.
Okay, Rico.
Oui.
I just performed the surgery. I performed a combined approach because the space is very narrow and is a very young child. I performed the tympanotomy and I performed cochleostomy through the air canal. Now I'll show you better with the big.
Very good. And if Emma unmutes, Emma can ask some questions as well. Yes.
Look.
Very good, Antonio. Yes.
And I removed also the incus because the space is very narrow and it was not possible to perform cochleostomy. In this case, I performed cochleostomy in the right direction with the right axis through the air canal. I think the advantage of this system could be the big magnification in this situation. You can check everything, focus and magnification through the movement of your head. Look, this is a focus.
It's huge magnification. Eh? It's very, very strong. Yes.
Look, it's especially very useful in the last part of the surgery when you have to perform cochleostomy, especially in situation you have a complicated cochlear, complicated sound malformation because you have a good view, just you can see of the cochlea, a perfect insertion of the electrode array in the cochlea.
So is this your approach of choice when it's difficult to access the round window or the promontory via the mastoidectomy?
Yes, this is combined approach I use when there is a difficulty in the mastectomy, when the mastectomy of the young child is very spaceless narrow, the facial nerve is high. I prefer to take away the incus and I prefer to perform cochleostomy through the air canal because the cochleostomy through the air canal I think it's a better solution also for the inclination, the axis of the electrode to insert the array in the scala tympani.
Lovely.
Okay. Now it close with a small piece of fascia. Look. It's possible to have a better magnification. Look.
I must say, Antonio, this is a great.
This is a difference between the lower magnification.
Have you tried using this scope with other surgeries such as stapes and vesiculoplasty, or do you just use it?
I didn't try. I didn't try it before, but it's useful. It's also useful in other kind of surgery, also in plastic surgery, because you have the possibility to have a very, very, very small suture till 11 points of suture. You can use in paralectomy, so you can have a good view of the facial nerve. I try only in the. I am trying only a few days. I try till now until only cochlear implantation. the very important thing is in this case that you don't have to take away the head, the hands, excuse me, from the field, the operating field. You can modify everything with only with the movement of your head. Give me the piece of fascia, please. No, fascia, fascia, pezzetto che ho preso. Scusa. Poi dammi il... Spinge. I put this piece of fascia to close the cochleostomy. A small piece of spongus. Yes. Ma me lo c'è detto qua, mettiamo dopo. Let me give me the piece of spongus.
Are you putting spongostan in the middle ear because you've lifted the eardrum?
Yes, yes, exactly. Exactly. I put a very small piece, just like in meningoplastic. No, it's top, very small piece, please, to avoid the contact between the fascia and the eardrum.
Have you tried any other techniques to access the round window when it's out of view via mastoid? Have you ever removed the posterior canal wall and put it back or reconstructed it? Or do you ever do a blind sac?
No, I don't use the access by round window because in very young child. This is a 4 years child, but usually we perform surgery in a child at the age of 11 months. In that case, the access to the round window it's too much complicated because we are the facial nerve, and in this case you can't perform a very large posterior tympanotomy. But the results usually between access, in my experience, but there are some publication about this. The results, I think, it's just the same between cochleostomy and round windows, of course, in case of bilateral profundity loss.
Antonio, we know that you were hit very hard by COVID in Italy. How much did this affect your pediatric cochlear implant program?
From 2006, we have in Italy the universal screening for newborns. So from that data, we have many patients arrive to our center at the age of 2 or 3 months. And in this case, so we had a lower age of implantation. We did an interesting job with an interesting article with Wilco about the age of implantation in different children hospitals in Europe. At that time, our age of implantation was about the median age was about 4 or 5 years. Now the median age is lower, about 1 or 2 years old.
Right, and Antonio, I didn't understand. Did COVID have a big effect on your operating on children?
Excuse me, I understand. Excuse me, I don't understand. I can't help.
Yeah, okay. Did the COVID epidemic have a big effect on the surgical program for children in your hospital?
Okay, we didn't have a big problem because till now in Italy, but all over Europe, the children didn't have any problem about COVID. Our hospital is the children hospital, the biggest children hospital in South. We didn't have many patients with the COVID. We had about, during this year, 60 60 patient with COVID. Any patients had a very important aspect of the disease. They have only fever and sometimes cough. So we didn't have the reduction of our patients about our program for cochlear implants.
And no problems with staffing because of your nurses and your anaesthetists and your trainees, were they okay?
Yes, maybe. Yes, the most important problem is just this. Some problem about nurses, doctors, and the organization. Yes, it was possible, but all of us, of course, from January, we have vaccination. And from that time to now, we had only few docs, or 1-2 nurses that had the positive to COVID, but without any disease.
That's quite interesting. I'm just going to ask Emma, who's the other moderator, whether they had any problems in Manchester because of COVID,
Yeah.
or whether they were able to continue operating.
Yeah, so most UK centres drastically had to cut down their elective operating when COVID hit because our operating theatres were used for emergency cases, cancer cases, and for ITU capacity. We continued to operate on urgent cochlear implant cases, but as a result, our numbers dropped, and we now have a backlog of cases that we're desperate to start operating on as soon as we're allowed to do so. So we're hoping that pretty soon we'll get lots of lists to start doing more elective surgery.
Yeah.
And that brings up a really interesting question as to how elective cochlear implant surgery is. Certainly, I've got a very good academic trainee who's done some qualitative work on how the.
He doesn't understand what you're saying.
Excuse me, but
That's a
yeah,
shame.
I don't have a good sound.
No,
What's the question?
No, the question is, actually, that's a nice discussion. Of course, during COVID, the question is what's elective and what's not elective. And I think what Emma is trying to say, at least Emma, correct me if I'm wrong, is that, I mean, of course, cochlear implant is to some extent elective, but if you don't implant in time, the damage is permanent.
In
So
fact,
it's not that elective.
I agree absolutely. I don't think it's selective cochlear implantation, especially very young child, because if you are to delay the implantation, the results will be so good, just like if you perform implantation during that time. In our national health service, cochlear implantation is considered not elective, but an important surgery to do in this period.
Of course, because the damage is permanent if the auditory pathway is not developed in time.
Yes.
Antonio, can you see the screen? Because there's a question from Spain, from Jose
yes.
Andrade. Can you please answer it? And then we will need to go to Béziers, because I see that Thibaut Dumont, the clinicos, is progressing nicely. So we need to move on. Can you answer the question that he's asking?
Just a moment, I can't see the question because I abbiamo leggito la domanda, per favore.
I will tell you, when the facial recess and the round window position is not favorable, isn't a cochleostomy still a good option? Because, you know, some years ago,
the option is just in this case, the option is a combined approach. We published something about this. We prefer to perform cochleostomy through the air canal, because in this case, the angle between the posterior tympanotomy and the round window was not a good angle. So you can, in this kind child, you have the possibility to wrong the direction of the cochleostomy. Yes. There are only 8 millimeters from cochlea to the tuba. Of course, the tuba and the carotid artery just is in the inferior part of the tuba. If you go straight, you can arrive there. Of course, you can see, but if you perform from the air canal, you have a right angle.
Yes, yeah, I agree with you. Maybe you should look up in literature. I know someone that published about the hearing preservation as an example on the differences between cochleostomy and round window insertion.
Yes.
I believe his name starts with a G and ends with man. He published something about this and also about different approaches. Antonio, very nice. Thank you very much. And very impressive microscope. Very nice. Do you have another case for us later on, or is this the only case that you're going to do today?
Thank you. No, it's the only case.
Okay. Okay. Well, thank you very much. We need to go to France because France is contributing as well. Thibaut Dumont is doing surgery. Emma, I leave the moderation up to you now to put you on the spot. And Antonio, thank you very much. Parliamo subito. Bye.
Okay. Bye. Prego. Ciao.
Ciao. Thibaut, we are now with you.
Yes.
Hello, Thibaut. Good morning.
Do you hear me?
Yes, we can hear you. The sound can be a little bit louder if you like. That would be nice.
Tu peux monter le son? Okay.
I'd like to introduce to you Emma Stapleton, and Emma Stapleton is an expert in England on this kind of procedure. Emma, here you go.
Okay. So I remind you, remember the case. It's an apical cholesteatoma in a young man. He was operated on the other ear in 2017 for cholesteatoma. And here he has an apical cholesteatoma with, at the pre-op audiogram that was performed yesterday, 40 decibel mixed hearing loss with 25 decibel airborne gap. So the indication is to perform a canal wall-up tympanoplasty to remove the cholesteatoma. I started it, and it is not possible to remove the cholesteatoma with the intact chain. And so I approached the middle ear, then I disarticulate the stapes from the incus, and I separate the pars tensa, which is intact, that I want to keep, from the cholesteatoma. That means I make the incision of the tympanic membrane along the malleus ligaments, posterior malleus ligament. Then I cut the neck of the malleus. I cut the tendon, the tympanic membrane along the anterior malar ligament. And so I will keep intact the pars tensa on the right there and remove the cholesteatoma in the attic there with the incus and the head of the malleus. So I perform a canal wall up mastoidectomy. It's a very sclerotic mastoid, and here you can see the cholesteatoma that really you cannot remove with the intact chain. So I now will remove the big part of the cholesteatoma, and after that we will finish the atticotomy and remove all and polish all the attic in order to prevent residual cholesteatoma.
Emma, are you still with us?
Yeah, I'm definitely still with you. I'm admiring this lovely combined approach and the explanation that we've been given about accepting that the articular chain is involved and making things safe before proceeding to take the cholesteatoma out. I think that's lovely.
Could you please repeat your question more slowly, because I didn't understand you.
I've not yet asked a question. I'll see if any come in.
Okay.
Emma, I think the natural thing is because it's your native tongue. Some people have some issues understanding the speed of language.
Okay, I'll slow down.
Hello?
You can see that with the removal of the bigger part of the cholesteatoma, we have a much better view of the attic, and
yes,
you can see that with the combined approach, we will have a complete exposure of the attic.
with Franz for 4 minutes, and then I come to Hanover. Okay.
Wilco, you're making you're coming. Mute yourself. Yeah.
Yes. Thank you, John.
Alors.
So one of the things I teach my trainees is that when they're approaching a cholesteatoma, they have to be thinking about how they're going to put it back together at the end. Have you already made a plan for your reconstruction? Did you get that?
And so in that case, I continue to remove the cholesteatoma from the arctic, and then I will continue through the auditory canal and perform a posterior tympanotomy to have a complete control of the cholesteatoma. Hop, malade vers moi. Hop, stop.
Thibaut, I think what Emma was saying there, I don't know whether you got it, was as you go into battle with a cholesteatoma, are you already preparing your plan of how you're going to reconstruct? Or is it a decision that you make right at the end?
No, I will reconstruct. The project is to perform a canal wall tympanoplasty with a port prosthesis. I will use a new Medel port prosthesis. And in that case, the ear is very infected, and so I will not perform mastoid obliteration because the risk of infection of the obliteration is too high. I will perform a canal wall tympanoplasty without obliteration. And so,
that's interesting. You're going to use a new prosthesis. Is that one that you've been involved in designing, or just one that you found is very good?
Yes, I'm just starting to use it since a few weeks, and then seems to be very good. I will show you the prosthesis. Because of the infection, the surgery is quite bloody, not very demonstrative during the removal of the cholesteatoma, but I think for the reconstruction it will be good. Alors, and the best is that you come back for the tympanic membrane and ossicular reconstruction. Alors, voilà, vous allez me donner le micro-ciseau.
Okay, Thibaut, we need to go to Hanover for a moment because they want to show something, and after that we need to go to Austria, but we will be back with you shortly. Okay, bye-bye. Okay, Hanover, as requested, we're now to Hanover.
Nein.
Hello. Hanover, hello.
Yeah.
Yes.
Hi, can you hear me?
We can hear you fine, yes.
Yes. Okay, we just performed the a cone beam computed tomography imaging to verify the intracochlear position of the electrode. And as you can see in this scan, you see the marker contact on the position of the posterior tympanotomy and the first electrode here at the round window. And in this imaging, you can see that the AB electrode is perfectly sitting intercochlear or has a perfect intracochlear position.
Do you do routine intraoperative cone beam CT?
Not routinely, but in case of, in children, of course, children until 8 years old, and when we are not sure about the intracochlear position of the electrode intraoperatively.
It's very nice imaging.
It's
So
a-
that
it's
takes
another
away
image.
the question, because there was only one NRI or NRT response in this patient.
No, there were no NRTs, and we think that maybe the program we were measuring with had any issue.
Okay. Well, good. Well, I mean, it's very reassuring to make sure that it's well placed and that there's no issue with that. Good. Hanover, thank you very much. We now go to Austria, to a new site. And as you know, John, you can pronounce those Austrian names much better because you've been skiing all the time. Can you please tell us what the name?
Well, it's a great pleasure to welcome our new Austrian colleagues, George Sprindl, who is at St. Pölten in Austria, and Stefan Edlinger. And the image we're seeing doesn't look like Stefan Edlinger or George Sprindl. Far more pleasing, I have to say. Would you like to introduce yourself from Austria?
Okay, you scared them away, John.
I have, yeah.
I need to read out them. I don't know what they did, but we have definitely some connection issue with Austria at the moment. Let's see if it happens.
Okay, well, as I was saying, it's the first time that that Austria have connected with us, and it's fantastic to have them on board. Can you hear us, Austria?
No, they can't.
Can you hear us in St. Pölten?
Well,
I don't think they can.
I think let's check.
The lady's very good at maintaining a nice smile.
Yeah. Well,
Can you hear us in Austria?
She worked for television.
Can you hear us? Talk to us. Talk to us.
Okay.
George, are you there?
Okay. Hold on.
Right. Well, George is obviously going to do a cochlear implant with a CI Flex 24. And I know that he's got some very nice equipment from the emails I've had.
And Gerald,
so hopefully this.
Gerald, it says that you are muted. I mean, your codec, not you, but it tells us that I think you can hear us, but we do not hear you.
We can't hear you.
Of course, then again, we can keep John babbling for a while. Come on, John, continue. Okay. Okay, there he goes. He goes into the. Come on, John.
We've got some more poll questions we can put up.
Okay, well let's run those while Wilco's getting the connection.
Oh,
I don't think the audience perhaps. I don't think the audience perhaps realise how difficult it is to cope. You just saw that screen there, and those are all the lines that are coming in.
No, that's not me at all.
And
that's
as an additional problem, we have up to 8,000 malicious attacks a day. So the whole time we're fighting with the firewall and to keep the lines open. But here are some polling questions. Perhaps those of you watching would like to answer those, and that'll give us an idea of what the lie of the land is. So Emma, what do you do with your patients? Do you perform cochlear implants under local anaesthesia, or do you favour general?
So I'm starting to do more under local, and that's because I had a number of patients who were elderly or who had heart conditions that made them unsuitable for a general anaesthetic. I've got a very good anaesthetist, and we have used conscious sedation very successfully. But I'm really interested in the fact that more and more people are doing it with just local and without conscious sedation, and the advantages of that. So that might be my personal next step with things.
Did you appreciate my comments earlier on about lying on an operating table? I've only ever had to do it once. It was for 4.5 hours when they broke the drill off in my finger. But have you talked to the patients about how it feels to lie on a table for probably 2 hours? Yeah.
That's a really important part of the pre-op conversation, is preparing the patient not just for their procedure that they're going to have and the feeling of the drill, but the fact that they are going to have to lie there for a certain amount of time. And that has other knock-on effects as well, not just for the patient, but for the entire team. So, for example, if you want to get an operation done quickly, it's less likely to be a training opportunity for your registrar or your fellow. And I certainly had a case where I did a bilateral cochlear implant under local anaesthesia, and my fellow got very disgruntled, but I didn't let him do much of it. But that was because we needed to move quickly to minimise the patient's time on the operating table. So it brings in lots of other things. But it's a great thing to start offering, and I think the general movement is towards offering it to everyone and not just to patients who have a general anaesthetic risk.
I think the comment you make about the theatre team being aware of the patients under local is really important, because it's inevitable that at some time during the procedure your gynecological or the urological or general surgical friend in the theatre next door will come in and say something entirely inappropriate. And that has happened to me several times. That's where a little bit of midazolam sometimes helps with a bit of retrograde amnesia.
Yeah. With cochlear implant patients, that doesn't matter too much because they generally can't hear the general chitter chatter that's going on. But it is still important not to.
Depends whether they've had both ears done. Yeah. So, Wilco, have we got any sound yet? Can we go back to George in St. Polten? You can see he's having a microphone held up to him, but I think it might be wise, Wilco, if we went back to Thibaut for a few minutes while this is sorted out.
Yeah, all right, we're working on it. Here's Thibaut.
Thibaut, it's John here. We're back with you. George Sprinzel in St. Polten's having some problems with sound, so if you'd like to tell us where you've got to, that would be helpful.
Okay, so I currently removed quite all the cholesteatoma. You can see lavage moi-même. And there is no more.
Have you got the right image, Wilco? This isn't Thibaut. Yeah.
You're so picky, John.
Yeah, well, I can recognise when a mastoid's open. Okay, Thibaut. Yes. So go ahead.
Cholesteatoma from the mastoid and the attic, and so you can see that.
It's a very nice mastoidectomy. That I'm impressed.
And then I have still to clean the stapes, point mousse. I can see here's the stapes head, the tensor tympani.
Just a little bit of skin there on the capitulum, yeah.
Yes, and the pars tensa that I kept intact for the reconstruction. So I will now perform a posterior tympanotomy to have a combined approach to the stapes and to finish to clean it. So
do you have access to the laser in your theatre for just a little blast on the top of that stapes, or do you prefer to do a manual removal?
I don't use laser for that. We have lasers, but I usually do it manually. I think in cholesteatoma surgery, the main aspiration 20 point is the quality of the exposure to avoid to let any residual cholesteatoma. And this is why, Petit Rosen, I will now expose the stapes through the facial recess. I can see here the tympanic portion of the facial nerve, which is there, the lateral semicircular canal, and so I will open the facial recess in that direction. Alors, fraise. Hop, c'est un peu gros ça. Vous allez me donner ensuite deux tailles plus petites diamantées. And it's the important landmarks to open the facial recess to perform the posterior tympanotomy are the lateral semicircular canal there, the fossa incudis. If the incus would be in place, the direction of the posterior tympanotomy is the axis of the body of the incus and the posterior wall of the auditory canal. I have to keep parallel to the posterior wall of the auditory canal, and the mastoid portion of the facial nerve is a little bit more internal than the fossa incudis. Alors, de l'eau, voilà.
We've been asking everybody, Thibaut, about the equipment they use. What drill are you using there?
I use the bigger drill that I can, and I progressively decrease the size, approaching between the lateral semicircular canal and the chorda tympani.
And what about the drills? What about the drill system? What system is it?
It is a pneumatic motor. It is a turbine made by Cavo. It's very Cavo, that's very reliable, and the pneumatic motors are very supple and more progressive than the electric one, in my opinion. I really like to use these pneumatic motors. And progressively from the fossa incudis.
Yes, I used to quite like the Hall Ostion, which was a pneumatic motor, and then they moved to the electric ones, which are very good as well. But I would certainly agree with you. I think one of the concerns we sometimes have with our trainees, we use all disposable burrs, is when they're first starting, they start with a 5mm burr, then ask for a 4, then a 3, then a 2, then a 1. And sometimes we have to say, look, in terms of healthcare economics, we would rather you went 5, 3, 1, because opening each burr costs 30 or 40 euros.
Yes, we use reusable burrs.
Yes.
And now I will approach the mastoid portion of the facial nerve. I think I will soon see it. C'est un peu surexposé. I will soon see it there. So I continue to approach it progressively.
Thibaut, do you use a monitor? Do you use a monitor? I can't hear one in the background, or do you not use a monitor?
In that case, no. I usually not use it. We have two nerve monitor in the clinic, but except for malformed ear or cases where the pre-op CT show high risk for the facial nerve, I usually not use it. But I think Benoit
Gratacap felt the same way, didn't he? Yes, yes.
Yes, but I think that the answer that was made in Munich yesterday was very good. That means probably we should take the attitude to use it for every case in order to prevent any discussion about this subject.
Well, I think as you know, we had a very famous colleague, Richard Ramsden, who retired a few years ago, who's still very active, and he always said if you use it for every case, you learn what the subtleties of the monitor mean, whereas if you only use it occasionally, it frightens you. And I think that's true. When I only use it occasionally, it goes off when I don't want it to go off, and it doesn't go off when I do want it to go. Emma will agree. Her generation have been brought up to use the monitor, and they become very confident and used to using it. Do you have a comment there, Emma, or is that fair?
So I'm personally quite comfortable not using the nerve monitor, but that's because of experience doing local anaesthetic cases and also working in low-income countries where they don't have a facial nerve monitor. But I do think it's a medical legal thing, isn't it? So
yes, I think so. Well, I think the argument is if you've got a monitor collecting dust in the cupboard in your operating theatre and you're operating without using it, the first thing that the lawyers will say is, why didn't you take it out of the cupboard?
Okay, John.
Absolutely.
John, I want to see if we can go to Austria. You have no idea.
Okay, Thibaut, we'll leave you for a few minutes. We're going to try see if George can hear us in Austria.
Can George hear us in Austria?
He has a frozen image now.
No, I don't think so. It's frozen. Yes, then we cannot do
George,
anything.
can you hear us?
If it's frozen, we cannot do anything about it, John. I've done my best.
Okay.
Oh, just one check. Okay, that works. Now it
Oh,
works.
no. Now we can see. Can you hear us, George?
We don't hear him. The volume is open.
Yeah.
Well, give us one because we did a lot of effort to get them connected. But if it's not going to work, it's not going to work. You know. Let me see.
I don't know whether he can transmit sound on a phone.
Yes, to whom?
He's got a microphone there, being held by his face. I can see.
Yeah, but I don't get. Do they get our sound? That's the first question.
George, yeah, they get our sound. We see a thumb there.
Okay.
So they're getting our sound.
This is a completely, I've routed them now via a completely different network. So this is clear.
Can we do anything with a simple telephone?
Well, anything
like Chris did last year. Yeah.
Gerald.
Should we go back to Thibaut while you try that?
Okay, let's see.
Okay, Thibaut, so we're back with you. We're still having sound problems with Austria.
Okay, so I am still enlarging the posterior tympanostomy phrase. C'est un peu gros ça, la taille en dessous. And at this stage, the suction tube is 1.5 millimeter. It is, in my opinion, the right size when I perform the posterior tympanotomy. Hello. And you can see that it's very inflammatory. Here is the tympanic portion of the facial nerve. Yeah. And I start to see the stapes head there. So I have to enlarge a little bit more. Alors, fraise. Hello. And to answer to the size of the burr, you can see that the suction tube is 1.5, and this burr should be a 2 millimeter burr.
There's a good question on the chat. Is it okay to ask now?
J'ai rien compris.
If you can hear me.
We could hear you, Emma, but we have technical problems over here to get a good sound connection to Austria.
Thibaut, can you hear?
Yes. Yes.
Emma wants to ask you a question. Okay, the other moderator. Go ahead, Emma.
Yes, but ask her to speak slowly, please. Yes.
So there's a question. There's a question about how you might.
I don't hear you now. It's cut.
No. Okay.
So the question that Emma was going to ask, I think, is
Yeah, I was going to phrase it slightly differently. I was going to ask
were you?
about.
Okay.
Well, I can
Go ahead,
I can
Emma.
deliver it to you, John, and you can deliver it to the surgeon.
Okay. Okay.
I think the interesting aspect of this is that the incus is gone, and yet he's drilling near the facial nerve. So the less experienced or the trainees watching might be wondering what landmarks he's using to know he's safe. What landmarks he's
Okay.
using to find the facial nerve in the absence of the incus.
Okay. So the question, Thibaut, is that
Yes.
you've had to remove the incus, but you're still
Yes.
drilling fairly close to the facial nerve.
Yes.
Now, I know that you're very experienced and you've done many hundreds, if not thousands of these, but what landmarks are you using to
Yes,
protect you from damaging the facial nerve?
Yes, I explained. So the first landmark is a lateral semicircular canal that we can see here.
Yes.
The second landmark, when the ossicular chain is in place, is the body of the incus and the fossa incudis. The third landmark is the posterior wall of the auditory canal. And so I approach the posterior tympanotomy by drilling strictly parallel to the posterior wall of the auditory canal, point pouce. You can see here the external fat, the posterior fat, face, and both are really strictly parallel.
Okay. And because you've had a preoperative CT scan, you have a fairly good idea that there is no facial nerve anomaly.
Yes, but in my experience, yes, I perform CT scan before each cholesteatoma surgery. It's mandatory. And in my experience, there is very, very, very rarely anomalies of the facial nerve traject into the mastoid. And it is quite always in right position over the oval window, the tympanic portion.
Yes.
And so there is no surprise. So once I have identified the lateral semicircular canal, the incus body, the fossa incudis, the posterior wall of the auditory canal, then the posterior tympanotomy will be in the axis of the body of the incus, which should be there approximately. But the incus give a landmark, but it's more difficult to drill posterior tympanotomy with the incus in place, but without incus. And as I have to remove it for the cholesteatoma removal, I remove it before to drill the posterior tympanotomy. And then I drill in the axis of the incus. And in that case, the mastoid portion of the facial nerve is always internal to the axis of the body of the incus. It's more internal to the incus than the incus. And what has to be done, that, and I have not really did it today, is that approaching posterior tympanotomy with the fossa incudis there, the posterior wall of the auditory canal, the lateral semicircular canal, with the biggest diamond burr that I can use, I will progressively scale it as the biggest, yes, I will skeletonize the mastoid portion of the facial nerve. And
yes,
which is approximately there. Yeah, I didn't really skeletonize it. And
yeah. I would add to what Thibaut's saying there that the problem is not usually when there's cholesteatoma, it's when there's granulation tissue. You're far more at risk when there's granulation tissue to damaging the nerve. The cholesteatoma, normally you can find a plane.
Yeah. I would also add that he's given a response about the anatomy, but actually he's demonstrating a really beautiful safe drilling technique, and that's really key to not injuring the nerve. And if you're drilling safely and you can always see the tip of your burr, you're going to see and hear the nerve long before it's injured, aren't you?
Okay.
Yeah, I think the old adage of the biggest drill possible, rotating as fast as possible. The smaller you go, the more likely you are to cause damage.
John.
Yes.
Are we having any joy with St. Polten?
We're going to try. We'll use the audio in a different way. At least we can do briefly what they're doing. Hello, you talk to them. You'll get an echo. That's the only thing.
Hello, George in St. Polten. Can you hear me now? It's John here, one of the moderators.
Can you hear me?
I can just hear you. You have to shout.
Sorry, we are seeing so many problems with audio transmission now. I can hear you very well, but obviously we have problems to connect to you. Anyway,
okay.
I'm in the middle of the maybe most exciting part of the surgery. I'm trying to prepare the round window niche here. And I need to enlarge a little bit the promontory rim. I faced a problem here with the facial nerve, which is coming up quite high. But
yes, we can see that on your image, yes.
1 millimeter drin ohne Wasser. Well, it's a pleasure to be with you, but unfortunately the technical issues are not solved so far. So now at a very low of the round window membrane, which is down here. Here we have already the membrane. Here's the stapedial tendon, elastostapes, and down here is the round window membrane.
Oh, the sound is much better now, George. Sound is much better.
Right now. And now we'll apply some cortisone here. And the opening of the round window membrane is just a very last crucial step. So this is cortisone with it.
Okay, Wilco, we've still got his sound, but the image is frozen.
Gelita with cortisone. And beforehand, I prepared already all the things I need. So I did already the mastectomy. Here we have the sigmoid sinus. I prepared already the implant bed, of course.
Okay, John.
Yeah. Your image is just frozen, I'm afraid, George. We can hear you talking very clearly now, but now the image is frozen. So
it's a dilemma.
I cannot change.
This is always the problem with live surgery. It's one of those things.
Okay, we go to Hanover then. Sorry, George.
We'll go back to Hanover. We'll try to come back later. So here we are back in Hanover. Hello, Hanover. Can you hear us?
Hello. I can hear you. Yeah. Okay. So,
Good.
John, Hello. It's a patient. She has a high frequency hearing loss. As you can see, das Audiogramm bitte. Können wir die Kamera einblenden bitte mit der Makrokamera? Yes, haben wir es. Dankeschön. So you see, the patient has high frequency deafness and still normal hearing in the low frequencies on both ears. No? Her speech recognition scores or speech recognition reception scores are somewhat like 30% at 65 decibels, which is below what you need for phone conversation. Your right ear is a bit better than the left one. And now we go for hearing preservation cochlear implantation using a Nucleus 624 electrode. And we will do probably also partial insertion depending on the patient's response. So we will give her a tone in the ear, like something like 500 hertz, while we insert and ask her whether the tone is changing. Yeah? Once it starts to change, then we stop the insertion. The pre-calculated insertion depth should be something like 16 millimeters, depending on the size of her cochlea and the Greenwood equation. So we want to have an overlap or crossover frequency where the threshold is about 65 decibels. This would be here in this frequency range. So 65 is approximately 1.5 kilohertz. So that's what we have as an intended insertion depth.
Okay,
now,
Thomas, so she had no success at all with hearing aids. They didn't help her at all.
Oh no, you can buy 50 of them, but it doesn't help because the high frequencies are really missing. So no, that's the point. No. And so we see here her cochlea, which is normal in shape, inner ear, here vestibulum, ossicles. Here we have the round window niche with a kind of overhang. I have to prepare. MRI scan shows normal appearance of inner ear and also auditory nerve is present. So it should be a kind of straightforward case then. And patient is under local. So we have just done the work here on the mastoid, and now we are going to the posterior terminotomy. We have done it. You see here, and so now we see in the depth we see the round window, niche here. No?
Yeah.
The pedis also we can see, which is here, no? And up here is the antrum, where we can see the incus here, no? Here's the incus body. So there's a semicircular canal. Facial nerve is here. Chorda is up here. So we can probably now go for
a bit bigger
preparation of the round window. There is a bit of false membrane on it. And bitte mal ein bisschen Schlitter mit Lösung. And I want to put a bit of local local anesthesia on it, because normally that could be a bit of itching, pain. So you see here we have
Emma, do feel free to chip in. This is very much your backyard.
Yeah, I did have a question actually, Prof. Lennox. Can you tell us a bit about the 624 electrode and why you've chosen that one?
Sorry, I didn't get your question. It was too fast. You did speak too fast.
Can you tell us why you've chosen this specific electrode?
Yes. As this electrode, we just have chosen because it's a hearing preservation electrode, and we can really easily stir it. So you will see the electrode has a wing on it, and the wing allows us to control the insertion very nicely. So here now, that is the reason why we go for that. So you can also do partial insertion, whatever you want. Huh? Okay, now let's see that we can bitte mal ein Häkchen 0,6. So I will try to prepare the false membrane. So you see here now the true membrane comes now here, and you see the bone overhang. Huh? The false membrane is taken away, and you see just the rim of the true membrane. So now we have to take away some bone. Bohrer 1,0 bitte. Kühlung 5 gepulst bitte. So now we go so I go down with slow revolutions. I try to bring it down, not too fast, no? So that we avoid the noise-induced damage to the inner ear. I think Rolf Salcher has demonstrated it in the morning with this kind of work on the round window niche. The patient, it can be quite loud. So one has to be very careful with this step. I think also Arno Dietz has shown it very well. So now we get more access to it, still not enough. So it's quite a bone lip we have seen in the CT scan. The overhang is quite a lot.
Thomas, there's a question here which I think is fair.
Mhm.
It's from Anwar Ashqar. Have you ever had an accident while operating under local anesthesia when drilling or because the patient has moved?
Yeah, the movement is not so much the problem. You have to, of course, give good local anesthesia, and in it also our colleagues from the anesthesiology are taking care. So that's what we basically do as an analgo sedation, as we call it. So patient is somewhat sleeping, which is of course done by the medication from the anesthesia. So I think it's disoprivan or so what they take, or the fentanyl you can take. You still have to prepare a bit of bone. But now it comes already, I have a bit of membrane, like a periosteum to take away, but okay, nochmal bitte das Häkchen. So now we take the hook, remove it. I think it's already enough for exposure. We'll see here. I assume it's ein 0,06er Häkchen, huh? Yeah. So now you see we have it nicely exposed. So this should be okay. And now see for the trajectory, no? I don't go too far inferior here. In order to avoid that, we have a trajectory like this. I want to have a trajectory like this, yeah, to go into the basal turn. Now the electrode is quite helpful, bitte 0,5er Bohrer, because it has kind of wing that allows us to fix it in the posterior tympanotomy in our slit we make. And this keeps the electrode itself in the trajectory. So we don't have to move it then once we have inserted it inferiorly. No?
I'm just going to have a word with Wilco. Wilco, could you just remove the name of the surgeon? We recognise him and the question because it's obscuring the surgery. That's great.
So there is another question that's come, and this is about your electrode insertion. Can you explain how you decide?
Yeah, you will.
What depth to insert it to, comparing it to the low frequency.
Ja, we will show you, we will organize it. Frau Mitowska, wenn Sie mal wir haben das, glaube ich, ausgedruckt in der Akte, da gibt es das MyCI, die Berechnung. Schauen Sie mal, sonst Herrn Tim fragen, bitte. We will show you. There is, what you can do is to calculate the, frequency of overlapping. And this depends, of course, on the audiogram. Second is on how long the cochlea is, and this is very much patient specific. So you have short and long cochlea, and here we have somewhat like mediums, 36 millimeters. It's not that long. Big long cochlea would be more than 40. Short cochlea would be 32. And we have a special algorithm to measure the length. So it's just by multiplanar regression. So you unroll the cochlea, and then you can measure the length. No? And then, so both factors, audiogram plus length, are brought into a formula. It tells you then how deep the electrode should be inserted. That's just the anatomy part of it. Okay, so gut, danke. So, okay, das ist ein bisschen Shelita, bitte. And then you can just see how many millimeters you should insert. Here with this electrode is 20 millimeters long. This would be too much because we would go too deep, and the deeper you go, the higher the risk for some loss of residual hearing. So therefore, we have to try to reduce the risk for hearing loss. Now, if the patient has progressive hearing loss, then of course we can have to decide what to do. Das brauchen wir einmal. So, wir müssen noch, so den größten Teil haben wir jetzt. Das müssen wir noch einmal ein bisschen bohren und dann sind wir so weit, dass wir einführen können. Einen kleinen Moment, es wird noch mal ein bisschen laut, ne? Das soll er machen. Vielleicht kann er das machen, ne? Dann werden wir es da zeigen dann nachher. Well, I have to do the bone bed, which is perhaps a bit of, not boring, but takes some time, and then I'm ready to insert. No?
I have another question for you.
Okay.
Do you select the MR compatible implants for every patient as routine now?
Well, I think all the current implants are MRI compatible. That means they at least go for 1.5, but there are some bit of but there are also some going for 3. But for 3, normally it's you have to either remove the magnet, or the blurring or the artifact, the picture artifact is quite high. So, and so I think we only use this MRI compatible bitte bohrer. So here I think I just make an anterior edge here for the implant so that it doesn't move, not too much here. The sinus is quite high, you see, it's not, we don't have so much space here. So we have to be careful not to damage the sinus. No? Patient has quite firm here periosteum. I had to work quite hardly to get it off the bone, huh? So it's just
Thomas,
an anterior edge here.
Thomas, it's
Yeah.
John here. I think we'll leave you while you're doing the bone work, then come back for your summary of the bone work in a few minutes. We're just going to go and see whether Thibaut is
Great.
completing this operation. Okay, so if you kill your microphone, that's great. Thibaut, it's John here and Emma. How are you getting on?
Yes. Okay. I start the reconstruction. The situation is that the pars tensa is quite fully intact, and I cleaned the stapes.
Well, that looks much better. Yes. Was it easy or was it difficult to clean the stapes?
Oh, it was as usual. It is not very easy,
Yeah.
but you can do it.
I remember asking Benoit Gratacap, what is the length of the prosthesis? He says, it is the right length.
Yes, the adequate
Yeah.
length. And so the stapes is intact.
Yes.
And I cannot clean it more. So
No.
I harvested some tragus cartilage, and I will prepare it to reconstruct the apical and superior part of the tympanic membrane smooth. I will use this will be the anterior part, posterior, superior, inferior. So I have to fit a little bit the shape, and after that I will decrease the thickness and curve the cartilage. First I have to curve it antero-posteriorly, and for that I will thin the cartilage on its internal face, and progressively it will curve. I take care because it's a young man, and the younger the patient, the more the cartilage curves when you thin it. And so if you want to fit the shape of the cartilage by thinning it in different way, then you have to be very progressive in young people. So this will be superior. It has to apply on the attic wall. So I thin it in that side.
And you always prefer to do this manually, like you're doing now, than to use a Kurtz cartilage slicer or
Yes,
anything like that? Yeah.
I want to fit the shape of the cartilage to the auditory canal. That means I want to curve it antero-posteriorly and also in other direction, and I do it by differential thinning up. And now I will try to see how it applies on the auditory canal. Before to prepare the cartilage, I made what I call the canalplasty. That means I prepared the shape of the auditory canal to the reconstruction. And lavage moi-même in canal wall up surgery, the key area is the anterior attic. It's the key area for residual cholesteatoma. In my experience, quite all the residual cholesteatoma are in the anterior attic. And to prevent that, the key point is the exposure. And you have seen that I took a great care to expose the anterior attic through the mastoid approach. And I have really a good control. And the second key point is that this is the part where the reconstruction is more petit crochet difficult. And malade un peu en avant, to have a good fitting of the cartilage, I shaped the auditory canal in order that there is a straight plan from the antero-superior sulcus there to the auditory canal wall. I had to drill there to have this flat plan. And then I will try the cartilage Où il est le cartilage? Ah oui. Hop. And see how it fits. I remind you that this is the superior part, anterior and posterior. And I go to apply the anterior part of the cartilage of the auditory canal wall. And this is the more important, is that part. I apply the cartilage well on the auditory canal wall. And after, I will see how it fits for the rest of the tympanic membrane. The more important is to apply it on the anterior auditory canal wall. So I think anteriorly it will be not so bad. I have to see more now. Ça se remet à saigner là. Posteriorly, you can see that it fits well under the remaining tympanic membrane.
Yes, I was going to say that's pretty good for what we call a first fit. You're fairly close, aren't you, on size?
Yes. And then I come to here, the stapes, and I check again, and I think that it will be quite good. I just will thin perhaps a little bit there, the cartilage, but there is quite nothing to do. Alors, un smooth. I have to thin.
I guess you get a good. Angle. I guess you'll get a good view through your posterior tympanotomy of the of the situation in a minute. Yeah.
Yes, it will be good to fit fitting to check the fitting of the prosthesis. So I just thin the posterior superior angle of.
Any comments, Emma? You happy?
And then
I think it's lovely. It's lovely to watch. It's really nice. So, yeah, no, it's great.
And now I have to. In that case, there was at the beginning a lot of middle ear effusion, and so I will put a T-tube to avoid that here is a middle ear effusion after the surgery. Vous avez le T-tube. So I will perform an anterior paracenthese.
It looks like a pretty good quality pars tensor to me. The drum is good quality,
yes.
Isn't it?
Yes. Alors, vous allez me donner la faux. I will put the T-tube there.
Anterior, yeah.
Very anterior. Alors, voilà. Tympanic membrane is quite thick because there is inflammatory reaction into the middle ear. Alors, le T-tube. So I have to shorten the T-tube because originally it is too long, and if the shaft of the tube is too long like that, there is crusts post-operatively, and I have to shorten it to avoid the accumulation of crusts around the T-tube, but smooth, not too much, because if I shorten it too much, it will go into the middle ear. So I think that will be good, something like that. And I shorten also the little wings. Oop. Voilà, micro-pince. Okay.
Yes, I find T-tubes a little bit difficult to insert. We have another nice tube which looks very similar but has a disc on called a permavent, and that to me is a little bit easier to get through a thick drum.
Yes, the idea is really to put the forceps in and then after to remove it.
That looks
and
fine.
now I will check from the inside, petit crochet, if the wings are deployed. No, that's okay. Oh, now before to put the cartilage, I have to make a first petit crochet layer of graft with temporalis fascia. I will prepare the fascia.
You've already dried that or pressed it.
Yes, at the beginning of the surgery, we pressed the fascia that dry it, and then we let it just like that during the length of the surgery. Voilà, pince mousse, pardon, micro-pince. So I first put it, and I have to remember that there is a T-tube. I have to avoid to go under the T-tube with the fascia. Pointe mousse. Voilà. So, and the same thing done with cartilage. The first step is to apply the fascia on the anterior wall of the auditory canal to prevent retraction in the anterior attic. Hop, alors, merde. Le bonbon colle au papier. C'est rouge, c'est rouge. The fascia sticks to the instrument because of blood. But you can see it's real life surgery, as we said. So, and the anesthesiologist is very good, and she is very worried that it is so bloody. But
Yeah, but that's not her fault. It's the inflammation, and quite often what you find is the anaesthetist is working incredibly hard to bring the blood pressure down, and the surgeon is throwing lumps of gel foam in soaked with adrenaline. So it's a constant battle, and we don't make the life very easy for our anaesthetist.
Yes. And now I will apply the cartilage. Up. I take care to avoid to remove the fascia with the hook. And I will apply the cartilage first in the anterosuperior angle there. And now I can, pointe mousse, apply the fascia on.
I must say this looks like a very nice assembly. It's going together nicely. I perhaps shouldn't say that yet. Yeah.
That's why I was asking earlier, John, if he'd thought ahead about how he was going to do this, because I knew there would be a plan.
Oh, well, you must remember he's done hundreds and hundreds.
And now I will check the prosthesis.
Good.
Alors.
I think when you've done 100,
I appreciate the size by my eye laser. I think I will try with Alors, on va les montrer. So these are the new dummy by Medal. You can recognize.
So these are the practice ones. You try this first to judge the size.
Yes, and
okay.
The packaging is quite good because you remove just laterally, and it's avoid that the dummy go out of their lodgement. But there is the size is indicated on it, but it's very hard to read it for the nurses, and we could take a little bit bétadine assez concentré, et avec micro pince ou pince mousse to mark.
Oh, you put it on to read it. Yeah.
Compress. I will try. I don't know if it will be enough, but we see a little bit more, but it's not so easy
yes,
to
problem. Yeah.
read. 1.5 millimeter, 1 millimeter, 1.5, 2, 2.5, and 3 millimeter. So I will try the 2 millimeter dummy. Alors, I will put it, 12. I take it with a suction tube. C'est des partiels, ça?
I think, like Chris Aldrin says, with the Variac system, because you get the dummy in and it fits so perfectly that you don't really want to go and put the real prosthesis in. So this is a 2. You can see that written on it now. It's quite clear.
2 millimeter.
Yes, yes.
And then, petit crochet. I will take it with the left hand.
And is this just an ordinary sucker or an interrupter sucker?
Yes, I interrupt the sucker with my foot.
Interrupter,
foot
yeah.
Pedal.
That's good.
And
very nice instrument.
Up.
Looks good.
It looks a little bit too high.
Too long.
I think 2 millimeter will be too high, probably.
It also has a big capitulum and a small hole in the prosthesis, which may be the problem.
And I will use the 1.5. I try with a 1.5 millimeter dummy.
Yeah. John, I have a question or a comment on the size of the cartilage reconstructing the annulus defect and supporting the tympanic membrane.
Go ahead, Cor. Ask Thibaut directly, I think.
In my experience, I got the experience that bringing in 2 pieces, just cutting such a larger part into 2 parts, that the part connected to the tympanic membrane will vibrate separately from the annulus reconstruction. And by doing so, this proves your ossicular reconstruction with about 20 decibel conductive hearing. And now it will be stiffened and damped the transmission just by the
1.5.
cartilage connected to the bony posterior wall.
That's an interesting point. It might be interesting to discuss that in the discussion at the end, because I think if we put that to Thibaut now, it's going to cause a little bit of confusion.
That's the reason that I was hesitating to comment.
Yes.
And so I looked to the results, the hearing results of the ossicular reconstruction in cholesteatoma surgery, and in that anatomical situation, that means Austin cartouche C with no malleus, no incus, and the stapes intact, the average airborne gap with a partial titanium prosthesis is 12 decibel, with 83% of airborne gap inferior to 20 decibel. These results are, the results with that prosthesis are really, really good. And
but the command is that we will come later on to it.
It's interesting though, isn't it, for the trainees that are watching, when we talk about our stapes results, we use 10 dB, and when we talk about our ossicular results, we use 20 dB, and there's a definite message there that, you know, to get a good result with an ossicular reconstruction is much harder than it is with a stapes reconstruction.
Yes, and what surprised me, and in a good way, is that the average airborne gap is 12 decibel with Austin cartouche C and that sort of prosthesis. So the clip prosthesis by Medel looks like the pince mousse, the Kurz partial clip prosthesis with the Dresden clip. There is two differences. The first is that you can see that there is a little separation between the two halves of the head, and you can bend the head, the both parts. If you want to use the malleus, for instance, then you can bend the head of the prosthesis to fit it to the malleus. The other difference is that the clip is symmetric. There is two teeth anteriorly, posteriorly, superiorly, and inferiorly, and so in the Kurz prosthesis, the clip is not symmetric, and there is a landmark for the posterior part, and you have to fit it with this landmark to have two teeth on both sides of the stapes tendon. This one is symmetric, so that there is no worry with anterior or posterior side of the prosthesis. Up, alors. So I will fit it with a number 10 suction tube. The idea is that I have to push it on the stapes head, but I have to avoid to dislocate the stapes, and for that I will use a quite fine suction tube, 1 millimeter, in order to point mousse, to prevent dislocation of the stapes. So I have to clean before to put it. Voilà. Vous allez me donner un petit gelita. So I will put a gel foam under the anterior part of the reconstruction. Allez. Alors. So I will take the prosthesis with the suction tube. Okay, you can see I check that the teeth are not bent to the inside, because I have seen that the stapes head is quite large in that case. vous allez me donner I will open a little bit the clip. Whoop là. And now I will push the prosthesis on the stapes head with the left hand and then fit it with the right hand very gently. And I check that the head of the prosthesis is well fitted, the head of the stapes into the clip. Yes, that's okay. And now I put the cartilage in the right position and the tympanic membrane in the right position. Okay, and I can check that the head is in right position and she's approximately at the level of the sulcus tympani. And then I can check from the posterior tympanotomy the position of the prosthesis on the stapes. And everything seems okay. If I move the tympanic membrane, I can see the transmission. Okay, and in cholesteatoma surgery, I compared in that anatomical situation one more time the results with total prosthesis between the stapes screws and this type of titanium prosthesis, and the results are the same. That means in the case of cholesteatoma surgery, in my hands, partial titanium prosthesis perform as well as total prosthesis with elastic banding. Alors, on va prendre. Now
Interestingly, Thibaut, Core made a comment. It's a little bit complex, but as you know, he's extremely experienced middle ear surgeon. He said that in his experience, using two separate pieces of cartilage for him worked better. He used one piece of cartilage to support the drum and the second piece of cartilage to reconstruct the attic. And he feels if you do that, the vibration of the drum is slightly better than using the single piece of cartilage. Do you understand?
Yes, I understand.
Do you have a comment? Yeah.
The comment, I like to perform a single piece cartilage reconstruction because I feel that it's better to prevent retraction. If you have two pieces of cartilage, if they are not perfectly fitted, you can have a retraction between the two pieces. And so I like to perform this one piece reconstruction. The condition is that the shape of the cartilage is fitted to the shape of the auditory canal and tympanic membrane. And with that, and the processes that, the kind of processes that I use today, the postoperative bone gap is 12 decibel. I'm very happy with that result. I do not had the impression that the hearing result was so good. I remember it's cholesteatoma surgery. And so my opinion is that my preference is really to the one-piece custom shape cartilage reconstruction.
Well, that's a very good answer, but we like controversy. So, Core, are you there in Utrecht? Would you like to make any further comment?
Yeah, I understand what he said. The argument that the, let's say, tympanoplasty, like the Germans do for the whole drum, stiffening it and coming to an end result of 10 dB air bone gap is a true story. But it will not take away that if it is a thicker, larger piece in which you reconstruct and support the posterior superior part of the tympanic membrane, that it stiffens too much the transmission of sound. And the risk of a recurrence disease is not caused by two different pieces of cartilage which are nicely and closely to each other. And it is just a comment and an idea and experience I give, and people can use it and cannot use it. That's up to them.
Well, this is good. This is good to have this discussion because, you know, yesterday we had a big discussion about whether you should do a TORP or a PORP. And here we are in a clinic that does thousands of these operations, and one surgeon prefers the PORP and the other surgeon prefers a TORP with a psilastic band. So even in the same institution, you know, it's what a surgeon feels happy with that is important.
And yes, and you can see that through the mastery, I can check that the cartilage do not fall into the attic. It is well applied on the anterior wall of the auditory canal, and the cartilage do not fall anteriorly there in the attic.
No, it looks good. I can see.
The reconstruction is good, but there is a point for the hearing and the optimal hearing whether it could be improved a bit or not.
I can see Emma wants to comment as well. So this is obviously, there's some good controversy going here. What does Manchester think?
So this is I'm a bit hesitant to contribute because you guys are a lot more experienced than me, but one of the things I do a lot of is revision cholesteatoma surgery, and you can learn a lot from revising other people's recurrences. And certainly the patients I get who've had cholesteatoma surgery as a child and it's recurred in adolescence or young adulthood, it's always retracted between the pieces of cartilage. So my personal current strategy is to try and use a single piece, as you guys do in Béziers, to try and prevent a further recurrence.
So it's the Mancunians, and the French versus the Dutch at the moment. There's a difference of opinion there. So this would be good if we could maybe have a discussion later on in the day when we've got some time to do it.
John, don't you have any opinion then?
Yeah, I do have an opinion, but I do a TORP. So so yes, and I will openly say that I struggle even with my cartilage slicer getting the cartilage to do what I want it to do. I was quite impressed there, the way Thibaut sliced it, and it fitted almost perfectly first time. My cartilage doesn't usually look that nice. Get quite good results, but it's definitely an acquired skill. And if you have a surgeon like this who's doing it day in, day out, year in, year out, you become very adept at that technique, and that's why we're showing it on the transmission today. Thomas, we're back with you. Can you hear us, Thomas?
Hello, Hanover. We are with you. Hallo.
Ein bisschen lauter machen, ein bisschen.
Thomas, can you hear us?
Yeah, I can hear you, yeah.
Good, good.
So der Ton ist noch da, ja? Good, okay. So now we have done the insertion, and the patient, she still is hearing the tone. Yeah? We give her a 500 Hertz tone, and she still says it's not changed, no? Unchanged. So I now at an insertion depth of approximately 18 millimeters. And so this is what we anticipated to do. So now we have it basically here in place. You see here, as I think the white marker would be full insertion, and there are approximately one electrode is out, or two, and the other one is right at the entrance to the inner ear. So the patient has no change in the sound, which is for us the, so to say, the direct acoustic monitoring, so that we can then we'll hope that the residual hearing is preserved. That's what we normally see with it. So it's very direct monitoring, just asking the patient. Ne? Bisschen lauter nochmal. Bisschen lauter machen nochmal bitte am Lautsprecher. Das geht dann. Okay, good. Can you hear me? Hello?
Yes, we can. Yes, I can hear you quite clearly, Thomas.
Okay.
Yes, hear you well. Yeah.
Okay. Okay. So now I think we can show the MyCI. I think Dr. Tim can explain it if he is present.
Me?
Microphone to Dr. Tim, please.
Hello?
Microphone to Dr. Tim, please.
Hello, can you hear me?
We can hear you.
Okay, perfect. So what we did that we measured the cochlear length of the patient, and we had our preoperative hearing test, and we were choosing for a crossover frequency about 1000 hertz.
Dr. Tim, could we have a camera with you?
Yes, normally we should have.
Sie den Ton noch hört.
Maybe the camera can change,
Gut, okay.
so that we can show it.
Gut, dann können wir den ausschalten jetzt. So, wir schalten jetzt den Ton aus, nicht erschrecken, gell?
Okay, and we measured the cochlear length in the cone beam CT scan. We had our preoperative hearing test, and we were choosing for crossover frequency, or what we want to reach with our electric simulation of 1000 hertz. We calculated it, so it's still a bit, with the cochlear electrode, it's a little bit work in progress. So we calculated it for a lateral wall length of 90 millimeter, and we were aiming for an insertion depth of the electrode of 60 millimeters, what Professor Leonard inserted. So that's basically the model and what we calculated in this case.
Moment. So. Bitte? Das gibt's ja nicht. Ja.
Do you have any questions with this individual cochlear implantation, or we call it MyCI?
I think it's better to let Emma ask the questions here. She's far more experienced in this area.
What I find very interesting, it is of course fantastic. I'm not sure if you're aware of, we published at one point that the frequencies supposed to be the frequencies done by the implant companies are not in line with, if you implant single-sided deafness, and you do matching tests, at least we found that the implant frequencies don't match the normal hearing frequencies. Have you encountered similar problems?
Yeah, we have it. Sorry.
We did that, and we are working also with that. And there's still also a bit work in progress. So we are thinking of that, and we also changed our work a little bit regarding on that. What we found out with this finding. So we are keeping that in mind.
Okay, okay. Mitgucken, ja? Gut. Das ist das Beste. Jetzt machen wir das Ohr wieder zu. Die Elektrode ist drin und jetzt machen wir hier ein bisschen Blut zum Verschluss wieder rein, ne? Dass das Ohr wieder zugeklebt ist. Das Blut ist wie ein Kleber, ne? So, gut, danke. So, jetzt brauchen wir nochmal die Spule und nochmal messen. Können wir jetzt machen wir nochmal Folgendes, dass wir jetzt mal das Implantat aktivieren. Und dann aktivieren wir verschiedene Elektroden. Und dann sagen Sie immer, wir machen den Strom immer ein bisschen höher, bis Sie was hören. Dann sagen Sie bitte, jetzt höre ich. Und dann machen wir das mit verschiedenen Elektroden. Und dann schauen wir mal, ob Sie da Unterschiede zwischen den verschiedenen Tönen hören, die Sie hören. Ne? Also fangen wir mal an mit der Mitte, oder? Ja.
Important for the audience, the patient is awake, so Professor Lennertz needs to speak German to the patient to instruct the patient to do all the tests and the comparison. That's what they're doing. And it's not a German transmission, if you think that's what it is. It's the Lion International broadcast in English, but of course, if the patient is awake, we need to speak to them in their own language.
Bisschen deutlich leiser, deutlich leiser. Okay, gut, jetzt machen wir das, okay? Immer laut, man fahren Sie einfach hoch. Bitte? Weiter. Hoch. Okay, hören Sie den Ton, ja? Okay. Gut, dann machen wir mal den nächsten. Apikal, ja. Hören Sie wieder einen Ton, ne? Ist der jetzt anders als der erste? Ist der tiefer oder höher? Bisschen lauter machen nochmal. Wir machen nochmal wir machen so einfach lauter, dass der laut, das ist gut, ist gute Laute. Laut ist es, ne? Okay, gut. Jetzt gehen wir nochmal den anderen. Der ist höher, okay, prima. So. Unangenehm. Und jetzt kommt nochmal einer. Dann ist nicht den 22. Gehen Sie mal auf den, nee, noch ein bisschen runter. Der ist möglicherweise nicht drin, noch weiter runter. Noch nicht 4 oder 5 oder sowas. 5 vielleicht mal. Höher noch? Höher, ne? Höher noch? Höher, okay. Now she has the right ordering, so we have activated an apical electrode, which is more slower, then middle electrode, which is medium, and then basal electrode, which perceives a high frequency pitch. So this means the electrode must be in place, must be correctly placed, and she has already pitch scaling. Yeah? So that's what we can basically give the patient on the table. And therefore we have checked the residual hearing, and we have also checked the function of the implant. Everything is okay. We don't need any further measurement. No? Okay, very so nice, then we stop the measurement and then we close. Okay, danke. So, jetzt sind wir fertig. Jetzt machen wir die Wunde zu und dann sind Sie erlöst. Ne? Wir haben das ganz toll gemacht. Ja? Und die Anästhesie und so weiter auch ganz großes Lob. Okay, that's it. I think it's the teamwork. You see, the anesthesiologist must really be with you. And also everybody else in here, we all have our role to instruct the patient and so forth. But it's, I think, one possibility for improving hearing preservation results. No?
Well, Thomas, I think we should all get an award today for the increasing relationship with anaesthetists. I think the International Association should recognise that Lion really does try to cooperate with their anaesthetists, unlike some of the other surgical specialties.
Yeah, absolutely. That is key, no? That we really have this very good, absolutely. Bitte mal nochmal den Sperrer 2.2. So now we close and then it's all done. No?
Of course, the unpolitical answer is they can make your life hell if you don't cooperate.
John, we try to do our best. No? Okay, gut. Gut, nochmal zweimal Pinzette anatomisch.
Thomas, I must.
So the patient was watching. The patient was watching her surgery, no? So she did look what we do.
Oh, really?
Which also can sometimes be helpful, no?
The image quality is very nice. Eh? It's a very nice image.
Yeah, it's the ARRI, or as you said, Wilco, it's a true digital microscope, no?
Yeah, but what makes a difference is that it has a very natural color, and also the red color is very nice. Frequently we find red to be very difficult, but this is very, very nice image. Excellent.
Okay, so das können wir nähen, ja, danke. Okay, gut, dann machen wir das. Danke. Dann ich muss noch ein bisschen, ja, danke. Okay, so then we finish, and thank you for your attention. No?
Thomas, can you thank the patient separately for us? Because I think we're all impressed.
Yeah,
and we are very grateful for the patient. Yeah.
Okay, die Zuschauer, die das mitgesehen haben, wollen Ihnen Danke sagen, dass Sie das miterleben konnten. Und bedanken sich bei Ihnen persönlich, ne? Okay, gut. Das war wichtig, dass das andere sehen, wie wir das hier machen, und dass man das halt auch, dass das so geht und dass das eine richtige Methode ist. Okay. So Wilco, as I expressed it, and she says, okay, she pleasure for her doing it.
Ich habe das verstehen. Ja, vielen Dank. Ja.
Okay, so Herr Professor Krollmann aus Utrecht hat sich auf Deutsch bedankt, ja. Okay, gut. Okay, Wilco, then let's go on.
Okay. We are going to go to Kuopio in a couple of minutes, but I think we would like to see you close. I think it's always good to see the remaining of the surgery, if you're okay with that.
Yeah, absolutely. Absolutely. So we have to close in layers. Try at least to get this periosteum and muscle back. Gives you one layer in the depth. Yeah, okay. And then we make subcutaneous and then skin. No? Always try to do the 3-layer closure. So, jetzt habe ich mich hier eingewickelt. Okay, so I'm sorry for being, but now we can future this back here. It's this pulvar or fish flap. Always use.
Have you had to top up your local anaesthetic at any stage during the procedure?
No, it was just initial injection. No? The only thing that I did was to give some local anesthesia into the middle ear, and also then use this third shell form pad on the round window in between, because once you remove the mucosa at this location, it can be a bit painful. It is the tympanic nerve that has some branches there, and they can be sometimes cause some pain. No? But I heard, yes, I think on when we had meeting on Monday, did you respond? Did you say that you also do under local, or some of the younger people from UK said they do it under local?
That's correct. Yeah, that's absolutely right. There's more and more of us doing it. None of us has a huge series of local in the UK, but we're all a lot of us are starting to do it and finding our way.
Okay. Well, so we can share experience. Arno Dietz and myself, we just put together our data in a publication. And so perhaps we can go for some multi-centric experiences.
Yeah, some international guidelines would be a great idea, I think. We'll ask Tom Rowland to join us for the international consensus.
Yeah, and Tom also has done some, no? Yeah. Okay, great. So actually that's now in layer. We hope is that we still have some tissue here. And so it's just a muscle. And this one should go down too. Let's see. So I think we should be prepared for our next case also. Yeah, okay, now let's see. No, it's not, it's too tight. So I see what I can do. Yes, we have some tissue here, yeah, okay. This could work.
What are you going to do with the post-operative management? Just give us a quick account of the next few days.
Well, we give, yeah, okay. So we give steroids for several days, and then just measure the bone conduction threshold tomorrow, so that we see whether we were successful with the preservation, and then basically makes the initial activation after 5-6 weeks. We don't do early activation in patients with residual hearing because we found some cases where probably this was not good for the inner ear. No? And so wait, but otherwise if patient has no residual hearing, we go for early activation, which means the next day. Just make a first fitting, the patient can hear then, so to say. I mean, here we also could have done early activation right on the table, but I think it's a bit overdone. It's not necessary to do that. Some people are glad for that, but I don't think it's necessary. It's really helpful.
Well, I saw some very nice innovations from your clinic again, of course. And of course, I agree we should not do the extraordinary just for the transmission.
No, I think I mean, could we do? I think later on we will have a case where we use a cortisone-eluting electrode. Dr. Brenzler will demonstrate now the implantation in a patient that gets the Dexter electrode, which is just a new development from Medel. Cochlear also has one in a study, but not in Europe. Due to MDR, we lag behind. That's a bit of a pity. Medel is European company.
Yeah, sorry.
European company and wants to do it first in Europe, which I think is very good. Even so, Europeans are sometimes difficult people, but you know, we have to try to do our best in order to compete. No?
Yes, bureaucracy makes it difficult at times. It's very complex.
Oh ja, that's true. Okay, danke. So, wir sind gleich fertig mit dem Nähen.
It could be worse. They could be making vaccines.
Ja. No, the Brits are out, so you can do your own regulations. Nochmal einen Faden bitte. Müsstest subkutane. Schere bitte.
It was interesting, Thomas. They did a poll of the medical profession, and virtually nobody wanted Brexit. Which we think the medical profession feel it's been a disaster. But politics is politics.
That's true, yeah. So okay, so sorry, good.
Thomas, if you don't mind, I think we like to check out Arno Dietz again in Finland.
Yeah, okay, great. Okay.
And,
yeah, great, thank you.
Will you be doing surgery yourself today, or is this your last surgery for today?
No, I will be back, and so I'll at least be present so that we can discuss everything and so on. And I think Dr. Brenzler and Dr. Salcher will do the cases now.
Thomas, I think you should practice that. You should say, "I'll be back," because you have just the right accent.
No, that's
thank you very much. That was a very nice demonstration.
That's an Austrian. That's not a German, John.
I know. Very close. Very close. Yeah.
But Thomas, something to think about. I spoke to Joachim as well. We should go for the 3D broadcast soon, because it's.
I think so.
We can, and with the Irish, if these people are motivated, we can do a very nice 3D, and people will not believe what they see if they see the perspective of what the surgeon sees.
Yeah.
So it's something completely different.
Yes, exactly. I mean, yeah, and this is this would be true 3D, no image. It's
yeah, exactly. But I can do it. I've done it in the past, and I think we're ready to do it now. And of course, you need sites with 3D microscope. But it would be very nice. Good. Thank you. Talk to you later. We go now to Arno Dietz, if John agrees. Even if John doesn't agree, it doesn't matter much really. We go to Arno.
Okay. Thank you, guys.
Bye. It's nice of you, Wilco.
I was talking about another John.
All right.
Arno, we are with you.
Hey. Hello.
Hello.
So this is our second case. Basically, quite similar what we have seen. Professor Lennartz was operating in Hanover. She's in under local anesthesia again because she has her first implant operated under local. And well, Professor Lennartz revealed it that we have summed up our experiences with local with nearly 120 patients operated under local, which is about the largest series yet. And we made an inquiry also for patients about how they experienced this surgery. Was it bad? Was it good? And the last question was that was the $1 million question: would you do it again? And it was very encouraging, because over 80% of the patients would say, yeah, that was no problem. So I would choose local anesthesia again for the second year. So actually our first patient was also a bilateral, which we implanted under local, and now she's also a bilateral patient, and she was operated a year or two ago on her right ear, and now it's left ear. And again, hearing preservation case, but she is a very good performer, and she has a really good speech reception threshold with the implant, and the hearing aid actually made things worse. So And because she has vision problems, we go for a bilateral implant, obviously. And now our approach is different from the first case, because here we want to have a full insertion. We don't want to any partial insertion, because she told me that she just want to have the second implant and no reoperation at a later stage. So we go for a full insertion, but we do it on the monitoring of her residual hearing, and also with cochlear microphonics, which is from Advanced Bionics. It's a system where you can see it's a real life monitoring, and here you can really see how the events in the subjective hearing, or changes in the subjective hearing, correlates then to the responses in the active cochlear monitoring device. And we try to screen it on one screen during insertion, and let's see how it works out. So basically it's quite the same procedure. What we see here now is I have make the skin incision, again an inferior pedicle flap, and now I have to admit that I'm not quite sure, because you spoke about the fish flap, and I think that the fish flap was actually this inferior pedicle flap, and the palva flap is the anterior pedicle flap. So I think we have to take the terminology right. And the anterior pedicle flap, it was also known as the Popper flap. So that's what I have been taught, and I don't know, you are of that age, guys, that you should know. And by the way, I'm the youngest guy here in the operating. So and even I'm getting gray. So we really have to have fresh blood here at one point. So, but let's start. I will take the microscope and I will start with the mastoidectomy. And if you have some questions, then be free to ask. And I try to be as talkative as possible.
We're still here, of course. Emma and John, are you still there? Or are we now in the
Yes, we're here. Yes,
British
yes.
siesta?
No. I was just thinking we'll have to give Emma 1 year's warning that she might yet be the youngest person operating next year if she wants to, but we'll see.
Great.
Well, you know, if we're aiming for equality, I think you should have women surgeons rather than just women moderators. But maybe that can be
Well, Emma, we have asked 4 surgeons, and none of them were available to comment. So we have tried. We're now improving the balance. It's 50-50 for the moderators, men and women. So I think we can genuinely say there's equality on the moderation team. We just have to work on the surgical side.
Yeah, but I really appreciate that you have done work to get also women on board. So I think it's just. So I usually take some bone dust just in case I mess up with something, and actually the posterior canal, if there is an accidental perforation, I will repair that with bone dust and fibrin glue, and also for the fixation of the electrode, which works quite well. So we have seen that Professor Lennart and the Hanover team, they use the slits between the facial nerve and the chorda tympani. And this is one way to do it. The other way is to do it is to somehow try to fixate it. And bone dust, I think, is a quite good in that sense that it really, if you do revision surgery, then you see that there is some bone formation, but it's not as hard as normal bone, so that you can just break it off, which makes, for example, the identification of the posterior tympanotomy easy, because usually, especially in periactive cases, you have to consider your younger surgeons who have to reoperate the patients, and this is always then the issue that you must do the first operation for them somehow predictable. And here I just want to point out here in this case that if you approach the middle fossa dura here, then the patient most often experience pain. So this is why I try to leave some cells unopened here on the dura plate, and this is something we have experienced in many patients. So just leave a layer of cells on the plates, then you should be okay. Otherwise, drilling is not a big problem. Some patients with residual hearing really complain about the loud noise of the drill, and this is something that you have to take into account. Joo, no me ollaan oikeastaan kohta ihan. The patient says that at one place she is experiencing some pain, but I think we have enough space that we can try to identify the lateral semicircular canal. Poispäin kallistusta. Here in this patient, we have a problem that she cannot move her neck probably, and this sometimes might be, sometimes might be a contraindication to do it under local.
Arno, I think we want to check a little bit what Hanover is doing, and we will be back with you in a minute. But I see that Hanover is progressing quickly. They have more ORs running at the same time. Okay.
All right.
Okay.
See
you
you
in a minute. Hello, Hanover. We're with you. Hanover. Hello, Hanover.
Hi, can you hear me?
Yes, we can hear you. And you
hi, this is Niels.
Hi, Niels. You can tell your technical staff that the echo has been solved. We like to learn what it was. But it was good.
Sorry, again, kann man lauter machen? Ich verstehe das gar nicht.
Welcome.
Sorry, now you're loud, please.
Yeah, it's good. It's very good.
Better.
Okay.
And Emma has a lot of questions ready.
Should I start with presenting the case?
Yes, please.
Yes, please. Yes, please, Niels. Yeah.
Okay, so we have a quite young male patient who suffers from fluctuant hearing loss on both sides for a couple of years. And now you see the pure tone audiographs, and he has some residual speech understanding. He has 40% at 60 dB monosyllables with hearing aids. But this is, of course, not enough for that patient. And so he decided to go for a cochlear implant on that side. My colleague Farnas Martin will now show you the CT and MRI scans. And besides, we can only say that the patient is very well pneumatized and we did not see any abnormal findings, neither in the CT scans nor in the MRI scans. So that patient, he decided to go for a mid-L electrode, and in that special case here, he fulfills the inclusion criteria of the CI DEXEL study. And I don't know if all of you heard of it before, so I want to explain quite short. It's an electrode, the usual Flex 28 as you know it, with the Synchrony 1. And it has silicone rings between some of the contacts that elute dexamethasone for up to 100 days. It has some kind of a burst release within the first days, and then a quite slow release, and approximately 80% of the dexamethasone are eluted on day 80 till 100. Okay? And we have not unpacked the electrode yet, but of course I will show you the rings and where they're situated. And yeah, so questions so far?
I think Emma always has questions. Hi. Hello. Hi, Niels.
Hi.
Oh, thank you very much. That's really nice to have an explanation of the drug-eluting electrode. I was admiring the favourable anatomy of your patient scan. When you're operating under local, do you select patients with favourable anatomy, i.e. would you be more likely to give a GA if they have a very sclerotic mastoid?
Emma, can you please explain what GA? You mean general anesthetics? Can you please
Sorry. Yeah. I'll make it.
GA, please. S'il vous plaît.
So I have to say here in Hanover, we pretty much let the patients decide. Of course, there are some very rare cases where we say it's rather a case for a general anesthesia because due to the anatomic situation. But in this patient, I mean, he could have had both, but he went for a general anesthesia. He's a young patient. He was counseled by the anesthesiologist, and they said, okay, you don't have to fear a general anesthesia. And he said, okay, it sounds more comfortable to me, so he chose that. But we speak about that with all of our patients, and we offer them both kinds. But that massive pneumonization here would not be a contra.
But I guess he's got an autoimmune condition, Kogan syndrome, which I must admit, I had to Google, but I would imagine that the drug-eluting electrode might be very useful in that situation.
Yes, of course. I mean, the actual indication or the idea behind the eluting electrode is, of course, to attenuate the electrode insertion trauma, and by that reducing the fibrous tissue that grows around the electrode afterwards. And we know pretty well from animal experiments that the drug-eluting electrodes have the property to reduce the fibrous tissue growth, and by that also reduce the impedances after surgery. And I can say so much because Professor Lennartz already showed some data on the CI 2021. We have implanted, I think, 7 patients so far successfully with that DEXEL electrode, and so far we see very, very low impedances afterwards. And we see quite some nice residual hearing. Okay.
Yes.
Great, thank you.
Okay. So if you stay tuned here in Hanover, then I can show you how far I proceeded so far. I hope it's okay that we did not wait. We did not wait with the skin incision, because here in Hanover, we pretty much do it. Everybody does it the same way. We all learned from Professor Lennartz, and you've seen that quite some time before. So now I show you under the ARRI microscope the situs, and it's a left ear. As you've seen before, it's very well pneumatized. We have quite a big mastoid cavity here. This is the bony bed, and you see the pneumatization runs on the ground of the bed. So this is the canal that connects the bony bed for the implant body with the mastoid cavity, and you see it's a Synchrony 1 device. I show you the dummy here. The electrode comes out at the side. Fortunately, for me as a surgeon, I have to say, fortunately, MED-EL changed that with the Synchrony 2. Now the cable comes from the middle, but the Dexel device is still with the Synchrony 1. I mean, the patient has no disadvantages of that because the implants are pretty much the same. It's just, I think personally, it's nicer for a surgeon that it comes out of the middle like all the other manufacturers as well, but some might probably miss those. I don't know. So in the mastoid cavity, I've already shown the antrum. As you see here, Nadel leicht geschwungen. Okay. This is the short process of the incus. It all looks quite normal here. This is the horizontal canal. And here I just started with the posterior tympanotomy. I have the facial here, somewhere here. The chorda comes here quite lateral to this to the facial nerve. I wasn't even expecting it already here. I would have expected it a little bit more medial, but I preserved it, and now I will dissect the run of the chorda to the middle ear and go here for the posterior tympanotomy. As you've seen before here in Hanover, we drill a niche in the facial recess to keep the electrode in place for, let's say, decades, because we've seen some extrusions of some extrusions and migrations of the electrode in lateral wall electrodes, but I will show you later. I use a Indigo from Medtronic, and this is a 2.0 diamond burr. We use diamond burr, we do cutting burrs, and we also use the sharp diamond burrs from Medtronic. As you see here as well, there's not much drilling work in this patient. Even the facial recess here is quite pneumatized.
I think we call
And
that
from a
good
surgical
patient
point of view,
selection.
sorry?
I think we'd call that good patient selection, Niels, because it gives us a much better view as well, this degree of pneumatization.
Yeah, okay, yeah, I got it. Okay, now I have a warning from the ARRI microscope. I don't know what that's about.
It's a German microscope, but it doesn't go well with John's remarks.
Yeah. I was just going to, actually, Niels, I was just going to ask Emma, who's my co-moderator. Emma, are you tied to what implants you can use, or do you pretty much have a free reign?
No, that's a really good question. So there are 4 implant companies, and we choose whichever implant we think would be most appropriate for the patient. So essentially that decision is made by our MDT. But sometimes patients come with a preference. They've read a lot of literature online, or they've been a member of a patient group, and they come in and they tell us which device they want. So that plays a part in device choice too. But no, we're not tied to any particular company.
And I mean, I know I'm from the UK and I know the answer, but for the other people watching, where does the funding come from in the poverty-stricken UK post-COVID?
So this is something I talk to my medical students about all the time, because I think it's a really nice story, which is that the UK has a guideline, a national guideline where patients have criteria in order to have their implant funded by the NHS. And those criteria were changed in 2019. They were changed 2 years ago. And the reason it's a nice story is because the people have been knocking on the door to try and get the criteria widened for many years. And it was actually when patient advocates started lobbying that momentum grew, and eventually they changed the guidelines. So there are actually now much more generous guidelines in the UK than there were a couple of years ago. But it is still I guess you would call it rationing. It is still a benchmark that has to be met in order for them to have an implant.
Emma, it's very interesting because you're referring to NICE, I think. And the interesting thing is how fluid or how liquid or how yielding scientific proof can be once there's a public pressure. That's ridiculous. Yeah? Of course, NICE was very stringent and has strong yes, no, the prices should be halved to make it worth double-sided, etc., qualities, etc. And then as soon as you have a little bit of pressure from outside, all of a sudden they yield, and proof and practice and rationale seems to be
fulfilled
and flexible.
Wilco, I know I'm a dreadful old cynic, but it boils down to vote. It boils down to votes, doesn't it? At the end of the day, I think. Yeah.
I think the proof was always there, but it wasn't really listened to until there was additional pressure.
Is that from a scientific point of view, or from the patients in your consultation?
It all plays a part, I think. It's all important stuff.
Well, whatever.
Gosh, she's diplomatic, isn't she? She'll go a long way.
Yeah, she can replace permanently the retired old.
Yeah, they can't sack dinosaurs, can they? That's it.
Niels, we're still with you.
Yes, I listen to you. There was before I said everything is so well pneumatized, but I had quite some solid bone here at the inferior end of the facial recess here. But now 1-0 bitte. Now I see the round window in the depths.
Okay, Niels, I really would like to go to Kuopio for a moment as well, but you're definitely main spot as well. We'll be back.
And no problem.
Okay, we'll be back.
Yeah, I will tell you when I open the electrode, because that's the interesting part.
Yes,
you know,
yes,
we will tell you.
Yes,
Thank
okay.
you.
I know we're back.
Hi.
Hi.
Now I will have to check about anatomy. I will try to look at the annulus where we have, she has a really this ear canal is curling really much into the medial part, and this makes me a bit trouble with the exposure, and therefore I will have to check how much. Here you see that again this reflex, but here I have still a lot of bone which I have to remove and to get before the facial nerve actually. So, and I will have to work around it, and I will have to expose it a bit more better. We have the incus here, but I have to make this bone again a bit thinner, because I think that we have the fascia around here. This is retrofacial, and here we have the incus. And in this case, it might be so that I will go for a suprameatal approach when in case I don't have any enough space for the normal posterior tympanotomy. So this is basically the situation right now, and according to imaging, the posterior tympanotomy is 2 millimeters. This might be a bit too narrow. So let's have a look then afterwards how it works out. I will make a bit more space, and I will make a better exposure, and then we'll see how we can proceed with the electrode insertion.
Do you want us to come back, or do you want us to stay? I know.
Well, it's how do you like it yourself? So these are situations we have to deal with, and I think that it might be quite interesting to see how I'm sweating now, and to see whether I come up with a good conclusion. One possibility to let's would be to make an incision here at the ear canal, and just to flip it over to have some access. But in that case, I think I will do a suprameatal approach in order to be very safe with the facial nerve. And 2 millimeters is quite tight. And in her first operation in the other year, there was I didn't face these problems, but now I can show you that I will raise the flap. Here we have already some bone. This will be repaired afterwards. And now I will lift here the flap to have a good view here. We are approaching the annulus already. Okay, peaky. So are you still with me or not?
Yes, we are.
Yes, we're still with you. We're still with you at the moment. We
right,
probably will move around because it's not. No, we probably will move around because it's not fair to watch you all the time, because that does put some stress on the surgeon as well as the moderators. But this is a really good demonstration of the fact that live surgery isn't like the textbooks.
No, absolutely not, and therefore I think it's quite interesting to see what the different approaches can be. So here you see that actually through the ear canal, you see the round window niche. You can see it down there. I will expose it a bit, and in that case, I'm quite sure that I will go through a suprameatal approach in this case. Here I have opened the retrofascial cell, and here the other way would be just to remove or just to make a slit here in the bony ear canal. But I think it's a better choice now to do a suprameatal. So this is, I think.
Hang on a sec, Arno. Wilco, can you just take this? Can you take the surgical banner away, because it's hiding what Arno's doing? That's it. That's great. That's great. We've got a good view now.
Yeah.
There's another one now. Let's come again, Wilco. Yeah.
John.
Yeah.
Yes.
I think I will have a good approach through the round window here, and I will go over from the incus here, and will drill away and the overhang, and then basically that's about it. So
Arno,
but this was really quite an interesting. I was to be honest, I was not alert to that, because I was thinking that this year is about the same like the last time, in which I could do it very well in with the posterior tympanotomy. But here in this case, I think I will go now for a suprametal, which is an alternative approach. I don't like it very much, but I have trained it, and I think it's a good alternative approach for example, for these cases here.
I think, Arno, I'd like to make a comment to the audience here who are watching, that this is why live surgery is far better than recorded surgery. It shows you the problems you come across, and it shows you the thought processes, or helps you understand the thought processes of the surgeon. If you see edited surgery, you don't gain that benefit. And there's a lot of argument around the world about whether live surgery should be transmitted. This is why it's good.
Yeah, but obviously it's a very personal thing whether you are comfortable to do it or not. So you are, you have done it, and it's always you take some, risks, obviously. So, but I think it's important, and as I told you many times, that Lion Web was one of my main educators, and that's the reason why I'm really happy to contribute.
Well, we're very happy that you're there, because Arno, what surprises me and what's nice is the innovations and the alternative procedures you do. Very good. It's very much appreciated, and it helps in education tremendously.
So I will just improve my exposure here, and if you want to move around,
yes,
then
we will go to Hanover
to do it, and
we'll come back maybe in 15 minutes, 10 minutes. Yeah,
great.
And we first try briefly to go to Austria to see if Austria is now connected. John, can you talk for a moment?
Okay. Yes. So Austria is St. Pölten. We tried to get through earlier on, and we only got a brief image. This is George Sprindle and his team. I don't know whether they can hear us. George, can you hear us in St. Pölten in Austria?
Yes, we can hear you. But we are not so far. We are doing the preparation.
Okay, but it's working anyway. We'll be back with
so we've got a connection. So maybe if we come back to you in you say 15-20 minutes, would that be convenient? Or longer? Okay, we see you in between 20 minutes and 30 minutes. See you later, George. Okay, Wilco, where would you like to go?
I want to check New York University.
Oh, fantastic.
But I'm not sure if the camera is on or what's going on.
Yeah.
Hello, Tom. Can you hear us? We are now briefly connected to New York University. And we don't have the image yet, but maybe you have the image switched off. If that's the case, that's fine. We'll start later on. Looking for it. This should be it. We don't have.
Maybe Emma, while Wilco's doing that, Emma, do you want to comment on the problems that Arno was facing there, or are you happy that's a good decision, or do you have your own views?
Hanover, Niels, we are back with you. Niels? And John, we're still with you. Okay.
Yeah, I was waiting for Emma, whether Emma wanted to make any comments, because she's obviously far more au fait with cochlear implantation than a mere middle ear surgeon like.
Yes, please keep on repeating that, John. That's
it's my waiver.
This is something we touched on earlier with Napoli, which was using a slightly alternative approach to get access to the cochlea. And there are a number of different options that can be taken. And today, both surgeons who've come across that have taken the option of lifting up the eardrum and doing a combined approach to the cochleostomy or to the round window.
Yes. Well, I think it's wise to have a couple of tricks in your tool bag if needed. Of course, John, well, let's not talk about John anymore. But anyway, it's very good that in England it also is present at certain sites. Is John still listening in? No, I don't think so.
I am still listening
Oh,
in. Yes,
okay.
I'm recording this, Wilco, ready for my court appearance with you. Yeah. I think this is the thing about a talented surgeon. You can always tell when somebody's talented because they have half a dozen different solutions to a difficult problem. If you start doing an operation and say, I'm going to do it this way because I've always done it exactly this way, you're going to run into difficulty. When you're a trainee, you want to go and work for 7 or 8 different bosses. And maybe if you pick up 1 or 2 useful tips off each one, you'll improve the specialty by 10% by putting those together. I think it's really important.
That's exactly what I say to my trainees as well, which is that if you ever work with a surgeon who has one way of doing things, learn from him or her as much as you can, but then learn from someone else who does it differently. And then when you get the challenging cases in your own practice, you've got a lot of different tools in your box to use. And I completely agree as well about traveling. I think if you can travel to as many places as you can and see as many different techniques as you can, you'll make friends in the process as well. And yeah, travel is something I really hope gets started again this year.
Yeah, from a diplomatic point of view, you should always listen to what your boss says and do what he says while you're working from him. But I had a boss long gone now who stood behind me on my first day as a consultant and said I wouldn't do it this way. And I said, well, I've worked for you for 4 years, and finally I don't have to do it the way you do it. And that got rid of him. So be diplomatic while you're training, but once you're a specialist in your own right, you can develop your own techniques.
Yeah, when I was doing one of my first solo lists as a consultant, a number of colleagues came into the operating theatre to see whose technique I was using. And my diplomatic approach was to tell them that I was using Richard Ramsden's technique because he'd already been retired for 8 years.
Yes, nobody was going to answer him back. Right. Right. Do we have any more? I don't think we have any more questions at the moment. Have we got any more polls that we can put up while we're?
Yeah, I'll stick some more polls up. There's a couple more.
And then if we do that, and then maybe if Wilco,
we go to Hanover for a moment.
Okay, we'll do that, and we'll have a poll in a minute.
Hello, Niels.
Hi, Hanover. Can you hear us?
Yes, I can hear you very well.
Okay, we've got a good picture of your operating stand. All very highly organized and keeping with German.
Yeah, this is Nina. She's very experienced, and she's with me today. And we just start now to open the packaging of the Dexel electrode. Maybe I can show you on the macro camera, the other one. That one. Könnt ihr es da drunter halten, dass Dagi das sieht? Can you switch the camera, please? Yeah, okay. And this is the humidity check, because the dexamethasone, it would not work when the implant got wet or too humid. So you see the scale and just to check that the implant is all right. And now we are allowed to open it. Cornelia, wenn das feucht wäre, wäre das rot, oder wie? So I just ask the stuff from Mit-El. So if the implant experienced, let's say, more than 20% of humidity, then it would turn red, and it doesn't. So this implant is dry, it's all right, and we open it now. The other difference compared to the usual Flex 28 electrode is that we are not allowed to touch the electrode, and we are not allowed to measure the impedances in saline as we usually do, or in Ringer solution, because that would start the process of the burst release, and we want that to happen in the perilymph. So we open it now.
If I understand correctly, then the release is not a gradual release. It's a high medication release. It's a special reason for that.
He explained this to us earlier. He said there's an initial burst of release, and then it continues at a lower dose for 100 days. Is that correct?
Thank you for rubbing it in. I've been.
Yeah, that's correct. So most of the dexamethasone, like the strongest release is Nina, is after the first seconds of the electrode. You know.
It's all a bit like the president's first 100 days in office.
Should not have happened.
Niels, it needs to stay dry, I think.
Yeah, okay, the electrode is dry.
Try again.
The picture is frozen. Yeah.
Wait,
No, okay, now we place the electrode in the bed. Protection.
I have no. Yeah. We have no feed on vMix Cool. Yeah.
Oh, you only see my head. So I put the electrode that's in a plastic cannula. So I will I will protect it when I pull it through the tunnel. Peeling.
So Niels,
Do
could
we have a
you
feed from the microscope?
could you center the camera, please?
Yeah, you don't miss anything. Let me just pull it through the tunnel.
Okay.
And then I use the microscope, and I want to show you the DEX eluting part of that electrode.
Okay.
But we do that under the microscope. Ja, gerade nicht, gleich, ne? Haben wir irgendwas, was nicht weiß ist hier? Nee, ne? Doch, das mal bitte umgedreht. Jetzt sieht man es genau. Davor, da hatte ich meinen Kopf da vorne. Okay, now you have the microscope picture?
Yes, we have.
Okay, and
Yes.
We start here with the basal part of the electrode, and you see here it has that notch like all the Synchrony 1 devices, and then it's ja, ich muss mal ausfahren. So, Nadel bitte. And here you can see it. This is contact 1 at 12, 11, 10, and here you see the first ring. Can you see that?
Yes, we can see that.
Yeah, that's the DEX eluting part of that electrode. Okay. And there are 8 of these rings. They don't start immediately after the entrance of the round window. They start after 3 contacts. And you see then there's one of the rings between every contact except the last one. It's probably due to the stiffness of the tip, because you don't want to, I don't know, have it stiffer or anything, that you are still as atraumatic as you're used to with the flex electrodes. Okay. And as you've seen, this should always stay dry before it enters the perilymph. Jetzt bitte den Button. Ja, ist alles vorbereitet, zeige ich.
So I guess it's self-lubricating as well. Is it self-lubricating as well then?
You mean if it's lubricated?
Yeah, if you don't get much perilymph coming out, does it lubricate itself?
Yes, in the perilymphs. And I mean, it's a flex electrode. You touch the facial or the chorda, that you cannot really avoid that. But it's just important. I mean, usually we keep that in water for a couple of minutes and make measurements. You just should not do that. So now I show you the setup for the cochlear microphonic measurements. Können wir das wahrscheinlich von oben machen? Okay, so we have like earphones in the outer ear canal. Yeah, this is connected to a machine from us. And then here is the coil already in place. And on the right upper side, you see that's quite nice. We can do that with the ARRI microscope. You see that we have a picture-in-picture, and I can see the measurements that my colleagues do while I'm inserting. Mal bitte 1,5er Sauger. Okay, one moment. I want to pull back the implant a little because the coil is so stiff. Feeling? And then I have a little more space. Okay. Sarah? Ole? Mal kleben. Haben wir guten Kontakt? Können wir das sehen? So we check that we have a good contact with the coil. Otherwise, it's a little annoying when you're inserting and you have to reposition it or anything. Good. Achtung, Elektrode. Sauger bitte 1,0. The round window is not open yet. Mhm. 0,7er. And scharf sehen? Yeah, very good. It's with the cochlear knife. The cannula. We use a cannula to open the cochlea.
John and Niels.
Yeah.
We can stay with you for a little bit more longer, but we also would very much like to go to George Sprinzel.
Okay.
Now, are you going to insert the electrode now, or are you still busy with the preparation?
I have to prepare for like 2 or 3 minutes.
Okay. Let's see if it
because
works.
There's still a false membrane on it that I did not dare to remove before.
Okay.
But I have to, otherwise I don't get a good access.
Yes. Okay. We'll try to be back with you in 2 minutes, 3 minutes. We want to say hi to George Sprinzel because we have not been able to connect, but I think it's going to work now. And if not, we're back directly with you. Hello, George. Can you hear us? Now connected.
Hello, George. It's Sam Polton. Can you hear us?
Well, they should. Yeah, there's definitely doing something.
Yes, we can hear you.
We can hear you.
Fantastic. Fantastic. That's good sound. So
We can
George,
hear you.
okay, we can see your presentation. Maybe you could talk us through the
And we can
presentation.
hear you too. Yes.
Yeah. So the second surgery performed by Professor Sprinzel today is a round window vibroplasty on the right side. In this case, we have a 40-year-old female patient who suffered of cholesteatoma on the right ear. So she had to undergo a radical mastoidectomy with partial removal of the ossicles in year 2019, a type 4 tympanoplasty. Due to combined hearing loss on the right side, she was provided with conventional hearing aids, but she suffered in time from ear canal inflammation, so she had to consider an implantable hearing device as an alternative. In the audiometry, you can clearly see the bone gap on the right side, hearing threshold reaching between 60 and 80 dB. The CT scan showed no contraindication for the round window vibroplasty, only a partial shading of the mastoid bone on both sides. The MRI was also without relevant pathologies.
Yes, very good. Yeah.
I will hand over now to Professor Sprinzel.
Yes.
Hi, Leah.
Hello.
Hello, George. Can you hear us?
Yes, I can hear you finally. So it was so.
Okay.
So
it's John here. We've just got
unfortunately.
we've just got a picture at the moment of well, it could be your ceiling lights or your Christmas decorations. I'm not sure which. So we're probably on the wrong camera at the moment.
Can you hear? Oops, something went.
This must be the microscope.
Yeah, maybe the microscope. Yeah. Now we
So we're just moving the microscope in my direction.
Good.
I'll give you
Good.
shortly an
Good.
overview.
That's good. That's good. That's good.
Okay.
At least we know you're there.
So here we go. So I marked already the field of interest. I'll give you an overview here, here.
You've infiltrated with epinephrine, adrenaline.
Yes, and as Dr. Perberes is in my team,
Sorry, George, your sound is and your picture is frozen.
already that the surgery beforehand was there. Happy with that because
So Wilco is breaking up as you can.
sometimes it's easier to have here a little bit in, but I don't. Implant put in already super incision elevator. We did the surgery beforehand, which was very nice. So I had the chance to do a cochlear implantation with preserving a residual hearing in that case. Messer bitte. And we did intraoperative measures for that. So we have a system to.
So
check if
what we're going to do. What we're going to do, George, the sound's improved again now. We have to go back very briefly to Niels Prenzler because he's going to put the electrode in and we can't wait. So we'll come back to you in a few minutes if that's all right. That's great.
Yes, of course. Perfect. I'm happy that we have now a good communication, and then we will.
Yeah, well, we've got a really good picture.
So
it's a great picture.
Okay.
Perfect. Great.
So Niels, can you hear me? It's John Oates here. We're back with you.
Yeah, I center for you. I have some struggles identifying the area where I can insert, because there was some ossification at the round window membrane. Maybe this is in this patient due to some inflammatory processes. I did not really see a usual round window membrane. It was quite thick and there was bone behind it, but now I think I opened the cochlea quite carefully, nadelleicht geschwungen.
Yes, we can see that. There's the impression of a little bit of edematous tissue there. Yeah.
Yeah. Try to do it as careful as possible. Not to suck at the round window, but I need to identify a lumen.
There seems to be a little bit of perilymph oozing out. I can see that.
Yeah, but I don't know if it's enough to
yes,
get the electrode in. I wasn't expecting that. Nochmal bitte 04er Arbeitshäkchen.
So this is one of the difficult decision-making times you come across in cochlear implant surgery, where you've got a patient where you want to preserve hearing thresholds, but actually you could really do with drilling a bit of bone away from the round window.
Yeah. I mean, in this patient, he will not benefit from his residual hearing. But of course, I mean, not just because it's a study, we always try to be as atraumatic as possible. But this is not a usual round window here.
No.
Or maybe he had a second false membrane. I cannot exactly tell now. I try to look very carefully here. Jetzt mal bitte ein Schippchen groß nochmal. Ja, ich bin da eigentlich schon sehr weit am Rand. Da schon der Stab ist. Okay, gut, dann mal bitte einen 1,0er Bohrer. Maximale Umdrehung 3000, Spielung 5 intermittierend. I will now drill underwater a little bit more of the bone surrounding the round window area.
John, I think we need to go to Kuopio a little bit.
Okay.
Okay, and we'll keep an eye out on what you're doing.
We're going to try and go to Kuopio for a few minutes to find out how Arno's getting on.
Hello,
Arno, can you hear us?
Yeah, I can hear you. I was just waiting. Good. So, Imo, I will demonstrate. So, I thought I could make a premiere here. So, I've never done a retrofascial insertion right now, but in that case, I think it might be appropriate to do it. Mm-hmm. So the facial nerve is actually exposed at that point, where I can see that here we have the facial nerve. So I opened up the retrofacial cell, and we can go retrofacial now. And I will do a cochleostomy because it will be a bit more difficult to get the electrode targeted right. So here you see that here we have the tip of the electrode. This is a dummy electrode, so no problem. So, but I think that the space will be okay if we have we have the round window membrane, and I will do a cochleostomy and try to insert the electrode from the retrofacial area. So I will now prepare the implant bed, and then I will do, when everything is ready, I will do a cochleostomy with a 1 millimeter burr, and then wish me good luck for the insertion.
Good luck.
We're crossing our fingers for you.
All right. Okay.
Luck is when preparation meets opportunity.
We go back to Niels.
Right.
Niels, so back to you. Hello, Niels.
Okay, Niels, we're back with you. So you're doing some drilling to try and improve the.
Yeah. Now I see something like a lumen. I drill very carefully.
And this is a 1 millimeter drill, just
1 millimeter,
very
right?
Slowly, very slowly.
Yeah, it's I chose a maximum of 3,000 rounds per minute, so I cannot accidentally fall into the.
Yes. And is that the main drill, or is it a micro drill that you're using, a Skeeter or
No,
a
it's
PNR the big one?
No, it's the same drill. We tried new drills from Medtronic with even longer hand pieces, which are also very handy for that purpose here. I just have to remove more and more bone. I need better view, otherwise it doesn't make sense to start the insertion. I really need to be sure to hit the scalar.
Okay, Niels, then we can go briefly to Austria, and we'll be back with you.
Yeah, I take my time here, sorry.
No problem at all. I mean,
no, you do what's best for the patient, not for us.
But our essence is that we need to share a little bit if we can.
Yeah.
So we now go to Austria, but we keep an eye on you.
Yeah.
Okay, we'll be back.
Yeah.
Hello.
Okay, George, we're back with you in Austria. Can you hear us?
Yes.
Good.
John?
Hello.
It's John here. We're back.
Yes.
We're back with you, watching you in Austria.
Oh, perfect. Hello again. So I'm just elevating now the flap. Bleeding a bit, so it's not so easy at the moment, but I will handle that situation hopefully soon. So first issue is to elevate here the flap from the external auditory canal. And I think that the tympanic membrane is lost beforehand, so there was simply no membrane.
Well, I guess you're just fine. You're fighting against the fact there's been a lot of chronic inflammation, aren't you? Which is always a problem, despite low blood pressure and adrenaline and everything else. It's very difficult to control.
Well, at the moment it's tricky, but I hope I can handle it. Yeah. Bitte nochmal das Rundschnittmesser. So, I think down here we have somewhere the stapes, as it looks like. Here is stapes, yes. I just need to elevate the flap. And of course, the first issue will be to enlarge a little bit here the access to the promontory. and to the, well, I would say remnants of the middle ear. Always a challenge when you do surgery in a subject that you have never seen before, and to give him a implant. So here we're at the bottom of the external auditory canal. Here we have the promontory, and step by step, I'm getting a little bit more overview. I just need to give you a bit of
We'll be back with you then shortly, George. We go to Niels Prensler for the moment, and then also we need to visit.
I have a lot of status here.
Yes, we can see that. We will be back with you in a minute, okay, George?
Yep.
Okay, John. Hello, Niels. We're back.
Okay, Niels, we're back with you. It looks as though you found a lumen there. Is that right?
I found a lumen, right?
Good. Well done. Well done.
And now I will. Yeah. Yeah, I mean,
it's a really good exposure now. That bit of drilling was really worthwhile, wasn't it?
Yeah, maybe it's a perfect case for the DEX electrode to prevent further ossification of this cochlea. But I mean, I did some kind of a cochleostomy. I drilled it open, but still we see if we can preserve residual hearing, which, as I said before, is not like that most important part in this case. Okay, now I touch it very carefully. Können wir jetzt einblenden? .07er Sauger dann. .07er Sauger. So you see that electrode does not enter the cochlea as it is supposed to be.
We can see that it seems to hinder somewhere inside the cochlea.
You see it's buckling.
It's flexing, yeah.
Yeah. That does not make sense with a flexed electrode. I was able to insert it like 7-8 millimeters, but then there was a resistance, a strong resistance, and I could not proceed. I will still need more time. I will have to open it a little further to really look for the basal the basilar, the basal turn.
No problem. Then we go to Cupio. We go to Arno Dietz, and we'll be back with you. Take your time, Niels. We have all the time that we want.
Ja, muss ich jetzt machen.
Arno, we're back with you.
Hi.
Hi.
So I have drilled the implant bed. I'm a bit running out of time. You must remember I'm doing it under local anesthesia. So this is obviously not something we plan to do, because now it's a different approach.
I know. If you prefer, we disconnect. That's no issue at all. Huh? If you prefer to do the surgery without us.
No. No, you should stay, because this is something you are not seeing very often. So this is very important that you stay with us, because now I'm drilling the posterior, the cochleostomy, and then I'm ready to put the implant in and insert the electrode. So this is now the crucial step, and the most interesting part of the whole story here. So that would be the same that you would follow a soccer match, and then you are going to get a bottle of beer, and then the only one goal was shot. So this is not something we would like to do. Pieni imu. Vähän poispäin kallistusta. Vihreä. So I will do it with the 1.0 cochleostomy burr, and this will accommodate for the Slim J electrode. And in this case, I would say that it's a good electrode, because it's not too flexible. In these cases where you need some kind of pushability, so to speak, to get the electrode inside the cochlea. So now we see the round. Vähän minun päin kallistusta. So, ihan pikkusen. I have prepared already the bony overhang. Kiitos. And here you can see a bit of the round window. There's some. Can you see it? I'm not quite sure, because the exposure is a bit, I would say, a bit tight.
I think we can see it almost. Yeah. No, we can see it now. Yeah.
You see it almost.
Let's see it fully.
We can now see it fully. Yes.
Okay. Now here we have the round window. We have a false membrane here on the round window, and what I will do, I will enlarge it here in that place, that I will get a better insertion angle, because what I'm now concerned is that I have enough what I call pushability, which is I don't know if that's an English word or not, but
we understand.
Yeah, that's acceptable. Yep.
It's acceptable. I'm glad. Pieni hentopisti. Okei. No, en mä tarvitse sitä. Nyt mä otan sen poran ja cochleostomia ohjelma ja huhtelu pois. Okay, now I have, hopefully you see it. Ja se on 1 millin. Ykkönen.
You could see even the false membrane.
Yeah, just to wait for the right size of the drill, and then we are ready. And then it will be interesting to see what happened. Now I have decided to change this procedure in favor of just doing the implant surgery, and we will do no measurement, because the measurement would add to the time, and we are, as I said, we are running out of time a bit. And now I will bit enlarge the.
Dat is lastig wat hij doet, hè, met die elektroden daarnaast.
Pardon?
It's difficult work to do with the electrode around.
Yeah. So let's have a look how it. Now I will enlarge here a bit of the bony overhang a bit more. Now I'm concerned to have a good insertion angle. This will help to get the electrode in the cochlea. So I will float away with dexamethasone and dexamethasone to get the bone dust out.
Okay. I hope you excuse me. I want to try to connect briefly to New York for a moment.
Okay.
But we're close to you. We'll be back in a minute.
Come back in a minute.
Yeah.
Hello,
all right.
Tom Rowland, can you hear me?
Okay, Dr. Bill.
Yeah, we can hear you.
Hello, Tom. Can you hear us in New York? Tom Rowland in NYU. Can you hear us?
Now we just get over the edge. So there's the top of the canal.
Yeah, well, what to say?
It's got a great picture.
Sometimes I could draw.
So Tom Rowland is. I haven't got the details of the case in front of me, but he's dealing with a CSF leak, which wasn't the case he originally planned.
Our sheet, so that's good medially.
Just try and find out what's going wrong with the sound.
I'm working on that, John. I'm happy that we have.
I'm sure you are, okay. You can see he's just pushing the Dura back to try and get a better view.
There. Yeah.
I guess he's probably going to just remove a little bit more bone.
Can you hear me?
We can hear you. Yeah, can you hear us?
Can you see me?
Yes.
Yes, we can see you very well, actually. Very nice.
Can you see? Oh.
Can you hear me talking, Tom? No.
Hello?
Hello?
Hello, Tom. Can you hear us? We can see you. We have an image from you from New York.
There further.
Can you hear us, Tom?
I think it's okay above the ossicles. This is the superior inguinal ligament. There's the malleus, incus. A little bit of wedge and stuff in there. Okay. I think that was the area we saw, that little pouch of spinal fluid probably opens and closes.
You can have there.
Okay, irrigation.
CSF leak.
Well, I guess we're seeing the sort of the lateral canal on the right, the level of the middle fossa dura on the left.
It is
and he was just dissecting around the ossicles, wasn't he, core? So the ooze is coming from, I think, above and anteriorly, isn't it?
Yeah.
Okay.
You can
about
have
11:30
there
on the top face. Don't actually know what the cause was in this patient. I don't know, maybe spontaneous. I'll see if I can find the case records. Wilco might have them.
And I'll take the bone plate and a mosquito and a big diamond.
Fussy.
I'll thin our bone plate. We're ready to patch. So I'll stuff I'll cut a piece of the fascia, and I'll thin the bone plate, and I'll make little beveled edges and sort of slide it in that way, and then slide it back that way, lock it in place, and then I'll plaster it with some bone pate to give a nice 3-layer closure.
Hello, Tom.
Very, very well.
Tom, do you have an audio in your OR? Tom Rowland, we can hear you here from the Netherlands, from Utrecht. Can you hear us?
You could put it on Diamox. It probably wouldn't hurt to take it once a day. BID, like 250.
Okay. John, we need to go to Kupion, and we need to go to.
She's already had a workup for sleep apnea.
I would suggest we do that. Yeah.
Okay. Hello, Kupio.
Hello. Now it's the, I would say, the highlight. So
yeah, that's why we're with you.
We have.
Oh, we're waiting with bated breath, Arno.
And we wish you luck as requested. Yeah.
Me too. So all right. So
we're waiting to see your push or your thrust. If you
cochleostomy opened, and now it has to go this way, and hopefully I will not spoil the electrode. But we'll see.
It looks very similar to what I've done in the past.
Okay.
Just do it.
Just do it. I have to find the right
passageway.
Right.
No.
Place, because the dummy electrode went through, but I'm not quite sure this will. I have to be a bit more careful. So I guess there you see, there you have it. You are not allowed to let loose. And let's have a look whether we can somehow guide it, because the dummy electrode, it's a bit more flexible like this one, so this should go, and about the same size. So, but somewhere it's stuck still. Now I have to check now. Doesn't work out yet, so I will have the suction. And see, because we had here for the dummy electrode, I found quite good space. But let's see whether we can. Oh. Okay. It hits to some structure, I don't know, because it's difficult to see, because I have no, an endoscope would be perhaps quite feasible in that case. So in case I get problems here, then I will certainly use an endoscope. But let's see whether we have it through. Okay, I will try it again. And here you have to remind that this is a half bond electrode, but I don't think you really mind about the vähän minun päin kallistusta. Ja sitten imu. Pikkusen vaan here. Yep. Let's have a look where we have the tip of the electrode. It's a bit. Kato, se on mullekin epätarkka.
Okay.
Well, I have to prepare the retrofacial approach a bit more.
Yes,
so
okay.
You can be back in a few minutes. So I'll try to make a bit.
We're going to try New York University first if they have audio. If they have audio, we'll talk. Hello, Tom Roland. Can you hear us, Tom? No, they even disconnected. Okay, then we go to Hanover.
Any chance of Austria again, or do you think that's
No, that was dialing in, maybe for the audio.
Ja, da ist schon der Stab ist.
This was.
Machen Sie mal. Müssen vorne einmal umstellen.
Okay. Tom, I think you can hear us now. Tom Rowland, can you hear us? I need to check your audio.
Yeah.
Tom,
Can you guys turn up the
hear
room
us now?
volume, please?
Hi, Tom.
Hi, can you hear me?
Yes, we can. We can.
See
I have to
anything?
admit, it was my mistake. My
Okay, no.
fault. My fault. I did something wrong. Yes,
Do
we
you
can
see the
hear you. Very good.
Can you see what I'm doing?
Yeah.
You're sculpturing a plate of bone, I think, or cartilage, which you're going to use as
perfect.
a plug.
All right, I'll go back. So we started the operation. So this lady had a CSF leak of spontaneous etiology. She has a high BMI and some sleep apnea, which we discovered. And so what I do is I do a mastoidectomy, but I leave the cortex. I drill around it with a 3 cutter, and then I take the cortex off, and now I'm just thinning it. This is going to be part of my reconstruction. I also hold this. Give me the fascia block. I also take a nice big piece of. Let me have a duckbill, please. Nice big piece of temporalis fascia, which we'll use for part of the reconstruction as well. You can see that. And now let's show the 5 suction and the irrigation. So if you look at my preoperative CAT scans and MRIs that I sent you, all of her dehiscences were lateral to the semicircular canals. So she had kind of a lumpy, bumpy mastoid tegmen and a few little dehiscent areas here and there. These were not leaking, did not have encephalocele. But Rose and needle, please. Down here in the depths, here's the horizontal semicircular canal. Here's the superior canal. And there's the, this was brain tissue hanging down into this area, which I amputated and cauterized and got it up. So here you can see, that's to the duckbill. This was all exposed dura with a meningoencephalocele. There was a little cyst attached to it. It was full of CSF that would open up intermittently. Now you can see I can elevate the dura up and over the superior semicircular canal. You can see that.
Yeah.
Now many people, and she was told by several people to have this done through middle fossa craniotomy and roof it, but I told her I think I can do it through the mastoid, and it can be an outpatient procedure instead of a intracranial operation in a day in the ICU and then maybe 3 days in the hospital. So here, I got the extended stuff, so it goes up to about right here. So you can see the defect, and there was brain hanging down here.
Yeah.
There was brain hanging down here, and that's all been cauterized and removed.
Yeah.
So I'm just about ready to do the repair. Rose and needle. You can see here how low her brain comes down, almost to the level of the external auditory canal. I'll put some bone pate. That's iatrogenic. I did that in trying to find the tegmen, but then the tegmen goes back up here. Rose and needle, please. Here you can see the incus, the head of the malleus, incudal ligament, lateral semicircular canal. This is the extent of the cephalocele. It stops there. So I'm just about ready to carve my bone and do the repairs.
Yeah.
Great. So Tom, I heard you mention acetazolamide. Do you employ other measures than surgery, such as medication and weight loss plans for these patients?
I don't do any other measure in surgery. She got some Decadron. She had a sleep apnea workup and is going to be on CPAP. We were talking about maybe giving her Diamox pulse
Yeah.
up for a few days to lower CSF pressure, but I usually don't. That can cause headaches. We were thinking about with her. She had an ophthalmology examination and had no evidence of papilledema. She does, on the image, maybe have empty cellar syndrome, which might be consistent with intracranial hypertension. We did
Yep.
not do it. We did not do a lumbar puncture and do an opening pressure or anything like that. But I do almost all my meningoencephalocele through the mastoid if I can. It saves someone, you know, it's a lot more cost effective, a lot safer than doing a middle fossa craniotomy. I have duckbill. Sometimes if I have a big defect here, I'll make an opening in the bone here and I'll elevate the whole middle fossa with a freer elevator and slide the reconstruction material in this way, the big pieces of it. But this one, it's all down here. So I'm going to tuck it in this way, which I'm going to start doing soon. I just want to finish carving the bone now.
Yeah.
I'll take the wet sponge again. I had another case for today, a pediatric auditory brainstem implant, but unfortunately, the mother tested positive, the 4-diamond, tested positive for COVID 48 hours ago, so we have to delay the case. So you can see this bone plate was pretty thick. I'm just going to thin it to slide into place.
Okay.
This will take me a few minutes if you want to.
Yes, please, because I see Hanover is going to insert their electrode, and I see that actually Kupia has already done it. Kupio. Hello, Hanover, quick with you.
Oh, here we go.
Hello.
I think we have a case of obliteration.
Uh-huh.
And what I did is was just to, well, I have to get a bit better organized here.
Can we come back to you then in a couple of minutes? Then we go to Kupio for 1 minute.
Yeah, you see here, you see here that we just did remove some bone here,
yes.
And it's kind of in the depth. I think could reach the point where Dr. Brenzer found a resistance, and now I have drilled a bit further anterior, and now let's see that we get the electrode in.
Do you want us to wait?
So
or can we go to Kupio? Because Kupio is...
we try, and then you can see. I mean, if you don't succeed, then
okay.
You can go.
Oh, no, then we stay.
If we don't succeed, then probably we have to do more and then decide what we do. It has something to do with also some regulatory stuff. So I think we still not able to proceed. I have to use this so-called the electrode guiding tool or so. Mm-hmm. And I think before that's the kind of, wir brauchen das, es hat keinen Sinn sonst. Wenn man den neben diesen diesen Bushy.
Intercochlear fibrosis or something. I saw that.
Something like that, but it's where you see it's not like bone, it's kind of tissue and a bit of blood. I try my best to avoid that, but I can't actually do it in a different way. Nochmal bitte nochmal den Bohrer bitte. I drill again and see that I get it a bit better exposed. The one trick could be always that you go for more straight trajectory, you know?
Yeah.
Which means with the cochleostomy you probably get it. Or if you go in this direction, then probably you can have a more straight insertion. Yeah. And then we can try again to get it in.
We'll be back
but I need
in 2 minutes, Thomas. In 2 minutes.
Yeah, okay.
Okay. Kupio, hello. I saw you were waiting for us.
Yeah, I'm waiting just to show you. I was, sorry for not waiting for you. There was some bone bone fracture actually, which was in the way. I removed that, and now we have, I don't know whether you can see it here, we have the electrode already inside the cochlea.
Yeah.
So the insertion process as such was very easy, because from the retrofacial you have actually a very good insertion angle.
Yes.
So, but this is also now an approach how you can do it in difficult cases like this one. So I think, I don't know whether you have showed it already in the Lion web. Most probably you have.
Yes.
But now this is actually what it looks like. We will seal the cochleostomy opening with fat.
Okay.
And then we will close up.
Okay. Thank you, Arno. Thank you.
And
Go to Hanover.
Yeah.
Okay. Bye.
All right. Thank you. Bye bye.
Hello, Thomas. We're back with you. It's going in.
Mal zu. Ist drin, ja.
Ja, geht's jetzt.
Pinzette bitte. Lass mal zu.
Aber trotzdem Special Case.
It's always good to do special cases.
Ja, richtig weit aufgemacht jetzt, ne?
Naja, ist halt so. Fürs Felsenbein-Labor, ne?
Nochmal bitte.
Fürs Felsenbein-Labor.
Ja.
Ja, das ist ein, ich sag ja, das ist noch nicht ganz drin, ne? Deswegen haben wir, geht aber rein. Hier mal die zweite Pinzette.
But you're at least past the first obstruction that you had, eh? And it's now further, but not fully inserted yet, is what I hear you say in German.
Yeah, it's inserted. I just could pass it. I think this was his point of resistance. It was in depth of a few millimeters. And now I think it's inserted. So we'll make measurements and then we see, no?
Okay.
But we should have responses.
Yes. We go back to
Sauber bitte.
Thomas, sorry about that.
Okay, but interesting case, no?
Yeah, very interesting. Well, I saw you, we didn't transmit that, but I saw you with a small curette opening a little bit of the fibrosis tissue.
Yeah, this is our operating theater for special cases here today.
Yes, but it's fantastic. It's very nice. Okay, and we go to New York. And do you have another case after this, Thomas? I think so, huh? Or are we finished?
Okay, thank you.
Okay, bye. Hello, Tom.
Five suction.
Tom, we're back
Hi.
with you.
Hi. So I've thinned that bone plate, and now I'm
Yes.
measuring my encephalocele, my defect. So this is going to be about 1 centimeter, and I'll make it a little bit larger to overlap
Yes.
in that direction. And then maybe one, two, about 2.5 centimeters in the other direction. Where did it go? Did it fall in here? There it is. Okay, she's got it. All right, let's see the bone plate and a marking pen. So this is my that cortex, which I thin now. What do they say? 2, almost 3. 1, 2.5. There. So this full length. And I said about 1 and a bit wide. So this piece will work nicely. And I'll make it to about right here. And I'll use this other piece. Okay. That's how the 2 diamond. Is there a smaller diamond or is that the smallest? Let me have the 1.5. Give another mosquito. just so it doesn't fly off another part of the room. You can hold that other mosquito, Hannah, if you could. Wilco, are you there?
Yes, we are. Absolutely.
Any questions?
Yeah.
You know any good jokes?
Ha! Oh, putting me on the spot there. Give me 1 minute.
I have one for you. I have a clean joke.
Okay, that's decent.
Two Doritos went to a horse farm. What did one say to the other?
That's a good question for John.
He said, "Cool Ranch."
That is a proper joke. Yes.
You have to be a Dorito lover to understand that.
Yes, that's clear.
I have one more if you want it.
Yes, remember.
I just wanted to put on record. I don't get Doritos. They're very well marketed, but
yes,
they're not as good as potato crisps, are they?
They're not
I have
the
a
same,
clean,
John.
dirty joke.
Well, remember, it's live on the internet. Whatever you do.
This is live. It's there forever.
Okay, that's why it's clean and dirty at the same time.
Yeah.
Why did the urologist use 2 fingers for the prostate exam? I know it's live.
Because
I know what you're thinking.
The third wouldn't fit.
Oh my God. No. See, you're thinking in the wrong way. The patient wanted a second opinion.
All right.
Well, we have to cut this. Cut.
Yes, I mean that's along the lines of the urologist, isn't it? Describing gynecologists who only have 3 operations: cut the right ureter, cut the left ureter, and cut both ureters. But
let me see the gonna be too long.
Tom, just a simple little question. I'm intrigued by your little tape measure. Where does that come from? The little tape measure you used?
Normally, when you get a marking pen in the OR, there's a little plastic ruler with it.
Yeah, so you cut it down, or
I just cut it. I just cut it very thin. Yeah.
Right. Well, you know, that's one of the best tips we've had today. So I'll just repeat that for everybody listening. When you get one of those,
exaggerating again.
Yeah. No, it is a good tip. It is a good tip.
No, you said
isn't it?
the best
when you get
tip.
that orange marker pen, what Tom's saying is he runs the scissors down it. And that is a really clever idea. Well done, Tom. We'll call that the Roland modification.
I just invented that this morning.
Well, I'm impressed.
I was so inspired by the intellectual content of this meeting that my brain is on fire today.
Well,
but you know, we picked up little tips.
Tom, cool down. I need to mute John. I mean, if you consider John, I wouldn't fry my brains over it.
Okay. Scissor, please.
But you know, as a point, Wilco, we do pick up these little tips. I mean, Chris gave that very good tip about the little beaver blade yesterday, which is has been a great help to a lot of stapes surgeons. And these are the sort of nuances that are so useful from this type of demonstration.
Okay.
And I'll take a scissor.
Okay. After this, we need to go to Austria, John.
So it's kind of a 3-layer closure. The bone and the fascia go intracranial, and then some bone pate goes on the outside. Okay, let's have a duckbill and a 20 sucker and a Rosen needle. I'll tell you what, Hannah, if you could save this, give me a smooth forceps. Save that fascia. Okay, first thing I like to just put this into place. Then I start tucking it up and over the superior canal, like so. And start tucking this all the way anteriorly. That's working quite nicely. So it's extradural, but intracranial.
Okay.
And we get it up under the edges. You know, it's interesting. When I was in training and we had anterior skull base leaks, we were always taught to use rigid things to fix it, you know, like bone or other stuff. But nowadays, in the endoscopic sinus world, they fix anterior skull base CSF leaks all the time with just soft tissue and alloderm and glue and different things. They don't. Now, it still might be a little big. I'm going to give it a shot.
But you know, Tom, fascia's great stuff, isn't it? One of the most useful tools in otology.
Yeah. Well, the nice thing about this procedure also, I'm using all the native materials. Let's take the mosquito. I'm going to thin this bone a little bit more and make it a little bit smaller. So she's having her own bone. She's having her own fascia. I guess tissue glue is the only expensive thing I'm using. And which I don't even know if that's necessary. I'll take the 4 diamond. But some people would use bone source and other artificial materials. And I collected bone pate when I was doing initial drilling, and I'll smear that on the outside. And that's not for immediate correction, but that will become a firm layer over time for the future.
Okay,
we have
Tom.
A major effort.
Tom,
Yes.
with permission, I would like to switch for a moment to Austria.
Go ahead. Yeah, please.
I will be back with you in a minute. Please don't go too fast.
Okay. Okay.
Hello, George. Hello. We don't have the water here. Hello, George. We're back with you.
Hi.
Hi.
So
Sorry.
this was a really enemy ear, I would call it, you know, send it to your enemy. First, I give you a small overview about the situation which I had. So in the first course, I could find here residual cholesteatoma, which I removed. So this was here quite a small pocket, and everything was filled with this cholesteatoma. I took it out. So far, it's clean. And I couldn't identify any residuum anymore. And then I checked the situation of the tympanon, which is as follows. So, Freunde, könnt ihr mal, yeah? So, which is as follows. So, we left here, or we have left here the half of the superstructure. So this is the footplate. Give me one nadel, bitte. And you can see here, this is the posterior cruise. The anterior cruise is still missing. And here I packed some gel foam with adrenaline. And I had a very hard overhang of the promontory lip over the round window. And it was quite a tricky work to remove it because you have to do this at a very slow speed with your burr. And finally, I could identify here the round window, and I adjusted it to that size that the FMT will fit here. And when we push it very slightly at the foot plate or at the posterior cruise, you can see the reflex. Oops, here's some blood coming up. You can see the reflex of the round window. Now you can see it nicely, I think. Here. So this is the place here for the FMT later on. What I'm doing now next, I'm drilling here a groove to place the cable here. In the meantime, they fed also the remnants of the tympanic membrane, which is here.
And I will perform later on a cartilage tympanoplasty, close this region here, block this the cable here with bone dust, and then I will upward a implantation bed for my receiver.
Okay, we will be back, George. We will be back with you in not too long. Now we go back to New York, because I think they're finishing off. He's moving on. We'll be back with you in a minute. Okay.
I'll take the suction and the ductile again.
Tom?
Yes, sir. I heard. So I think I've got it down to the right size. If there's a little tissue on it, doesn't matter. Helps make a seal. Now I'm going to try to get this into place. This is always a little tricky. I always oversize it first and then carve it down. I'm going to slide this superiorly. Sometimes if you can't get one piece, you can use two pieces. Looks like it's going. I might have to make it a little bit thinner. Try one more time. I think I'm going to make a little thin right there and make a little bend in it. That's how the I'll take the drill. Got a 2 diamond. I'm going to make a little groove here and just make a little bend in it. And I have a 5 suction, and I'll take the mosquito. So I just bent it a little bit. Okay, maybe it broke a little, that's okay. I'll take the duckbill. So this was going to be the back piece. And this is going to be the front piece. Okay. So this is going right on top of the semicircular canal. And it's locking into place. I'm going to slide it forward as far as it will go. So now that's all intracranial. And this is the back piece. Also going to do the same thing. So on top of the lateral, the superior semicircular canal, and then it's locked up under the dura there. So now
that's nice and snug, eh? You can see that
it's
sticks.
Nice and snug. I can push on it. It's under the lateral. I can back it up a little bit. So it's on top of the superior canal. Nice and snug there. Then I'm going to smear bone pate, but there's another little opening up here. I might put another patch in. I think we're okay. Yeah, that's bone. No, we're okay up there. Now let's see. Let me see my residual piece. I think we're okay. Here's a little bit. I'll put a patch in. Let's see the piece of fascia. You can just cut it in half in a long way. Yeah. You can give me that piece, and then I'll take that extra piece of bone. Yeah. Just drop it in there. Thank you. Nice. So there's some more of our temporalis fascia that I've let dry. That just run. There was no encephalocele here or a leak here. Okay, I'll take the bone plate. Just drop that in there. I think it's just about the right size. Just let me see the other piece. Yeah, let
Tom,
me see that piece.
what you may not realize, I'm here in the studio in Utrecht with Cor Kremers from Nijmegen, and he approves of every move that you make. It's very nice, and he says, well, it's a good trip back to memory lane because he's retired, obviously, but he's very content, I should say.
So you see how the bone is under the bone edge. So that's a nice, and that will form a nice scar.
Ken je hem goed?
And I don't want to jinx myself, but I've had 100% success with doing it this way. And I've saved people I often get patients coming to me as a second opinion, not for how many fingers to examine the prostate with, but a second opinion about, do I need a craniotomy? And I said, if your hole is medial to the labyrinth, yes. If your hole is giant, yes. If your hole is small like this or medium size, I think I can fix it from below and you can go home the same day.
Tom, the problem is...
Tom, you should have been a coloproctologist.
Yes. Yes. It's really...
And don't ever take them seriously if they talk about 18 holes a day. That's...
No, but Tom, you started this. You started the whole discussion. when you have a whole central, I mean, I cannot, it must be a third opinion.
I didn't start it. I'm just the vehicle for your illnesses. I just get you guys going.
I need to write this down in my memoirs.
I think the problem, Tom, and apologies to everybody else listening, is the British sense of humour and the Dutch sense of humour are remarkably similar. It all goes back to William of Orange. We do enjoy.
See, the bone pate in place will then, over the next couple of months, will become another layer. And that will look very nice if you happen to do a CT scan. I don't routinely scan or image these people post-op unless I find a problem or a concern or I see fluid in their ear again. But so you can see her ossicles are still free. I haven't, let me say Rosen needle. I'm going to put some tissue glue in, which will then set against the ossicles and give them a conductive hearing loss, but they're still mobile and free. There's incus, the malleus up front. And this is all, let me duckbill. I'm really sorry we couldn't do the ABI. I think that would have been a fun case too. And it's a real example of great teamwork between a neurosurgeon, a neurotologist, and the audiology team, and how we find the right place and all that.
But Tom, we need to schedule another surgery now that we've made the link and Carlos has it all set up on your end. And if we manage to lose John, we can do this more frequently.
Okay. Maybe if we get the ABI back in, we can do it.
I think we can. John is offended. He's sending me a text now.
Is there any more bone pate in there?
No, I'm just answering questions in the Zoom room, Wilco.
Go ahead. So now you see I have a nice 3-layer repair. The whole, she should do well. This was my iatrogenic ventilation hole. Yeah. Okay. I'll take the tissue glue, please.
And Tom,
I don't know whether tissue glue makes any difference, but I'm putting a little bit over this just to kind of hold everything in place. Not too much.
I think a sinus surgery with holes is done all the time.
20 sucker.
And Tom, antibiotic scheme, you may have said it, but I was occupied with the technical stuff, but you're connected now.
I give them just 1 gram of Ancef, cephalosporin, intraoperatively. I don't send them home on antibiotics. And we washed out we rinsed the bone pate and the bone plate, and also rinsed out the mastoid with vancomycin solution.
Okay.
Duckbill. And I'll take 1 little piece of gel foam that's not wet, just a dry piece of gel. I'm just going to put a piece of gel foam between the ossicles
to stabilize it, to warrant the distance.
Just to sort of, the gel foam will just sort of hold this up not you have a dry piece?
Yeah.
Yeah, completely dry little square.
I mean, this is very nice, Tom. I guess we might see this later in the week. I mean, you may not know, but the sister organisation Lioness has its FEST transmission later in the week, and I would be prepared to put a small wager that there'll be a CSF repair on that. I don't know whether Wilco knows.
But not in the ear, John.
You know,
not in the ear.
No, but it's still, we were talking about the similarity between the FEST repairs, and very similar, very similar.
I think this exposure is better. But anyway, thanks, Tom.
Okay, I'm just going to close up now. We're all done. Thank you.
Okay, no, thank you very much. And we need to touch base more frequently because I think we can do more things that are of interest to all of us for the community, especially now with COVID. Thank you very much, and great that you were able to connect. Thanks to Carlos as well.
Thanks, Tom. That was great. That was a great image, and thanks for the banter. It's lifted all our spirits.
Yes.
Mine anyway.
Yes. Yesterday the toilet paper, and now the
I can't be struck off.
Okay. Austria, we're back with you.
Das dritte Patch schon präpariert?
Yes, we are back.
Wir brauchen noch eins, ne? Okay. So, jetzt pass auf.
Austria.
Noch?
George.
Hi.
George, we're back with you.
Oh, perfect. Yes, so I'm prepared here already the valve for my cable. So just in case I have too much cable from the conductor link, you know?
Yes.
And this is the valve which I will use in order to save here the length. And before I start with the implantation, I will just harvest some cartilage because I need to close the tympanic membrane, of course. And this is not working just here with fascia. So I will harvest some cartilage from the auricle, which is quite large, as you can see. And I think somebody was also there before me, but this doesn't matter because I have a lot of cartilage here to harvest. So this is the last preparation I do before I go now back inside with the implant. So, well, yes. Messer bitte. Schere bitte. Pinzette. I was a little bit surprised because I found during my preparation some cholesteatoma in the sinus dura angle, which I had to remove first. So, and now, of course, the discussion is open whether it's appropriate to go to proceed with the implantation. To my point of view, she is a very clever lady and she has a good compliance, so she will be under control. This is one thing. And the other thing is the hypotympany was completely free. So the disease was somewhere else and not in the region of the round window. And basically, this is also the reason why I'm proceeding now with the implantation, because she wants to hear, she's desperate. Bipolar.
Okay. Ja, maar niet uit.
Bipolar.
Okay, George, we are going to go quickly to, we stay with you, of course, but we go quickly to Hanover because they are doing something as well. I mean, they do so much surgery. And we'll be back with you in a minute. Hi, Ralph.
Yes.
Ralph. Hi.
Hi. Yes, nice to hear you again. So I started my last case for today. I have a 31-year-old lady. She's a refugee and she has a hearing aid on the left side and a long time deafness on the right side. Promotorial testing was positive. The facial nerve is visible in the MRI scan. There was no acousticus neuronoma. The mastate is a little bit narrow, but well pneumatized so far. And we want to go for Oticon implant. We first called out that we want to go for a change of implant due to facial stimulation, changing to an Oticon implant, but we are sorry. So we have an Oticon patient, but not a change due to facial stimulation, because the Oticon system is especially interesting in patients who undergo problems due to facial nerve stimulation. Oticon presented before a presentation where they just talked about that because they have this special kind of stimulation mechanism which allow to stimulate the inner ear with a very low energy. Yeah. So in that case, we already started the same way we always are doing that. Patient is lying on her back, facing towards my scrub nurse, Bartosz. And then we just started with a mastectomy. There's something special about the Oticon implant. Perhaps can I get the dummy? Sag mal den Dummy für mich. Den hier. So as you can see, it's the Oticon implant is has a very small footprint and has the possibilities to screw this implant. So in Hanover, that's the reason why we always have a conflict between drilling an implant bed or just screwing it to the head. Because the most important thing is really to be sure that your implant is not moving around while your patient is moving. And therefore, I will do a little bit of a mixture. I will later on drill and tunnel into the nested cavity, make a little bit of a narrowing of the bone, but then I will use the fixture. One other important thing is about the Oticon implant. Kann ich ja mal die silberne Schablone haben? Due to this very small footprint, you have to keep in mind not to be too close to the pinner. So this is a dummy for the external
the
part.
BTE, the behind
Yeah,
the
thanks.
ear.
BTE.
Yes.
Yeah, BTE. Perfect. Thank you for the word. And there you have to stay away around 1 centimeter with your implant. So therefore, if you're just using to screw, you can nicely perform periostal pocket, put it into the pocket and screw it to the bone. Otherwise, if I want to go for drilling a whole implant bed, I have to go for a more S-shaped opening of the skin to be able to drill the bone for the implant bed. But so far right now, I can show you what I did. Hast du einmal ein bisschen Spülung für mich?
Okay,
Just
John,
let
there was
me,
a question. Can you say something about it? We were following you, Ralph. Rolf.
Yo. So.
Show the question again, Wilco.
You mentioned it.
Oh
so
yes,
you better
just to
respond.
talk. Is it Saturday, Sunday, Wilco?
No,
or is
it's
it
Friday.
Saturday?
It's Friday, Saturday. It starts very early, officially, but not all sites have tested. So you see what happens if sites don't test.
Bohrer habe ich denn?
Well, James Murphy's just asking about Lioness. Sorry about this, Rolf. Lioness is our sister organisation, and that's Lion Endoscopic Sinus Surgery, and they'll be having a transmission on Friday and Saturday, which was highly successful last year. So hopefully it will be again. So if you Google it or look at the site, hopefully you'll see information about it. Where should they go to, Wilco, for information?
Gress, I think, has her own site as well. It's called, I think, Global Sinus Surgery or something. And otherwise, the live broadcast will probably also be broadcast on YouTube or maybe even Facebook. You need to search it. It should be easy to find. I may be able to put a link on the website as well.
So over here, I have the facial nerve. It's just in the bone. Chorda tympani over there. And starting with the posterior tympanotomy. I can just follow the cells over here.
This looks nice, Ralph. I think we need to include our Austrian
Of course.
surgeons as well. We'll be back with you. And
Oh, I'm also from Austria.
Oh, then we won't come back to you anymore. Okay, thank you. Bye bye.
Yeah, thank you.
Have a good evening.
Bye bye.
Bye. Okay, George, we're back with you.
So now it's getting closer to the big step section. Well, it was really a tricky one, but with chronic years, that's how it is sometimes. Größer bitte. And I'm just removing the blood, and then I'm placing my implant. I harvested in the meantime the cartilage. So, irrigation. Yeah, I'm irrigating a bit. So as you can see here, I created here a groove for the conductor link. Patient, etwas von mir wegdrehen, bitte, und etwas höher. I just need to reposition the patient a little bit better. Yes. Okay. So it's okay. Stop. So, Implantat bitte. Okay. So now I'm taking the implant. The implant bed is prepared already. I will fix the implant later on with 2 screws. But what I like to do first now, spitz bitte, is to check the situation with okay. Check the situation with the FMT if it's really fits. Okay. So it's bitte Gnade. Sauger bitte. And I like to have the situation that the silver ring is blocked somehow under the rim of the promontory. I did in my short life a couple of round window vibroplasties, and many things can happen, but so far I never lost the round window due to coupling problems. And you can see it fits very nicely into the niche. The cable will be placed later on. The only thing what I want to see right now is the silver ring is
George, there is there's a titanium holder by Kurtz for the round window. I do not see
there is.
That you apply it.
But honestly,
could you comment on that too?
Well, honestly, I don't like to have too much material between the round window, the titanium holder.
Yeah.
I would like to work with the Coletti technique, which was 45, yeah. And I just need to know right now if the round window is really.
This is the original technique you are performing, huh? This is the way it has been designed by Coletti.
Well,
from Verona.
I know, so Coletti. No, I need to enlarge it a little bit more.
Yeah.
It's still flipping up. Honestly, Coletti teach me his technique with the tutor patch, which I like to use most.
The surgery, we can't remove it for a few minutes. So if you could just raise the image a little bit with your microscope.
Of course.
Just move
Just
your
a moment.
only a little bit. That's a bit more,
Better?
That's fine. That's fine. Yeah, that's fine.
Okay. Yes, you see now it has a better position, but I'm still not completely happy. No. Pass auf, gib mir mal den. Still have to drill a little bit more. Spitz, spitz nochmal.
Of je de bel.
Und halt bitte mal das Ohr ein bisschen weg.
Zo uitkomt. Ja, doe maar.
Ja, ist besser. Nochmal 45 Grad.
Je moet ook reclame draaien, anders krijg je dat gezegd.
En dat beeld omhoog gebracht. Zo kun je het ook oplossen.
Ja, maar ja, het is gewoon
Hij heeft last dat het een beetje nou.
Like this. Now this is the nice position I like to have. You see that the silver ring is blocked motor lip.
Even zonder koptelefoon.
And at the end, I will block the situation here also. What I'm doing right now, and finally, then I will do also. Give me my Tellermesser. No, no. So now I want to place here the. Gib mir nochmal Spitz, Spitz oder Uhrmacher. Pass auf, ich brauche ein bisschen Knochenmehl. Ein bisschen fixieren kann. Ein wenig. Tellermesser. Ah, das ist zu viel. Tellermesser bitte. Kleines Tellermesser. Kleineres Tellermesser. I just take some bone dust in order to give my cable a little bit more stability. Sauger ist zu. This is the last situation. Yes. So okay. Sauger ist zu. I hope you can see that the attachment is quite nice here and very clear to the round window in the perpendicular plane. So this was how Coletti was describing it. And what I do as the last step, I place between the FMT on the one hand and the round window on the other hand some artificial fascia, tuto patch, and I will block here behind the FMT the situation with cartilage, and then layer by layer I will close the situation here in the hypotympanum. And beforehand I will just lock here my cable a little bit more with bone dust, but in terms of attachment here I have a pretty nice situation, which was not so easy in this case. Gib mir jetzt mal ein größeres Raspa und bone dust. So it was quite a tricky thing here. Und in die andere Spitz. Also ohne Haarpinzett. So. Ein bisschen mehr. And as you can see here, I don't have left so much of the cable. I even cannot use this created well. I will place it here like this. Bone dust. And this would work well. Yeah. Okay. Noch mehr? So, und jetzt brauche ich gleich mal Tutor Patch. Noch ein bisschen? Noch ein bisschen. Und ein Sauger, der funktioniert. So. Suction. Okay, so gib mir nochmal die cartilage. Warte mal, gleich. I will prepare a little bit of the cartilage in order to block the situation behind. Mal Licht hier bitte.
Okay, that's clear. I want to go a little bit to Hanover, but we're keeping an eye on you and we'll be back with you shortly. Hanover, hello. Rolf.
Mein Spiel ist viel zu groß. Now did my posterior tympanotomy, and it's also a quite narrow situation now here. Kann ich mal den Osteo-Step haben? So I decided to choose the whole of another drill.
The Osteo-Step, eh? I hear you Osteo-Step BNR.
Yes. Yeah. And so my window is just coming down here.
And what size burr are you using now?
1.2 millimeters.
Okay.
kan je CT zien, hè? Dat je dit hier
Dat is mooi.
hebt.
Wenn wir uns mal Hydron geben lassen.
Just to annoy John.
Dann hätte ich gerne bitte mal das Schippchen groß.
Ralph, we have to do some thank you to the companies that are helping us.
Of course.
We can see what you're doing, but we're not leaving you. But I need to do
No problem.
some additional things. And John, I hope you're still awake. We'll talk in a minute.
Los pasos más sencillos que tiene el modelo actual con respecto al anterior es, número uno, que es menos profundo, entra menos dentro de la cavidad craneal, con lo cual hay que fresar menos. Y en segundo lugar, que es algo por lo que llevo luchando desde hace 7 años, que tiene tornillos autorroscantes y autoperforantes. Tornillos que se ponen en segundos, en 10-15 segundos está puesto cada tornillo.
So we did now the first surgery, and the first surgery time was about 15 minutes from the incision to the skin to the closure to the skin. And this reflects, I think, the easiness of the surgery itself and also the safety of the surgery. So you don't have to deal with dura, you don't have to deal with sigmoid sinus. To my knowledge, this implant at the moment is the best implant on the world.
Right after surgery now, the first impressions are great. It's fantastic to see how the company uses the hints and the feedback of the surgeons to improve the implant. And so this is like a symbiotic activity between the developer and the ENT surgeon, and that's fantastic.
Wir werden sicherlich mehrere Patienten damit versorgen können, weil es einfach einfacher ist zu implantieren, weil es mehr Patienten gibt, die in diese Richtung gehen, die für dieses Implantat in Frage kommen. Und deswegen sind wir jetzt auch sehr glücklich, auch im Sinne von unseren Patienten, dass wir da einfach ein größeres Angebot haben, beziehungsweise eine größere Indikationsbreite.
I just finished the first implantation of the new Bone Bridge 602, and I'm really excited. All the work we put in the new design altogether makes a great benefit and a great step ahead for that implant. And I'm looking really forward to tomorrow, 3 more implantations, and I'm really happy and really excited about it.
See. See. Saga.
Okay, we are back with you now. George, you're screwing down.
Just a moment, yes, I'm just down the image. And I show you the situation at the round window, which is maybe more interesting. So this is fixed right now.
All interesting.
We have the other screw. This is also placed already. A little bit more drill, okay. So coming back to the round window situation, I blocked already right now the FMT with the cartilage to release a certain pre-stress. This was also the Coletti, and we played around also with the E-caps. Sauger bitte, jetzt ein Feinen. And I show you where I placed the cartilage. And already I placed some super patch between the FMT and the round window. And here already I placed some cartilage to have a pre-stress of the FMT in the round window niche. And with that we have very nice audiological results. And this was also the way Coletti described it. In this case it was really quite tricky because the round window niche is very, very narrow. And now the situation here is very stable. With tutor patch bitte, and it's closed now layer by layer. Tutor patch first on the niche. And here I will place also a piece of cartilage in order to have more stability. Noch ein Stück.
So if anybody has questions, either on Facebook, YouTube, or via the website, they can ask the question directly and we will transfer them to the surgeons. Thank you.
So honestly spoken, I did now in my life around 60, 70 round window vibroplasties. This was one of the trickiest due to the fact that the anatomy in the round window was not really nice. And also I had to fight with the cholesteatoma beforehand. But as I told you beforehand, there was no cholesteatoma here in the hypotympanon. One more. Ja. Dann gehen wir nochmal ein Stück Knorpel. Mittleres bitte. Ah, das ist fast zu groß. Etwas. Ein bisschen kleiner. Ja, das ist besser. So, jetzt habe ich dann noch ein dünnes. Patient von mir wegdrehen, bitte. I have really here a stable situation, but I don't have the FMT will flop out. Never lost FMT here. Okay. Etwas größeren Sauger und jetzt bitte nochmal ein größeres Stück Knorpel. Noch etwas weiter weg, die Patienten von mir, bitte. Noch weiter. Noch weiter. Danke, stopp. So, and Sauger. Sauger, bitte. And here you see now the situation of the remnants of the round window. Der Sauger ist zu. Knorpel bitte. Etwas größer bitte. Knorpel. Mhm. Ja, das hier das runter. Mhm. Ja, noch mehr. And with the cartilage, I have really a sufficient closure here of the situation. I don't have to be afraid that anything will go wrong with the. Oh, pass auf, gib mir noch ein kleineres Stück. Nee, ist zu groß. Das hier. Bitte Patch jetzt für das große Stück. Jetzt pass auf, das schneide ich mir zu. I take now a bigger piece of tuto patch and Schere. It's okay. And we'll place it. Feucht machen.
Okay.
Place it here. Nadel bitte. Nadel. Noch eine weitere Nadel bitte, oder Sauger.
Yours. I want to thank you for
And then I have a chance to
for the fantastic presentation.
control the whole thing. Yes, please. Any questions?
No, I don't see any questions coming through. I think it was a very good presentation. Very calm, very quiet, even though it was a very difficult case. Thank you very much. Impressive.
You're welcome.
We'd like to thank you and thank you for your participation. And I'm happy that we were able to make the connection after all. I'm also sorry that you couldn't show everything.
Yes.
But it went
It's a
well.
pity that the first one failed so badly, but
Yes.
maybe we have more like next time.
Yes.
Okay, give me noch ein bisschen cartilage.
This project is bound to continue. Thank you very much. We need to go
Okay.
to
Thank you very much.
Ralph Prenzel.
Thanks, George. Thanks
Say
for all
thank
your
you to,
efforts. That's much appreciated.
My pleasure.
Say thanks
Thank you.
to
Thank you.
Medel
Stefan, yeah.
and for all the,
Also,
all
ich
the
brauche noch ein
help that they
bisschen
gave.
cartilage.
Okay, bye bye.
And to Stefan, yeah.
Ralph, we're back with you. Hello, Ralph.
Oh, are you with us? Okay.
Yes, of course.
Then we can show the implant. Gib mir den Spritzschutz wieder abnehmen. Ah, danke. Was damit rauskommen?
So the last thing you said before we left was that you are an Austrian.
Okay. So let's implant body with these two possibilities to fixture the implant body with screws.
Mhm.
And the electrode is here. I will show you in some minutes under the microscope, and you can see it even more nice than you can see it now. So. Okay, also müssen wir einmal messen, ne? We just do a short pre-testing on the operating table. Genau. Da müssten so 2 Schrauben sein, die brauchen wir dann gleich nochmal eine Schraubenzieher, genau. Habt ihr einmal die Spule? BTI. Okay, we can go for it. Das ist runter zu schieben. Man muss das schieben, in eine Richtung kannst du das schieben. Wunderbar. So the testing was okay. So we can use the implant. Darf ich mal den Sauger haben zum Saugspülhaken? Dann bitte einmal die Ätzen bauen. Dann bitte einmal den Schraubenzieher. Die erste, hast du das auch bekommen? Ah ja, perfekt.
So, John, you've been awfully quiet.
Well, by common request, I mean, yes, this is a lovely demonstration. I think the picture from Hanover this year has been excellent.
Oh. No, it's okay.
Like this.
First time it was loose. Second time it's okay.
I quite like this. I quite like this fixing as well, Rolf. It looks very nice.
No, it's still loose.
Rolf, do you have already for some longer time experience with the clinical outcome of this implant? Rolf, did you hear me? We have a question about the experience, the clinical experience you have after implantation of this Oticon cochlear implant. Could you tell us
Now
something?
the screw is tightened. I hope it.
Rolf, can you hear us?
Rolf, can you hear me?
Yeah.
Rolf,
Second screw.
can you hear us?
I can hear you, John.
Afraid. Yeah, I know you can work over.
John?
Yes,
You were
I've
talking
asked
about-
him. He
you
can't
were
hear
talking
me.
about screw, yeah.
Yeah, I just thought it was a nice, the way they've put a nice little metal former inside to make sure that the screw doesn't extrude from the silicone.
That's fine. With the
Rolf,
time.
Rolf, can you hear us? Rolf?
Nee, but
Yeah.
So, da ist eine Hülle.
Whatever.
Kann ich ja mal ganz kurz die anatomische Facette haben. Just check, but yeah. So there's just a protection shield for the electrode.
That's smart.
I don't know whether you want to make any comments, Emma. This looks
Da
your
haben wir
sort of
14.
procedure. It looks very elegant.
It does. It
Now I
looks
can
lovely.
introduce the electrode into the mastoid.
I don't yet have experience of the Oticon implant, but it does look really elegant, as you say.
The angulation is a little bit off, maybe.
Quite nice to
Okay.
use the tubing like that with a sort of Seldinger
Oh.
type technique to pass through the bone, prevent damage.
You should
Okay, yeah.
respect the old
So we
videos
just switch to our microscope. Dann kannst du einmal hier den geben. Kann er wieder raus, der 14.
That's niet specific for the.
Let's try once more. Rolf, can you hear us?
I will give him the
Oh, no,
technician a
that's fine.
call.
Okay.
They're probably out for Bratwurst.
I don't know whether we've got, have we got a final case from Joachim Muller or we finished with
No,
Munchen?
no. I think.
Okay, they cancelled it.
Yeah, they.
Yeah.
Well,
I
John,
think this is
So now you can see the
we need to-
electrode.
John, we need to consider that this is quite an impressive show of patience, even though we didn't have. I mean, with COVID and all. Okay.
Wie viel Kontakt habt ihr noch?
We can hear you now. Can you
Kontaktanzahl?
please explain what you're
20 contacts.
Okay.
They're just round contacts. So, and I really had to do some bone work to find the round window. 1-0 erstmal.
Hi. We tried to talk to Ralph Sachs, yeah, but he doesn't hear us. Or at least he doesn't respond. Maybe he does not want to hear us. Hello? Yes, please, because we talked to him. I mean, it's okay. Okay, let me know then.
Kann ich meine lila Kanüle haben? And can already, I don't know if you can see it, so I really guess I will get a gusher in this case because the basal membrane is already pulsating.
Some oozing. There's no
We will see.
I quite like this, although I don't do cochlear implants, this Hanover technique of stabilizing the electrode with the slot.
Darf ich mal ein
That's in the
Arbeitshäppchen
tympanotomy is a nice idea.
04 haben?
Emma, is this something you've tried?
It's not something I've tried before, but I think it's something I probably will try. I think extrusion is quite rare, but it's slightly commoner with the slim straight implants. So this just seems like a great idea. I'm definitely going to give it a try.
Well, you should give it a try, Emma, because I mean, I think it's very comparable
die
to
das Schippchen
British
haben.
and German engineering.
Schippchen
What car
groß.
would you buy?
I'm a fan of German engineering. I drive a German car.
I drive both, but you know, as they say, you want to go in the outback, take a Range Rover. You want to get home again, make sure your mate's got a Toyota.
I'm pretty sure it's common knowledge that no one needs anything better than a 3 Series 320B. Apparently, the best car you can get.
Depends who drives it, Emma. I don't want to burst your bubble. Okay, Ralph, I understand that you turned down the speaker because you couldn't stand it anymore, but we were trying to talk to you.
Okay.
Well, if it would have been a gusher, it would have filled your operating field fully. But the CSF is not even oozing.
It's really only gentle, yeah.
Yeah.
Kann ich mal eine Testelektrode haben? I will start with a test electrode and see what is happening.
Yeah.
We had earlier on a question which you didn't receive about the clinical outcome of this new implant you are applying. whether you could tell us
So
something.
far right now we are, we can get a microphone to our engineer and then he can tell us a little bit about our patient's success. Willst du noch kurz ein bisschen erzählen über die Ergebnisse, die wir haben? Von euch mit Oticon?
Yeah, it's not urgent at
Über
this point.
Oticon, eure Ergebnisse.
Ralph, it's not
Well,
urgent.
alternatively, you could
It's
just relay. You
It's
could
not a
just relay
problem.
because your voice is coming
Einfach-
through very
einfach nur ein
well.
bisschen was erzählen, wie die Ergebnisse sind mit dem Implantat, mit Oticon.
Wie geht das?
So my engineer is now a microphone. Darf ich nochmal das Schippchen groß haben?
Well, the sound was not that clear, so I don't think he's from Oticon. So Emma, for you is a 320
Gib
is
mir erst-
good. Yeah. Now continue, Ralph. Sorry.
Oh no, I'm fine.
No, me too.
Darf ich mal eine Stiff Probe Vorwerk haben? So I will use a stiff probe first. The fabric tissue probe. No. It's a product by Med-El company, but we really like it if you have an unclear case about tissue inside. Ach, eine Pinzette bitte. About tissue inside the cochlear. I show it you in a minute. So it's just a stiff probe, and you can insert it into the inner ear just to see if everything is going fine or not.
Is that a depth gauge? Is it a Med-El depth gauge?
Yeah, a little bit like that, but especially for if you're unsure if you can insert an electrode.
A little dummy. It's a little dummy to practice with.
Yeah, but as you can see, it's not really easy to
No, it
insert
doesn't
the
go in.
electrode.
And I wouldn't call it
No.
practice with. It's just to precede the expensive electrodes, Emma. It's not a practice electrode.
Yeah, darf ich wieder meine 1,5er haben? Bohrer.
No, let's practice on this ear. Yeah.
Die Spülung bitte auf R5
Don't
gepulst.
worry, Emma. It's just got through to that time of day, Emma. Don't worry.
It's okay. I'm not taking it personally.
At least he has a German car, John.
Yeah, yeah. Well, I have two German cars. Well,
So, Emma, I would like to ask you to make the summary of the day for our general address at the end.
Yeah, no problem. I've made a list of the things I've seen, actually. It's a fantastic list.
Oh, really? I was very good. So then we can go through. So, Rolf, what are you doing? Are you making the round window opening bigger or
Larger, yeah.
the same thing
Have
as
to enlarge.
Niels, the same thing as Niels' case? With Niels's case, there was also some difficulty
Yeah.
advancing the electrodes and not having a practice electrode.
Darf ich noch bitte das Schippchen groß haben? Nochmal den Bohrer, bitte. Mhm.
Maar jij vergelijkt het ook met jezelf, wat je presteert. Dus daar ligt je standaard.
Ja, denk het.
Ik al onderuit.
So John, I think because I can make it, maybe for next time we need a talk back loop so we can discuss among each other without transmitting it. Would that be practical?
Yeah, I think that would be great because it must be very off-putting for the surgeons to have us bantering in the background.
Well, if they know the word
Kann ich wieder
bantering.
mal eine leicht geschwungene Nadel haben?
Yes. It's a very in term in the UK, Wilco.
Bantering or battering?
Banter. We even have a TV channel called the Home of Witty Banter.
Well, if you're not careful, I will batter you the next time I see you. Laddie.
But you know, I think we've seen some great surgery today.
Yeah.
The images are fantastic.
You know, I've had that happen before, indeed, with someone post-infection meningitis, and have quite a bit of an issue to get the
Darf ich
electrode.
nochmal Stückchen groß haben?
But don't you think it's so much better to have live surgery like this with the real problems rather than the edited highlights of Robert Vonsot, John Oates, Chris Aldrin, and everybody else? You know, you really see what's possible.
Well, John, the difference is from Robert, we know he can do it.
Yes.
And
well, he makes a video of every case.
What other name?
Well, I think Grolman was the second one.
Well, that's the rotten humor of the Brits. No,
but you know, this is a very productive thing to see. Is, as Emma was saying early on, the decision-making process is all important.
Yeah, it is. No, I think all the cases that we've seen have an excellence and a cool overview. I mean, I remember the first live surgery that was quite a pressure on the shoulder as well. And now I think if you see, I've not seen any decision making that seemed to be under pressure or so. And with deep respect for the surgeons that did the local surgeries, I think that's of course for the patient as well. But it's just another factor of uncertainty at times. No, very good. And the same thing with this. I mean, you need to, with stamina, continue with your goal and not be put off or feel the pressure to do anything. So I think that is actually very good.
Ik begrijp niet wat er nu gebeurt, want ik dacht dat die.
Well, I don't want to spoil Emma's summary, but 3 times we've seen difficult situations where the surgeon has said, right, I'm going to do something completely different to solve this problem.
Well, you know,
myself and for this patient.
I would never criticize.
Okay, dann hätte ich gerne bitte einmal
because I used his doctor's code when I was in Hannover.
bitte einmal den
No.
3-0er Diamant.
I think it's very good.
So now we'll open up the bridge to get a wider access to the middle ear.
Okay.
Glatt.
Yeah. Well, take your time, Ralph.
Yes, of course. That's a normal. That's usually a Friday afternoon case.
Well.
Ich will bitte wieder kurz auf 10 hochstellen.
We could listen to Emma's summary and then come back to Rolf in 5 or 10 minutes.
Yeah, take your time.
I expect a 20-minute summary. Let's have a look at that. Okay, Ralph, I can't.
Yeah, see you later.
I cannot mute the sound towards you, but we'll be back with you in 5 minutes, or maybe 20. I don't know. Let's see.
Yeah.
Okay. So, well, here from the studio, to tell you honestly, it has been interesting, wonderful, tiring by the quantity of information that we had. And Cor, what is your general impression? Of course, we talked about it a little bit.
We talked a bit. We have seen many cases. We have seen many different implants, but besides, outside that, we have seen some general otologic issues like the dehiscence of the middle fossa from New York, and the way you handle it, and that you don't need a neurosurgeon to support you, or that you need a neurosurgical middle fossa approach. It is good to know and to have seen such type of surgery, and that even the risk of that type of surgery is less. You could see even that in case you would have a bleeding intracranially, that would drop out in the mastoid, and that for that reason, the otologic route for that surgery is even safer. So there were many issues. I just pick out this one. It was nice to see a middle and vibrant sound bridge through the round window again, and a bit in the classic way, but also with some coverage by cartilage, and to see it covered against protrusion.
Yeah.
It were small tricks which you were not aware to you presume to see this morning already. It just occurred during the day.
Yeah.
Since it is live surgery, and that was emphasized by John, that live surgery is an exposure you need to get more out of it and more tricks out of it. And over years, the technical performances of communication and of visualization of the surgery, and the group of surgeons which get well known to each other, and so they perform better and feel more comfortable. That's what I can see. And so yesterday it was an excellent day for more classic middle ear surgery performed by some of the best we have in Europe. But today it was the new area of implants, which is continuing to developing itself and to improve. So we have now even 4 cochlear implants, and we have different bone bridges or bone
conducting
devices, which are semi-implantable, etc. And the active one are newer than the passive one, and so the comparable outcomes, whether they are comparable or not, that are really nowadays issues to revalidate our patients which you couldn't revalidate in the past. And so all this stuff is coming along. So this really education which is presented, and for me, being out of my clinical university office for now 10 years, there are festivities to attend such events, and to have to be exposed to this type of surgery and education.
Yeah.
So thank you for that.
I fully agree with that, Cor. I think it's. I think the thing, and that's what John and Emma highlighted before. Live surgery has something honest to it, and what makes it honest is that there's no hiding, and that's why not everybody can do it, because some people will not like that very much. But it is an honest way of seeing how to deal things. And like Arno Dietz from Finland also said, well, I picked that up some years ago, because this is the 16th broadcast that we do. And he said, well, I remember I picked it up so and so. And well, anyway, good. So Emma, your voice is heavenly, even though it doesn't come through with all surgical blocks, because, well, I think it's still excuse, because they're adapted to John's Midwest, or what is it? the beer country language, and then we have Emma, who is talking posh British. Emma, can you please tell us what your experience was today, and what were the highlights for you, please? That would be very nice. Thank you.
Yeah, thank you so much, Wilco. I mean, I'd really like to say thank you so much to all of the surgeons and the sponsors, but especially to the patients. Especially, there were some of the patients having their surgery under local anaesthesia, broadcast to the world, and I think that's a real treat for us. So some of the highlights for me are some of the things that we've already touched on. So the first one is obviously the skills of the surgeons that we've seen today. And there were some questions I asked, and I think the surgeons underestimated their own skills. And I'm junior enough to remember learning those skills, but I think these really talented guys, they've perhaps forgotten how good they are. And I hope everyone in the audience, everyone watching on the different channels, really appreciates how skilled these guys are, and that with practice, you know, your skills can become so fine and so beautiful. It's just a joy to watch. And the second real highlight for me, I think, is as Wilco has mentioned, looking at real life surgery and people coming across challenges and using decision making before our eyes and staying cool and using the tools that are in their box. It's just what surgery is all about, really, and it's something that you don't necessarily hear about when you're being taught or when you're watching a highly edited video. And I've made a note of the cases we've seen today because all of them have brought up a really rich kind of discussion. So we had a pediatric cochlear implant from Antonio in Napoli in Italy, and he used a combined approach for that because he couldn't access the part of the promontory that he wanted to access. And we talked through the different challenges that you might come across with access, and it was beautiful. It was lovely, and the images on the screen were really good. We've had some real treats from Hanover as well. Cochlear implant under local with a cochlear microphonics and a cone beam CT post-operatively. And then, of course, the dexamethasone eluting implant, which it was really nice to hear about. And I really look forward to hearing the results of that.
You need to insert that dry.
Yeah, do not get it wet. What else have we seen? We've seen the case from Béziers, the combined approach tympanoplasty with cholesteatoma. And that was lovely to see, because I guess that's the sort of case that we'll all come across as otologists, whether we are implant surgeons or not, and then a lovely articuloplasty to go with it, and a discussion of the way we use our articuloplasty tools and our cartilage graft. I really love the cases from Finland with the local anaesthetic and talking about the different processes and the different decision-making that's involved. Not just the surgical plans, but also communicating with the patient and preparing the patient preoperatively. It's all really, really important stuff. The Raumund vibroplasty we've just seen was lovely. We're still, I think, watching the Oticon cochlear implant. And of course, Tom Rowland's meningoencephalocele, which I really enjoyed. So overall, I think it's been absolutely a real honour to be involved. And I think what's really interesting is that you guys have been doing this for 16 years, but you're still way ahead of the game. So thank you so much for including me in it.
What was the word that you chose?
We're back with you, Rolf.
Yeah, no, yeah, only, but is it the toy dilator or something? What did Emma call it?
No, this is Emma calls it the practice, but it's I think it's a seeker would be the best word.
Yeah, in England, yeah. No, so that's
right now. So you can see I just drilled away the bridge.
Yes.
So I have a much more base to manipulate in the middle ear. And I removed the ambus, so it's now away. And then I drilled down the basal turn, and I finally found it just here. So at the very end of the basal turn, I was able to find the lumen and insert now this stiff probe. And now we can try to go for the real implant. I hope so. Das bitte mal abnehmen. Ich nehme mal die Oticon-Pinzette.
Well, I have once again have to say that the image, the quality of the image is exceptional.
Fantastic.
Very, very nice.
Fantastic.
Yeah.
Bitte einmal den Sauger. Bitte nochmal eine anatomische Pinzette. So, I think next to 2/3 of the electrode are already in.
Okay. Da kann man gut sehen, das Salja, ne?
It's very nice.
Geht das ja, oder ist so okay?
That's
Very good.
Bitte mal eine leicht geschwungene Nadel.
There's a little bit of pressure still in it, huh? What?
Well, I think the dulcet tones of Thomas Lenhart standing behind you probably don't help.
Oh, no, I'm sitting outside, you see.
All right, okay.
Yeah. So finally I could insert the electrode now.
Boys.
Okay.
The image is good, Thomas. It's very nice
Bitte
quality.
2 anatomische Pinzetten.
Yeah, I think so. Let's see. That is the advanced version of the ARI, which probably has a bit more light than the other one.
The Munich medical imaging, what's the company called?
Yes, they call it like this now. Yeah.
Well, of course, it's a fantastic device, but it'll be like the Apple Mac. It'll be upgraded every year, won't it?
Only if you break the glass, John. No, but what's exceptional is the dynamic range of the picture is very nice. It's sharp, but
that's true.
It's not really working that way. I want it placed in the method now, but I will just see.
It's always a cable problem, no?
So, okay.
Yeah.
Dann nehmen wir einmal den Button. So now we try to measure and to see what we will find out.
So Thomas, will you be able to come into the camera so you can have some final words as treasury of the foundation?
Mit dem Klee müssen wir erstmal warten, bis wir sicher.
There you go.
So no, what should I do?
Well, the thing.
Well, I think we should
just checking
should meet afterwards.
If we are having,
but that's something else. But I think we owe Hanover a big thanks for the amount of surgery and the amount of quality that we've seen. And it's always at the forefront of medical technology, at least in our field. So I really have to thank you for that, because it's really true, Thomas. It's always something the first in Europe or the first in the world, which is very nice. And the inspiring thing, at least for me, but I think Cor and I talked about it as well. The inspiring thing is that it's the whole team that is motivated, and we sometimes hear your voice on the back. No, make it bigger. But you have a whole team that's doing it. Yes, and I think it's very good. And what I appreciate, and I must say that Niels Prince was working, and at one point you took it over, and I think that's the way it should be. Also for life surgery, it doesn't matter. The boss should be there ready to help when it's better for the patient, and that's what happens. So I think it's a multi-dimensional, a very good educational platform. I think we've discussed that, but I think Hanover, of course Munich as well, but Hanover especially, have shown us very nice innovations as always. So I want to personally thank you, and I know Cor wants to thank you as well. The same. Yeah. And
well, thank you much for this nice words, and of course I only can give it to the team and everybody who really tried to make it happen, and also to make it good. Yesterday I was a bit dissatisfied with the first case, but that was more on our side. The point is, of course, always life surgery is different to your normal surgery. We know it, and it's also definitely different to some videos you have created beforehand and just show them. Because excitement is much different, and also you never know what is coming in the case. So we had today's, I think, 3 ones which were not that normal.
No, that's
and
right.
I think, but it is important thing that we also show how to deal with these, let's say, non-normal cases or difficulties, how to overcome them, and also that we also show them that we are open. Also to comments, criticism, whatever, and also to look how others do it. I think that's always the nice thing about Lion. It's not only that beginners or young people learn, but also we as advanced surgeons learn from each other. And I think that is something we probably can do more in the future with this kind of more modern systems, some microscopes, but also the vMix on which would allow us to at least do a surgery of the week or whatever,
Yes.
and transmit it on a. I think this is, we should pursue this. The other point what I want to mention is was very good that you had some young people, residents or fellows invited to comment, and I think that's something we really should keep and do in the also in the. You see the Serpides reflex at Rolf's demonstration, yeah. Okay, so I think that is very valuable because the questions they ask are important, and we should answer them. And I think this involvement I would play for having it also in the future.
I agree with you, Thomas.
Can we,
sorry, John.
Can we see those reflexes quickly, and then I'll. Since we're all mutual backslapping, I'll give you a thank you, Wilco. Can we see the reflexes, Thomas?
No,
or Wilco?
But hold on, I think it's already passed. But Thomas, what I would like to address, maybe we should consider something. Maybe do a global 3D transmission, because I think if we prepare it, it's not that difficult. I've done it before, and I think if we with the right support, I think. The 3D image, if we were able to do that, that is yet another dimension. And now with the quality that we get from you, but also from Munich, it should be doable fairly easily, actually.
I think so. Yeah, the quality is now so that you really would benefit from 3D. I think if you can do that technically, we should go for that. I mean, it's a real a third dimension, as you said.
Yes.
Yeah. So I'm personally grateful to you all, but I think there's one person who we haven't really mentioned here, and that's Wilco, has been traveling backwards and forwards from France to Utrecht for the last few weeks, which is a big ask. You know, he looks like a porcupine. He's had so many needles stuck in him to make sure he hasn't got COVID. And he's got an indwelling arterial monitor that I've got Bluetoothed. And he's been crawling around on the ground for the last 4 days because there are so many codecs and so much wiring involved in doing what looks like a simple transmission, but actually involves many, many tens of hours of effort. So Wilco, we really do appreciate the strain you've put yourself through. It hasn't gone unnoticed.
Thanks, Tom.
And I'm extremely grateful.
Yeah, well, thanks. Yes,
maybe.
maybe.
No, I mean, that's a great achievement through your willingness to do it. And I think without you, we would not be able to do it like this. No?
Yes, maybe. Well, anyway, let's talk about this offline.
Now, we can mention that the inclusivity in this organization is increasing. So this time we had Emma and Nina, but we had also Kirsten Willenborg as an ear surgeon. And we had in the past, a few years ago, a female colleague from Sweden, which performed a perfect
Stromberg
stapedotomy.
Yeah, Karen, she was fantastic.
Yeah. And so we don't need to fear for that, just to welcome them and enjoy it.
Well, it's the articulation.
Well, I think we'd certainly, as a faculty, make an appeal to female colleagues who want to be surgeons to contact us.
Yes, contact you, John.
More than welcome.
Yes, you're right. Well, anyway, Thomas, I will schedule a Zoom meeting for the hardcore founding members. Like you requested, we have some things that we should discuss, I think, probably. There are some remarks which I will show you online. This is from Abu Abbas, who is very happy that we did this, and this is for okay, let me check. Yeah. So this is the new dimension as well, that we get directly the remarks from people on the web, and we can integrate it in the transmission. I think that's good as well. Thank you very much. It's been worthwhile but a tiring project, and I will schedule a new meeting between us, and we need to think about what we want to do in the future. Thank you, Cor, for coming, because Cor is the only one physically present, even though John and Emma seem to be, but they're not. And Thomas, thank you for, again, all the fantastic work that you've done and the whole input in the project.
Okay, thank you to you.
Well, and thank you particularly.
And also we have to thank thank John. We have to ask John. we have to thank you, John, because you were the British humor who always did drive us forward. And I mean, I heard that you are retired. You can reapply for a Lion. I mean, be one of the youngsters to go in and learn more about implants.
Well, we have to thank our surgeons as well, and our patients. I mean, we lost 7 patients who couldn't take part because of COVID. We almost had one with a needle phobia who got into the anaesthetic room, went out and came back in again. You see none of this during this transmission. But I think we should wind it up now. Everybody's had a great time. A particular thanks to the people who've been present in the Zoom room, because we're conscious that colleagues from all over the world have registered for that. And that's where some of the best questions have come from. So grateful to all. We've all had a great couple of days, and hopefully some of you who are generalists will join Lioness later in the week, which should be equally as exciting.
Friday, Saturday. Okay, thank you. And till next time. Thanks. Bye-bye.
Bye-bye. Au revoir.
Bye.
Auf Wiedersehen.
Oh, well.
Good. Okay, guys, I'm going to knock it off everybody.
Good.
I'll give you a call later on, John. Emma, thanks.
Yeah, great. Thanks very much, Emma. That was really good. And Nina, if she's still watching.
Well, at least we're not broadcasting anymore. Well, maybe still on Zoom.
Thanks, Cor. It's great to see you.
Pleasure.
You look a bit younger than Wilco, actually, I reckon, but don't tell him.
John, enjoy your last Lion while you can.
Yes, I will, yes.
Okay, cheerio. Bye-bye.
Cheerio, bye.
Is nog steeds connectie.